Good morning. At the outset, I would like to congratulate IAP and the NNF Alapura and also Kerala chapter for organizing a wonderful CME. Yesterday, we had seen the workshop and the CME, and today also I think a long list of topics are there. I'm not extending my to start with the in this session we have 3 topics. I request all the 3 speakers confined to 10 minutes each so that you will get 10 minutes for discussion. And also to audience, please type your questions in the chat box so that we can avoid further delay. So first we have eminent speaker Dr. Radhika. He's talking about the management of tuberculosis and HIV in children. Luckily, I think the last few years there is no case report of HIV in newborn, at least in Thrissur. I don't know. I think for last 3 years there is no HIV in children in newborn in Kerala. And also we are seeing that in Kerala also we are also in the process of eliminating tuberculosis. Now we are focusing on latent tuberculosis. So we are lucky to have both these conditions dramatically reduced in Kerala. So to talk about the management, we have Dr. Radhika, head of the Department of the Neonatology from SAT Hospital Trivandrum. And she is a very active member of our MBFHA committee, active faculty. That is why I am associated with Radhika. So now I request Radhika to deliver her talk. Unmute Radhika.
Yes, sir. Can you kindly enable share screen, sir? It is.
Yeah. One second. You.
I'm not able to.
Yeah, please see now.
Yes.
You'll be able to. I done it.
Okay.
You're able to share now, no, Radhika?
Let me just check, sir. Sir, actually, I'm not able to, sir. It's not coming. My screen is not.
No, but it is enabled here. Do you want to?
Yeah.
Yeah.
Okay, sir. Just 1 second.
I think the whiteboard has come. You have to open the presentation and then minimize Zoom. Open your presentation in the desktop and then.
That's what I'm trying to do. So just a second. Can you see, sir?
Yeah, perfect.
Yeah.
Okay, sorry. So I have good morning to all, and thank you for the organizers for giving me this opportunity. And I have been given the Herculean task of discussing 2 long topics in 10 minutes. Let me see how much I can do justice to it. So straight away going to the topic. First, I'll be dealing with the section of babies born to mothers with HIV. And we know that mother-to-child transmission is a major root of HIV in the neonates. And in the absence of any intervention, the rate of transmission of HIV from the mother to child can be as high as 15 to 45%. But luckily, we have a very good ongoing program, and in Kerala, the PPTCT program is going on very well. And as Anthakeshwan sir said, we are hardly seeing any cases of infants with HIV. And in the last 3 years from SAT also, only 1 baby at 6 weeks was found to be positive because of poor compliance in the mother, and unfortunately, we lost that. But overall, the incidence of HIV in infancy from mother to child transmission is coming down to a great extent. So the recommendations are early detection of HIV and initiation of antiretroviral therapy as soon as possible in the first trimester, a triple drug regime in the mother with tenofovir, lamivudine, and efavirenz, and ideally a therapy of more than 24 weeks during pregnancy, and this to be continued during delivery and breastfeeding and lifelong to the mother will cause the HIV transmission to come down to a large extent. During labor and delivery, we have to follow all universal precautions, minimize all invasive procedures, vaginal examinations, artificial rupture of membranes, invasive procedures on the fetus, avoid episiotomies, instrumental deliveries as far as possible, and avoid cord milking. And for the newborn baby during resuscitation, routine suctioning should be avoided. The mode of delivery, it can be as per obstetric indications. There is no indication that one mode is superior to the other. The baby should be initiated on exclusive breastfeeding, but definitely there is a risk of transmission of the virus through breastfeeding. So we have to do intensive counseling to the parents, and we have seen that most of the parents are opting for replacement feeding in spite of counseling them. But when they take up formula feeding or artificial feeding, we have to ensure that it is an affordable option, it is feasible, it is acceptable, they are doing it in a safe way, and it is sustainable for them to continue, because we do not advise mixed feeding where you give both formula and breastfeeding. And breastfeeding should be continued, and you stop it only for 6 weeks till you do a confirmatory test as 18 months. If the baby is found to be HIV positive, you start the baby on ART and you can continue till 2 years. All routine vaccination for an HIV exposed neonate can be given as per the national schedule. Now, coming to the retroviral regime for the baby, now we are starting the baby on nevirapine, and if the mother has had adherence for more than 24 weeks of triple drug therapy, then 6 weeks of nevirapine at 2 milligram per kg should be sufficient. And if the mother has not received 24 weeks, or she has not been compliant, or she has discontinued the treatment, then an extended treatment of nevirapine for the baby till 12 weeks is advised. And earlier we used to give single dose nevirapine and sidovodine. That practice is no longer being done. Now, sidovodine is only prescribed in rare cases where you have HIV-2 infection or the mother has been exposed to nevirapine during pregnancy. Otherwise, it is nevirapine once a day treatment for 6 weeks, daily treatment, which is advised. Every baby who is exposed should be started on the clotrimazole prophylaxis therapy. This starts at 6 weeks and it is continued till 18 months. If the baby is found to be confirmed to be negative, you can stop the prophylaxis at that time. And if the baby is found to be positive of HIV, you continue till 5 years. So clotrimazole prophylaxis at 6 weeks is started. Now coming to the testing of the baby, the first testing is done at 6 weeks and subsequent testing is recommended at 6 months, 12 months and 18 months. So when I was preparing this talk, actually, I went to see what is being happening in our ICTC. Normally, they have a very good system there and they're doing it routinely. So we are not directly involved in what is happening there. So because this topic was given to me, I actually had an opportunity to see what is happening because we are learning the theory, but we are not directly involved in the investigation. So at 6 weeks, the babies are called and after we are doing a dried blood spot card test for this baby for DNA PCR. This test is actually being sent to the center in Chennai, and there is maybe a 3 weeks interval to get the result. If it comes as positive, for confirmation, one more dried blood spot is being sent, and if 2 tests are positive, the baby is started on antiretroviral 3-drug therapy. And whole blood test for confirmation is not done. It is a dried blood filter paper test which is being done. Now, if the baby is negative, we call back at 6 months, and this time we do the rapid antibody testing is done. You get the result in 30 minutes. If the result comes at positive, we still could be because of the maternal antibodies. So you have to confirm by again doing a direct blood spot, which is testing, which is sent to Chennai. And again, the same process is repeated if the baby is negative at 12 months. So 6 weeks, it is a DNA PCR. Then you do at 6 months and 12 months. The final confirmation to label a child as HIV positive is done at 18 months. And here we do not do PCR. It is a rapid 3 antibody test that is being done. And if the baby is breastfeeding, the breastfeeding has to be stopped for 6 weeks prior to doing this confirmatory antibody testing. So this is about the infant diagnosis, and this is how the national guidelines will go. So just in a nutshell of a care of an HIV exposed infant, the nevirapine prophylaxis for 6 weeks, and this is extended to 12 weeks if the mother has not completed 24 weeks of treatment. Cotrimoxazole prophylaxis again from 6 weeks. We do infant diagnosis by PCR at 6 weeks, and then antibody testing at 6 months and 12 months, and confirmation at 18 months. Give the option to the parents. Breastfeeding is what is recommended by WHO, and if they are opting for formula feeding, make sure it is FAS. Immunization can be continued as per the national schedule, and the baby should be kept under close follow-up and growth monitoring to be continued. So this is in a nutshell of the first part. Now coming to the second part is a baby born to a mother with tuberculosis. So I'll be talking about the latest guidelines on latent TB infection that was came out in November 2020 by the government of Kerala. So any baby who is born to the mother who has been diagnosed with any type of TB should receive TB preventive therapy once congenital tuberculosis has been ruled out. So there are, WHO has given different options, and we used to stick to the 6-month INH prophylaxis, which was being done. But now the latent government guidelines, latent TB guidelines by the government of Kerala has advocated even for newborn babies exposed with a mother with tuberculosis to give 3 months of INH and rifampicin. And for latent TB, why have they switched over to 3 months INH rifampicin combination? Is lower risk of adverse effects, better chance for adherence, and there are fixed drug combinations which are easily available and more familiar for use for pediatricians. And so the treatment regime, INH at a dose of 10 milligram per kg and rifampicin at a dose of 15 milligram per kg. You can use the combination drug which is available of rifampicin and INH 75 and 50 milligram tablets are available, and you can give according to the weight of the baby for 3 months. And babies who are exclusively breastfed should receive pyridoxine at a dose of 10 milligram per kg while they are receiving this prophylaxis. Now, in an HIV exposed baby, BCG should be administered. There is no contraindication. And how do you rule out congenital tuberculosis? You need a high index of suspicion, and we do in a mother who has tuberculosis, we do recommend examination of the placenta for histopathology for tuberculosis. And this is the Cantwell criteria: a proven tuberculous disease plus evidence of any one of the following: a tuberculous lesion in the first week, a liver complex, evidence of maternal placental tuberculosis or genital tract tuberculosis, and you have ruled out any postnatal transmission by screening of all the contacts. So many times congenital tuberculosis, if you do not suspect, it may mimic many other diseases, and most common one is sepsis. So the common presentations in a newborn period of tuberculosis, when you don't have a definite history in the mother, may be as respiratory distress or hepatosplenomegaly, or it may be very vague, like just poor feeding, fever, irritability, lethargy. So once you are not finding a cause, you have to definitely think of congenital tuberculosis. Now it is now a routine AFB smear testing of gastric aspirate as per the latest guidelines is not done. We can do a gastric aspirate and send it for a CBNAT testing. And a chest X-ray is mandatory to look for any characteristic tuberculous lesions. And if the baby is found to have a congenital tuberculosis, then you go for the 2 months of 4 drugs followed by 4 months of 2 drugs. Breastfeeding should be encouraged because most of the risk of transmission through breast milk is very low. And the first line drugs are also the mother, even if the mother is on ATT, the risk of transmission of these drugs is very, very less. There is no need for routine separation of the mother and the baby. And as we have seen during the COVID times, the mother should follow all droplet and respiratory precautions like washing hands, using a mask while feeding if she is in the active stage. But breastfeeding should be encouraged and should be continued till 2 years of age. So thank you. I hope I have been able to cover all the points, and I'll be happy to answer any questions in these 2 topics.
Thank you, Dr. Radhika. And now you request Dr. Narayanan to introduce the speaker.
Yeah, good morning to you all. Our next topic is hypoglycemia in the newborn. We all know that the most common metabolic problem in the newborn is hypoglycemia. And we are all worried about hypoglycemia because it is a cause for mental retardation and developmental delay in children. And one more concern is that The fear of neonatal hypoglycemia is a major cause for reduced exclusive breastfeeding, at least in our state. So it's a concern. To discuss all this, we have Dr. Vishnu Mohan, PT. You all know. His qualifications are MD, Fellowship in Neonatology, PGD MLS, and PGD Healthcare Quality from University of Bath, UK. He is working as consultant neonatologist in Aster MIMS Calicut. Apart from being the editor of NNF today, he holds many posts in IAP Kerala, IAP national level, and neonatology. Dr. Vishnu Mohan, your firing time starts right now.
Sir, for that introduction. Respected seniors and my dear friends, a very good morning. First of all, let me thank AAP, NNF Alapi, and NNF Kerala for the opportunity. So the topic given to me is neonatal hypoglycemia. As Narayan sir was telling, this is one of the few scenarios that we encounter on a day-to-day basis whenever we cater to newborn care. So glucose level in the newborn. Glucose is a primary source of energy for neonatal brain. Maintenance of normal glucose level is essential for normal neurological function and development. So needs urgent attention to prevent injury to the CNS. Placenta is impermeable to insulin. Fetus oxidizes glucose for energy needs. Remainder stored as glycogen and fat in liver and adipose tissues. This occurs till the late third trimester, therefore limited in preterms and low birth weight babies. No universal definition for hypoglycemia. WHO defines hypoglycemia as blood glucose level less than 45 milligrams per deciliter. And the highest infants are the low birth weights, preterms, infant of diabetic mothers, and the LGU babies. So, pathogenesis being inadequate glucose supply, inadequate glycogen stores, impaired glucose production, that is glucogenolysis and gluconeogenesis, increased glucose utilization like in excessive insulin secretions like hyperinsulinism and other causes like neonatal sepsis. So inadequate glycogen stores, prematurity, glycogen is deposited during third trimester, have diminished glycogen stores. In growth restricted fetuses, there's a decrease in the glycogen stores along with adipose tissue, decrease in gluconeogenesis, reduced ability to oxidize free fatty acids, and increased sensitivity to insulin. Impaired glucose production due to poorly coordinated response to the counter-regulatory hormones is another case. So, coming to a case, a male baby born by LSES for fetal distress, liquor was meconium stained, had bradycardia, required post-tissue ventilation, was shifted to the NICU. The mother had a bad obstetric history. There were 4 early neonatal deaths due to convulsions. 1 living sibling at 10 years is healthy. So birth weight was 4.22 kilograms, head circumference was 35 and length 50 centimeters, hairy pinna but no dysmorphic features. The first glucometry showed 20 milligrams percentage. IV glucose bolus given started on 10% dextrose at a rate of 6 milligram per kg per minute. So there's a question that comes to all of our minds. Do all macroscopic large babies warrant sugar monitoring or an ICU admission? So genetically large babies who weigh up to 4 kilograms do not need glucose monitoring, but if in doubt, it is better to err on the positive side. So these babies look large but have proportionate head circumferences and no other clinical features of an infant of diabetic mother. So what glucose levels do we act? So the operational threshold is 45 milligrams per deciliter on the bedside. So another important point, glucose bolus versus glucose infusion. So give bolus only if symptomatic or bedside glucose less than 20 milligrams percentage. Otherwise, infusion with 15 minutes monitoring till levels are more than 50 milligrams percentage. So how the glucose balance takes place. Neonatal glucose concentration falls rapidly after birth, nadir at 1 hour of age as low as 30 milligrams per deciliter. Stabilizes by 3 hours of age. Glucose production by glucogenolysis and gluconeogenesis. Promotion of oxidative fat metabolism using lipids from fat stores and ingested milk feeds. Transient and asymptomatic ones are resolved spontaneously or in response to milk feeds. So we all know the signs and symptoms like irritability, apnea, jitteriness, feeding difficulty, lethargy, tachypnea, seizures, hypothermia, and tachycardia. So this something important. Critical sample. Lab findings, especially the hormonal responses at the time of hypoglycemia, is known as a critical sample. Critical samples are obtained when plasma glucose is less than 50 milligrams per deciliter, and blood samples are taken from plasma insulin, cortisol, blood pH, free fatty acids and ketones, bicarbonate, lactate, ammonia, and urine for ketones and organic acids. So this is how the approach goes. In hypoglycemia, with presence of acidemia, look for the ketones. If the ketones are increased, think about ketotic hypoglycemias like cortisol deficiency or growth hormone deficiency. Lactic acidemia, think about disorders of gluconeogenesis like pyruvate carboxylase deficiency or glycogen storage disease, disorder 1. In absence of acidemia and a reduced free fatty acids or reduced ketones, think about insulin-mediated ones like hyperinsulinism, and increased free fatty acids and reduced ketones, think about fatty acid oxidation defects. So rule out other investigations, rule out other causes of hypoglycemia, do all basic bloods like CBC, LFT, kidney function test, and always rule out sepsis. So again, another question that we need to be aware about: how high GAR can we go up to? So beginning with 6 milligrams per kilogram per minute with gradual high creatinine euglycemia with a minimum concentration of glucose required. A peripheral vein or an umbilical vein is a preferred route. Other than in emergency, rates more than 12.5 to 15 milligrams per kilogram should be given only through a central venous line. So rates more than 25 milligrams per kilogram are contraindicated by either route. So any precautions? Again, as we told, rapid correction of hypoglycemia is reported to have worse neurodevelopmental outcomes at later stages. So better to have a strategy of bypassing the 200 per kg bolus in favor of simply starting a continuous glucose infusion in asymptomatic patients. So other interventions at this point: start feeds. If hypoglycemia persists on a GAR of 15 milligram per kilogram per minute, specific medications are recommended like hydrocortisone, glucagon, and diazoxide. So in our baby, the blood sugar levels continue to be 38 milligram percentage. The GAR was stepped up to 8 milligram per kilogram per minute. And on repeat evaluation again, the blood sugar levels remained low and the GAR was stepped up to 10 milligram per kilogram per minute. On evaluation, the basic bloods were normal, ABG was normal, and the serum insulin was found to be 65 microunits per milliliter. So glucagon activates adenylate cyclase via G protein coupled receptor, increasing genolysis and gluconeogenesis, indicated in emergency treatment of severe hypoglycemia and infants awaiting surgery, and also many times aids the diagnostic process. Dosage is 1 milligram glucagon as IM, IV, or subcutaneously. In case continuous IV glucagon, 1 to 2 milligram per day. One of the problems is glucagon is not easily available. So first line treatment in hyperinsulinic hypoglycemia, it acts by opening the potassium ATP channels, hyperpolarization of pancreatic beta cells, preventing glucose-stimulated insulin secretion. Also affects by increased hepatic glucose production, decreased peripheral utilization of glucose, and increased lipolysis. Dose is 5 to 15 milligram per kilogram per day, per orally 8 to 12 hourly. And whenever we use, we need to have a concomitant diuretic therapy as it causes sodium and water retention, along with hypertrichosis, hyperuricemia, tachycardia, and leukopenia. So cortisone steroids are not an effective therapy for hyperinsulinism. In the past, steroids have been widely used in hypoglycemic infants. Better understanding of the pathophysiology is needed. It exposes infants to unnecessary adverse effects such as pathogenic adrenal insufficiency, hypertension, bone demineralization, indicated in acute and chronic adrenocortical insufficiency. Dosage is 10 milligram per kilogram per day, IV in 2 divided doses. So the differential diagnosis in our case at this point is congenital hyperinsulinism, maybe genetic or familial, most likely autosomal recessive, ABCC8 or KCNG mutation. So hyperinsulinic hypoglycemia, any insulin response if blood sugar is less than 33.5 millimoles per liter on high GAR more than 8 milligram per kilogram per minute. When in doubt, a positive glycemic response to glucagon or octreotide therapy can be useful, can be transient, prolonged, or persistent. Hyperinsulinemia is usually not related to intake and can occur any time after feed. So transient hyperinsulinemia seen in infant of diabetic mothers, small for gestation age infants, perinatal asphyxia, polycythemia, present soon after birth and settles in a few days with increased intake. May be related to maternal glucose levels due to a transient derangement in insulin secretion or response to intermediaries of the counter-regulatory hormone mechanism. Prolonged hyperinsulinemia seen in SGA babies, no genetic cause has been identified. Resolution seen in weeks to months, may be diagnosed as late as 2 weeks after birth. Responds well to diazoxide. And then hyperinsulinemia, usually genetic, hyperinsulinism, hypoketonemia, and hypofatty acidemia with severe and persistent hypoglycemia. May be a channelopathy or metabolopathy, or associated with syndrome, overgrowth syndromes like SOTO and Becker-Treatment syndrome. Channelopathy most commonly due to mutation in ABCC8 and KCNG11 genes. They are unresponsive usually to diazoxide. Metabolopathy, hypoglycemia seen after feed, response to diazoxide. So our baby was started on diazoxide, reached maximum GIR and diazoxide from my 5 microgram to maximum 15 micrograms per kilogram per day. Still, there was some low sugars. The dosage was hiked up to 25 microgram per kg per day. Baby was tolerating feeds and was on full feeds. So a few questions that comes at this point. Any problems with high diazoxide doses, use of hydrocortisone, nifedipin's role, and octreotide. So high dose diazoxide causes fluid retention, increased weight gain can cause heart failure due to fluid overload, need to add thiazide diuretics, and hypertrichosis with increased growth of hair on the body. Non-response is also seen in a few babies. Hydrocortisone, no specific role unless pro and glucocorticoid deficiency. Often used, it is difficult to maintain glucose values in the normal range despite a GR of 15 milligram per kilogram. It reduces peripheral glucose utilization and increases gluconeogenesis and increases the effects of glucose. So nifedipine, any role, and it acts by the L-type calcium channels, permit entry of calcium into the beta cell to stimulate release of insulin, blocks these channels. Dosage is 0.25 milligram per kilogram per day, divided in 3 daily doses. In practice, ability to wean the intravenous glucose infusion or reduce any of the concomitant medications, not very effective. So genetics defines the best approach to treatment of congenital hyperinsulinemic hypoglycemia. In patients who are not responding to the first-line treatment with diazoxide, it's important to distinguish focal or diffuse disease. So 3 situations to be considered: presence of 2 pathologic variants, homozygous or compound heterozygous mutations in ABCC8 and KCNG. Is usually diagnostic of a medically unresponsive diffuse disease. Presence of single recessive potentially have a curable focal disease, and mutations not identified require further imaging tests to localize these lesions. So the approach goes. So in our case, the erratic but ill-sustained response to hydrocortisone and nifedipine. 24 hours after starting octreotide, GR and diazoxide gradually tapered. So octreotide frequently used as a second-line therapy for persistent hypoglycemia, non-responsive to diazoxide. Inhibits insulin secretion. Dose is 5 to 30 micrograms per kg per day, 8 hourly subcutaneously. GI symptoms like pale stools, dilated gallbladder without gallstones, NC hepatitis, growth deceleration of adverse effects. Long-acting somatostatin analog like lanreotide acetate is a safe alternative. So it binds to somatostatin receptors and acts via G protein coupled inward rectifier potassium channel. Dosage is 5 to 10 microgram per kilogram per day, administered subcutaneously. Imaging in hypoglycemic infants, the most useful imaging technique is the f-propofol emission tomography, that's a f-propofol scan, but not widely available, and it helps in identifying the pancreatic pathology as a focal or a diffuse disease. but it doesn't help in identifying the location or the size and extent of the lesion. So histopathology is again into two classifications, focal or diffuse. So our baby was on full feeds, Jaundice, oxide and subcutaneous octreotide, maintaining acceptable sugars. Mother strained to give subcutaneous octreotide. Octreotide PET CT was suggestive of diffuse histopathology, but not conclusive. Parents were opted against separate pancreatectomy in view of results. And our genetic results came as autosomal recessive ABCCH nonsense mutation in potassium channel SCR1.
Excuse me. Thank you. Thank you, Dr. Vishnu Mohan. Now we will go to the next speaker.
Now we have another important problem, just like hypoglycemia, that is a retinopathy of prematurity, what is behind the screen. I think now it is one of the most common cause for the blindness in the low or middle income country. We are increasing survival of the preterm baby with the complication. I think there is epidemic of, it is mentioned like that epidemic of premature ROP. So to discuss this, we have our neonatologist from Lifeline Hospital, Ladu, Dr. Binu Govind. He completed his MD from SAT Hospital, Trivandrum, and done his DN neonatology from CMC building. He got many publications in index journals. And over to Dr. Binu.
Thank you, sir. Hope I'm audible. I'll be moving into an important section, and I will try to do justice in around 10 minutes. So regarding the topic, something about the anatomy. Retinal vascularization starts from 16th week and then spreads. Nasal vascularization is completed by 36 weeks and peripheral retina by 40 weeks. As you all know, the eye
Not audible.
Yeah, I'm audible now?
Yeah.
Okay, thanks. The IGF-1 and the VEGF contributes to the ROP development. Now, this is the picture which I just mentioned, how the vascularization starts from the around the orocerat and reaches the temporal and the lateral side. Now, briefly regarding some things, like the mean birth weight of infants with severe ROP was greater in developing countries. Exactly, the mean gestational age was also greater in the developed countries compared to the developed countries. Now, why is this though? Is maybe I think that the developed countries will be looking after the smaller babies. But now, as more and more units are building up across our country, I think the scenario will change. Now, the etiology, we all know about the prematurity cause for pregnancy. There are a lot of other causes also, like low birth weight, low gestational age, assisted ventilation, surfactant therapy, high blood transfusion volumes, then severely ill babies. All these things have been independently associated with high rates of ROP. Now, these are the zones. I'm not going into the details. Just for the completion sake, I put up the zones and how they are divided. The zone 1 is the central zone of the posterior pole of the retina. Zone 2 is outside the zone 1, and zone 3 is the outermost part. Now, the staging also, I am sure everybody is quite well known. Flat line, stage 2. Stage 2 is the ridge. Stage 3 is the fibrous tissue proliferation. And stage 4 onwards, the retinal detachment starts. The extent, this is basically regarding the clock hours. The retinal surface in 12 sections and similar to the hours of a clock. And the plus disease, of course, we are familiar with this. This indicates the disease severity, dilatation and tortuosity of the retinal arterioles and venules in the posterior part of the retina, associated with vitreous age, engorgement of iris vessels, and poor dilatation. So this is what we don't want in a premature baby. Now, pre-plus disease is just before this stage. And threshold ROP, there's a certain terminologies which we all come across. So I just put up this together: 5 contiguous clock hours or 8 total clock hours of stage 3, and plus disease in zone 1 or 2. Pre-threshold ROP, I'm not going to read all this. All these things you can get up from the textbooks. Now, this is important. The type 1 ROP means the ROP which you have to treat. So any stage ROP with plus disease in zone 1, or stage 3 ROP without plus disease in zone 1, or stage 2 or stage 3 ROP with plus disease in zone 2. So these are the ROPs which you have to treat. Now, how does the ROP progress? Naturally, typically begins at around 34 weeks. advances irregularly until 40 to 45 weeks, and then resolves spontaneously. All poor visual acuity outcomes had a history of severe ROP. Now I just put up some pictures. Now, as you can see, the pointed areas, you can see the place where the vascularization, that is, I just put it, this is the zone between the good vascularization and the reasonably avascular retina. Now, this is the thing known as the ridge. And you can see the vascularity coming up to the ridge, and beyond that, there is the avascular retina. Now, from here, it will start proliferating into the vitreous if we don't take care at this point of time. So this is what I meant by the demarcation line along with the ridging in this side. And this is stage 3. There is more of ridging and fibrovascular proliferation. And this thing will be proliferating into the vitreous rather than going into the temporal part of the retina. And here there is a partial retinal detachment has already started. And this is the stage 5 or the total retinal detachment. Now, this is the plus disease where there is posterior venous dilatation and arterial torsions. You can see an angry looking retina. And the aggressive posterior ROP, which we usually see when we look into this, the ophthalmologist will write this and go. Severe plus disease, subtle retinal findings, rapid progression, and posterior location. So this is a separate entity in this ROP. So I just put this all together. You can see there is the normal blood vessels proliferating, and then there is this demarcation line and then avascular retina. And from this demarcation line, the fibrous tissue starts proliferating. And so instead of the retinal vessels, the fibrous tissue is proliferating, and then it attaches to the retina and whatever the lens and all, and then it causes the retinal detachment. The lens and whatever, and then it causes the retinal detachment from here. So these are the stages of the ROP progression. And there is a video for this. I don't think I'm showing this. So whom to screen? I think this is better for the practical practice points. I think we'll be needing this. All newborns less than 34 weeks, right? All newborns less than 34 weeks or less than 2 kilos. This is the NNF guidelines, has to be screened. Whereas if you go to the American Academy, they will be cutoffs like 30 weeks and 1.5 kg. Newborns between 34 to 36 weeks who were sick, it is the responsibility of the neonatologist to identify extremely septic babies, extremely high jaundice, on high ventilator settings. All these will come as if the baby is up to 36 weeks, you are justified in going for an ROP. When to screen is, there is not much controversy here. At 4 weeks of postnatal age, that is the safest. But nowadays, if the newborn is born, we are more and more people are taking care of 23, 24, 25 weeks. So better to do it at 2 to 3 weeks and then screen every 1 to 2 weeks till vascularization is complete. The thing is, sometimes if you do early, the ophthalmologist will tell that it's not seen, it's hazy, it's not opened up and all. That's fair, you can repeat it. And the treatment, I'm not going to the details of this. As you all know, there is laser and anti-VEGF. There are merits and demerits from both of them. Now, laser is the standard practice. It takes more time for normalization if you go for laser. What they say is if the VEGF therapy, the normalization is much more faster. But the thing is the recurrences are supposed to be slightly more if in the VEGF compared to the laser group, even though no definite guidelines have not come. It all depends on the practitioner's thing. Like the ophthalmologist who is comfortable with what therapy, he goes for that. A baby opting for laser can go for VEGF if he's not getting the desired event, and vice versa. Now, prevention of ROP, you can't prevent preterm births. So that is the easiest way to prevent it, but that is beyond us. And we are trying to take care of more and more preterm babies. So how you can't do that, obviously. Breast milk is supposed to be protective. DHA supplementation, most of the breast milk and most of the formula feeds are now supplementing with DHA. Of course, principles of BPT therapy, like whatever have oxygen control and all these things, and the shorter duration of ventilation, all this comes in BPT control, and that indirectly helps in ROP. So whenever you see the studies, you will see all these as a secondary outcome. They will be looking at ROP also. Now, doubtful therapies, antioxidant, not much in the practice, and oxygen targets. Even though everybody says keep low oxygen and prevent ROP. There are various schools of thought. Like if you keep low oxygen, there is a trend, but no definite statistically important difference. And there is an increased mortality for extreme preterm if you keep low oxygen. If you give supplemental oxygen, the outcome is better, the mortality side, but there is a trend towards higher ROP. But there is no definite, like you have to keep this 89 to 94 thing to reduce ROP like that. So that is, this keeps on changing. I'm telling the current thing. So I think this will be my last slide. ROP is preventable. I don't know, it's for you to judge. I don't think it's preventable, but there are a lot of factors which will help in minimizing this. So I think from the practitioner's point, as you more and more you treat these small preterms, you'll be looking into this more. I think I have fairly done justice. I'm happy to answer the queries. So sorry for the delay, but thanks to all the organizers for giving me an opportunity to talk. Thank you.
Stop sharing, Binu. I think we have only one question. All three speakers done a very wonderful job. Stick to their time limit. I think only one question. Can you elaborate to Binu? Can you elaborate a bit more about the BGEF, especially regarding how long to follow up if giving BGF?
See, the thing is, there is no definite thing like you have to follow up for this much time or anything. The thing is, the VGF is much more easier to give. So certain ophthalmologists prefer this because, and there is not much of side effects. You can directly give it and it's a very short procedure and doesn't cause much harm. The problem with this VGF is it may affect the vasculature in the other organs like brain, kidney, and the heart. And there are concerns about long-time problems in these organs, though it's not scientific evidence. The follow-up is the same. You keep on looking every 2 weeks. And once the vascularization is complete by 45 weeks, I think you will be able to make a judgment. Say your baby is born at 25 weeks. In the next 20 weeks, you will be having a clear idea whether you are treated it properly or not. Beyond that, I don't think these drugs or laser can help you out. If the baby has a bad ROP and he has developed retinal detachment, you will have to go for the therapy for that, like scleral buckling. So I think up to 45 weeks, every 2 weeks, whichever be the modality of care.
Yeah, one more question to Dr. Binu. What is the role of antenatal steroid in preventing ROP?
No definite linkages between antenatal steroids and ROP. The thing is, indirectly, as you all know, the antenatal steroids helps in reducing the oxygen dependency and the ventilation. And in that aspect, in an indirect way, it may help. But no definite thing like helpful against IVH, RDS, and NEC. No definite direct link is there, as far as I have read.
I think that finished the questions in the chat box. Thank you all speakers for keeping to the time and finishing the session before time given. Thank you all.
So good morning to all. So without any delay, let us move on to the next session for today. And for the same, I invite our chairpersons, Dr. Ravindra Verma and Dr. Mohandas Nair. Dr. Ravindra Verma is the senior consultant and neonatologist at Mother Hospital, Thrissur. And Dr. Mohandas Nair is the professor and HOD of Pediatrics, Government Medical College, Idukki, and IAP President, Kozhikode. So over to you, sir, to introduce the topics and the speakers for the present session.
Thank you. Thank you very much. I am extremely thankful to the organizers for asking Dr. Mohandas and me to chair this session for this NNF MidNeocon. I don't know, the litigation has become a fashion in medical practice nowadays. On 2nd of July 2015, one day after the Doctors' Day celebrations, neonatologist community was rudely awakened to a judgment by the apex court in a ROP case for 1.3 crores, which was awarded to a case to a baby who went blind in 1996. That was a time when even ROP screening was not proper. I don't know, a handful of people knew how to do ROP screening in whole of India. It was an enhancement of 5 lakhs compensation awarded in a lower court in the state. So That is the way things goes. Welcome to the world of litigations. To talk all about this, we have Giridhar. To introduce the speaker, I request Mohan Das to introduce Giridhar. Thank you.
Thank you, Dr. Verma. Dr. Giridhar Seduraman is professor in neonatology, presently working in Chettinad Hospital and Research Center, Chennai. He has contributed in developing NeoPED, that's Indian Pediatric and Neonatal Database Software. He is a trainer in NIV, NRP, and FBNC. He's a good academician, researcher, and his oratory skills we are going to enjoy. Dr. Giridhar.
Thank you, sir, for that wonderful introduction. Am I audible to everyone?
Yes, yes.
Yes, sir. Yeah, I'd like to share my screen. Is my screen seen to everyone?
Yes, yes.
Yes, sir. Yeah, thank you, chairpersons, Mohan Das sir and Verma sir for the wonderful introduction. I would like to thank the organizing committee of Alappuzha MidNeocon for the opportunity given. I enjoyed the previous sessions by the speakers. So we will just digress a little bit and come to one area where we are more and more we face more and more legal issues. So now this is the current state of the neonatologists in India. They are constantly being chased by lawyers who are specialized in medical law. I think this is all the more important for neonatologists because they are treating newborns, and if harm happens to your newborn, it would affect the entire life, and the cost towards care will escalate a lot. So compensations are also pretty high. And second thing is the judges who adjudicate in such cases always empathetic towards newborn. So they don't take any harm happening to newborn in a lighter way, and compensations are pretty high. This is what we are seeing globally. So neonatologists are always going to be at a legal problem with the work they are doing currently. And this is more and more happening. Newborn practice is inviting litigations. I think globally, if you look at pediatricians and neonatologists, they are fourth among all medical and surgical specialties in terms of litigations. So after neurologists and neurosurgeons, after obstetricians, the fourth on the list is pediatricians and neonatologists. And these are the general reasons why malpractice lawsuits are being awarded. If you see among the entire reasons, I don't want to go into the entire list. The tick mark ones, that is the ones like brain damaged infants, problems during routine infant and child health check, respiratory issues in newborns. These are the ones that attract a lot of indemnity. The average indemnity goes pretty high in these conditions, even congenital and non-teratogenic anomalies, premature births. So most of these have implication in newborn practice. So if you are a neonatologist, you have to face it. I think this is the era of litigations. We live in an environment of litigations. We have to be very vigilant here. And this was what Dr. Verma was referring to, the third on my list here. This was a case in 2015 against the government hospital. The baby was actually born in 1996. And at that time, there was not much information about ROP. And the compensation in this case, where the baby later landed up with a stage 5 ROP, was pretty high. I think 1.8 crores. These are numbers we didn't actually hear about earlier. So, and also we see the other cases against ROP, 5 lakhs, 7.5, 64 lakhs, 43 lakhs. You can see that as the, the years become more, I think the compensation actually is, increasing. So this is what is going to face it. I think this is what is going to be the reality. So I think we have to sort ourselves out. Let's see what we have to do about it. So I'll just go as per, I'll just see certain scenarios. So this was actually a delivery room hospital management, or in the words of the parents, a mismanagement by a neonatologist. So this is a pregnant woman who was admitted in labor at 1 a.m. in the morning, and she was given Synto for augmentation. and the obstetrician was not at that point available at that point of time, and instructions were given. The nurses carried them out, and the obstetrician attends to the patient at 8 a.m. That time the fetus was noticed to be in bradycardia, and the obstetrician hurriedly takes up the mother for a lower segment cesarean section. And in that hurry, she did not brief the family and obtain an informed consent, because she felt that the baby's life was more important. Fair enough. The baby delivered, and the pediatrician was given a call, but he could not attend because it was an emergent delivery. He came later, and subsequently he took the baby to the newborn corner, started an IV drip, gave oxygen, and the baby was behaving fairly well. So the pediatrician thought that he could have the baby at the same hospital. Level 2A care was given by the pediatrician, and 3 months post discharge, the baby developed recurrent seizures. Now, because the seizures were not stopping, another pediatrician was consulted by the parents, and this baby was referred to a pediatric neurologist, where polytherapy was given. MRI showed global cerebral insult, and on follow-up, this baby cannot sit, cannot see, and also the baby is on recurrent many medications for seizures. Now the family alleges that the pediatrician is at fault. He should have informed the parents that there was a problem at birth, and because the other doctor had told that this problem has actually happened, the problems which the baby is having at that current point of time was all the continuum of what happened at the birth. So is this medical negligence? That is a question that it comes to our mind. So what is medical negligence? So there should be 3 issues that should be there in medical negligence. First, there should be an established doctor-patient relationship. So when we start seeing a patient and we start doing our work as a doctor, we undertake a case, we decide treatment, we decide the treatment modalities also. So this, when offered to do that, that establishes a doctor-patient relationship. The second thing is, not only that the relationship should be there, there should be an act of omission or commission. Either we should have omitted doing something, or we should have done something wrong. So I think even there is no consensus on what is the correct way of managing the child. This principle drops in. This is called the Bolam's principle. So when there is no consensus, no standard way of managing things, then the court generally asks other competent doctor whether what he would have done. If many doctors agree that they would have managed the baby in the same way, that is called the Bolam's principle. And if our own doctor did not do that, that becomes an act of omission or commission. Sometimes it becomes very obvious, which is called the res ipsa loquitur. So the thing speaks in itself. So it becomes very obvious that the act of omission or commission has happened. So these 2 principles have to be there. And last thing is there should be a damage, and that damage should be quantifiable. So this damage should be a direct result of the act of omission or commission. If these 3 things are there, there is an established doctor-patient relationship, an act of omission or commission, or there is a damage, then it constitutes medical negligence. So let's see, in this case, the doctor had decided to, the pediatrician has decided to treat the case, though there is a definite relationship that is there. Direct an act of omission, because the baby was not referred to a level 3 NICU, because we know that therapeutic hypothermia is the standard of care for such babies. So there is an act of omission. The damage is a direct result of that, because this baby has ended up with a neurodevelopmental impairment. And we know that therapeutic hypothermia, all the systematic reviews say that it avoids neurodevelopmental impairment. So there is a definite medical negligence in this case. So what are we answerable to? We as neonatologists are answerable to a lot of people, not only to the patients, we're answerable to the medical council, where medical council to tell us that we have not followed the standard way of managing things. And we are answerable to the civil court, we are answerable to the consumer forum. If the act of omission as commission has caused death or a serious impairment, then we are even answerable to the criminal code. And a lot of other peoples also come into the picture, like the National Human Rights Commission, the Prevention of Child Sex Abuse Commission. All these acts come into the picture. And now people have started doing, the governments have started doing the Janata Darbar. We have seen this sort of Janata Darbar in UP, in West Bengal. So I think most of the times doctors are called to the Darbar to answer patients' complaints. So we are answerable to a lot of people here. And the most annoying thing is the Consumer Protection Act, the Consumer Forum, because the Consumer Protection Act in its 1986 amendment brought our profession into the Consumer Forum. So this is an easy procedure because anyone can go and give a complaint to the Consumer Forum, and it's an easy procedure. A lawyer is not required, and it doesn't involve any monetary liability to the patient, because there is no stamp duty. The 10% stamp duty which comes for a civil complaint or a criminal court complaint does not stand good here. And the other thing is, I can complain and file a case in any Consumer Forum. So the patient could have undergone treatment in Delhi, but I'm a native of Assam or I'm a native of Chennai, and I give a complaint in Chennai. Then the doctor has to come all the way to Chennai to answer these complaints. So it involves a lot of travel, and even local courts, they can award a compensation of up to 1 crore. And in these forums, judges may not always be presiding officers. Social activists could be presiding these forums. So these are areas, I mean, this one forum where doctors are always at a fault, and 1 in 2 cases goes against a doctor. So this forum has now become more of a foe than a friend for the doctor. So what do we do? I mean, follow ethics to avoid availability. That is the buzzword. So ethics, the 4 pillars of ethics are doing good, called beneficence, and doing no harm, which is called maleficence. Both these things, if we are going to do good and do no harm, I mean, these when it comes to neonatology, we are doing things in the best interest of the baby. The third pillar is autonomy. We should respect the individual preferences, but because the newborn population is such that it cannot, voice out its grievances, though this is the onus of the parents to actually voice the preferences of the newborn, and the courts generally support these parents. And lastly, justice. So this is one thing that is slightly blurred in the Indian scenario, because justice means equitable distribution, but at least for neonatology, it means that use of resources effectively. So let us visit some problem areas in neonatology. The number 1 problem area is delivery room, where the allegations are often that the proper resuscitation has not been done. The second problem area is related to birth asphyxia, where the doctor has failed to recognize HIE and initiate therapeutic hypothermia, like we saw in the case number 1. And the third and a very important problem is when babies being born, when the gestational age is not known and they look very small, less than 1 kilos. So deciding the appropriate level of care becomes very important. And late preterms, these are not term babies, they behave like preterms, and unrecognized complications in the nursery, they're not seen and properly treated, they're landing up with problems. Newborn jaundice, always a problematic area. Failure to recognize the risk factors, not doing a pre-discharge bilirubin, and no follow-up being there. These are areas where neonatal jaundice causes problems to the neonatologist. And lastly, patient safety, because errors are creeping in practice. These are procedural errors, medication errors. Procedural errors, I mean that if you place an umbilical arterial catheter, you land up with the ischemia of the lower limbs, which we don't recognize, then it becomes a procedural error. Medication errors, like we give a higher dose, the right duration, everything has to be taken care of. It is not being followed, then it can land up with errors. And hypoglycemia, failure to monitor sugars in high-risk population, not monitoring electrolytes in extreme preterms. All this could be errors which we see in neonatal practice, which could be problematic areas in neonatology. So a few cases.
So we have 2 more minutes.
I'll finish, ma'am. Yeah. So this is a 3-day-old child who develops 3rd-degree burns the postnatal ward after a bath. The nurse did not check the temperature, and the parents decided to sue the doctor, nurse, and the institution. Who's at fault here? So the nurse claims that she is under vicarious liability because superior is answerable for her. But currently, the court of law is saying that vicarious liability only when the nurse is under the direct supervision of the supervisor, it comes under that concept. So the concept is moving away from the captain of the ship concept, though the doctor might not be held liable for the actions of the nurses, because this nurse particularly was in the postnatal ward giving a bath to the baby. So vicarious liability is one thing that we need to know in medical legal cases. So this is a 4-day-old child in the postnatal ward found to be unresponsive, and the attending physician was had seen the baby around 1 hour back, and the baby was found to be normal. Now the parents are agitated and decided to sue the doctor. So the onus here, the medico-legal angle here is explanation of the unexpected death has to be given by the healthcare team. And even in the cases, on the doctor, the onus on explaining the negligence is on the patient. So the patient has to prove the negligence on the part of the doctor. So if the doctor has followed all the diligent procedures, then he is not negligent. So these are things that we generally do when there's sudden unexpected death. Immediately give an info to the family, receive the family in the counseling area, and prepare the relatives the possibility of death. And if the baby is actually dead by the time the parents arrive, we use, we disclose death only by a senior pediatrician, and we ask them to express their grief, and we don't discourage that. We don't tell them to remain silent. And if there is parents start abusing the team also, we remain silent, but we generally do things to audio record so that we don't land up with medical legal angles, and don't forget the need for medical autopsies. And if the other relatives are there, you want to view the body of the baby, don't prevent it, because only thing is we have to show it to them. Only thing is make it more medically presentable, disconnect the tubes, cover the baby with the cloth, remove all the secretions and the blood, and then show the babies to the attending relatives. And very importantly, be flexible about money, because most of the litigations in these children, in these cases, are related to not paying the fees and overcharging without a good outcome. And a lot of times when this happens, the treating physician is not there and the baby is being seen by some other person. So what the law says is the last attending physician has to take responsibility. But if you are not there, it's our duty to inform the parents and display that we are not there, and assign the role to someone with their equal competence, qualification, experience. So periviable births are something that is always a problem. We don't know what is the periviable period in India, because different bodies give different things. So the recent issues which happened in Delhi, all have told that because as made the IMA, IAP and NNF come up with this gestation less than 28 weeks. So viability or must treatment has to be provided only to individuals that are more than 28 weeks. They're going to be less than 28 weeks, then a call could be taken depending upon the other issues and the parental concerns. So a lot of things are here. Look at all the risk factors. At least in private setup, this is what we do. The baby is having an extreme high chance of mortality, and the high risk, that is called the high risk group, extremely high risk group. There is a chance of mortality is 50 to 90%. It's called the high risk group. The less than 50% mortality is there. It's called the moderate risk group. So depending upon a local data, come up with gestations. And if there is extremely high risk, then palliative care has to be given. If it is high risk, then parents refuse treatment, still palliative care. But the parents agree to treatment, then we can actually give full quality care, but with documentation. And the baby is going to be at moderate risk, then life-sustaining care has to be given. So if the family wants treatment, even the baby is not likely to be viable, it is our duty to provide treatment, but always re-engage the parents. Let us know that this baby is not likely to make it, but provide treatment. But if the other end, the baby is likely to do well and the families still don't want treatment, then seek a legal support. It's better to refer these children to the government setups, because otherwise it might become a little bit tricky for the neonatologists also. So always maintain consistency in obstetric and neonatal care, and review your management plan and have a clear documentation. So last slide is this, some question answers. Is it necessary to have a pediatrician for every delivery? What the code says is yes. What is the legality of the newborn screening, the hearing screening, the ROP screening? Regarding newborn screening and hearing screening, if the facility is available, it can offer it, but if facilities are not available, it can be done away with. But the ROP screening has to be done as per the current government protocol. So you are attending a delivery, the obstetrician wants the pupil sterilization, sterilization, and the baby has respiratory distress. And she says that the distress is likely to settle down. Give your consent, but pediatricians have to take a stand here. Don't give a consent. So, but if you land up giving a consent for tubectomy and the baby has worsening distress and pulmonary hypertension, the baby admitted to the NICU, and now the parents are agitated. Now we are at a fault, accept our fault, but tell them that PPHN is an evolving process. And it's always put to involve other specialists here to make the parents understand the issues. And lastly, what if bills are not paid and the patient does not have money? It's our duty to continue treatment, inform the police, refer the patient ideally to a government hospital where free treatment is provided, and try to get the money later by a civil suit. So tips to avoid litigations: attention to plan, additional opinion, have good behavior. See the bills, talk to the patients about the bills, communicate to the patients. Consent is very important because lack of consent is negligence. Be compassionate in your care. Document. The D stands for documentation. Give good expertise and be efficient in your management. So good current protocols, evidence-based management guidelines should be followed. And there are government guidelines, please follow them. And lastly, have a professional indemnity insurance. So thank you. Other slides, I think we are beyond time. So we have been talking to our patients, telling them that prevention is better than cure. Now this is applicable to doctors also. So
okay, thank you, Dr. Giridhar.
Yes,
we have exceeded the time now, so
yes, sir.
we will move to the next session. Okay, thank you.
Thank you, Giridhar. I think we will go to the next session. This will be done by none other than Dr. PMC Nair. I don't think he needs any introduction. As you all know, neonatal jaundice is a problem, but I have not seen a case of kernicterus for the past 15 years almost now. But I have seen a lot of cases of RH incompatibilities even after giving anti-D to the mother properly. That is the one thing which has come to my notice. To talk all about neonatal jaundice, we have Dr. PMC Nair. He did his MD and DCH from CMC Vellore. He has DNB and FRCP. He did his one of the earliest neonatologists in the country. He did his fellowship in neonatal intensive care from Sydney, Australia. He is ex-HOD and of neonatology and pediatric ICU, Sultan Qaboos University, Muscat, Sultanate of Oman. He is an HOD of pediatrics and neonatology at Sri Gokulam Medical College, Trivandrum now. He is also an emeritus professor of SAT Hospital, Trivandrum. He is an honorary consultant to KIMS and Anandaburi Hospital, Trivandrum. He is the national faculty in neonatal resuscitation program. Dr. PMC Nair, please.
Thank you, Dr. Verma. So we'll go straight away into the topic. If you look at it, a few issues in the management of the newborn infant have generated as much confusion and anxiety as jaundice. And I'm sure some of you know the term virginity phobia, that is the fear of 20. I still remember 2.5 decades earlier, I had to go to Idiki to protect a doctor, and the advocate had brought the OP guide test book to show that any value above 20 causes brain damage. So that was the situation. Now, but if you look at it another angle, bilirubin is an antioxidant. 50% of them, 80% of preterm babies develop physiological jaundice. Then the question is, why are we worried? We are not worried about the jaundice. We are worried about the kernicterus part of it, isn't it? We don't think about it unless we end up in the problem. And as Giridhar, I was his examiner earlier, so I'm very happy that he's doing very well. And Giridhar just discussed about the medical legal aspects, and jaundice is another area where I can run into problems. There's high levels of lipid soluble, unconjugated free bilirubin. That is the one process the blood-brain barrier and causes staining and damage of the brain tissues, causing apoptosis and necrosis, resulting in bilirubin-induced neurological dysfunction. And in preterm babies, especially, the blood-brain barrier can be broken by asphyxias, ischemia, inflammation, hyperosmolarity, hypercarbia, acidosis, and trauma, and lower the integrity of the blood-brain barrier in the slow gestation babies, leading to lower threshold for bind. So we have to be careful. It's not as simple as we think. And with different forms of acute bilirubin encephalopathy. But the classic one we see after the first year, brought for MD examinations, presenting with sensory neural hearing loss, upward gaze palsy, dental enamel hypoplasia, and dystonic or orthototic movements. If you look at the identification or finding out the seriousness of the jaundice, first is we have got physical screening, that is modified Kramer's rule. We have the transcutaneous bilirubinometer, and finally blood estimation of total serum bilirubin. Carboxyhemoglobinometry, bilirubin albumin ratio, all these are more research oriented. Anyway, the American Academy of Pediatrics recommends universal bilirubin screening in all neonates within the first 72 hours. And this is Bilicheck machine. Drag is a very good one. It measures the multi-wavelength spectral reflectance from the skin surface. And the disadvantages of transcutaneous bilirubinometer are: one is not reliable, infant is undergoing phototherapy or exchange transfusion, also prolonged jaundice, conjugated hyperbilirubinemia, also skin pigmentation and gestation also affected. Otherwise, it's a very useful non-invasive technique. And now we have nomograms also to document the transcutaneous bilirubin. You do it either on the forehead or on the chest. And the sternum. Sternum is better, especially the baby is coming from outside. And I am of opinion the spectrophotometer should be available each NICU so that we can do a bilirubin estimation in the site lab. Now coming to management, my acronym is PHED, that is phototherapy, hydration, exchange transfusion, and drugs. In phototherapy, we know that is liposoluble, unconjugated bilirubin is converted to harmless water-soluble bilirubin, which is excreted as 4Z, 15E to 4Z, 15Z, 4Z, 15Z bilirubin is excreted in urine and bile. Also, the more stable structural isomer, that is lumirubin, is excreted mainly in urine and bile. Remember that bilirubin absorbs light optimally in the blue-green region, that is 430 to 490 nanometer. That is why the blue light is supposed to be very useful. And all of us follow the American Academy of Pediatrics guidelines, especially for term and late preterm babies. And there's a green line, red line, and the orange line. Orange line is for infants at higher risk. And we also have exchange transfusion guidelines, and it's ideal to have all this as a printout at care point for easy reference. I found this Bhutanese nomogram very useful, especially for term and late preterm babies. The high risk, high intermediate, low intermediate, and low risk is the green zone. They represent 95th, 75th, and 40th percentiles. And the important thing is medical legally also will be safe if you document and send. For example, I show this 48 hours of age, one baby is going home and the bilirubin is in the low risk zone. You can confidently send them home and see them after 2 days. Whereas if it is coming in the high risk zone or high intermediate risk, there is a danger. So you shouldn't send the baby home, or if the baby is going home, should be brought back within 1 day, next day itself, because otherwise you may end up in bind. So that is the importance of this Bhutanese nomogram. It's very useful. I think every unit should follow this principle so that they don't end up in problems. And the nice guidelines we have, especially from 23 weeks gestation onwards, this bilirubin absorbs light mostly in the blue-green region. And this is the CFL phototherapy in SAT hospital 20 years back. This is the fiber optic system. It's very convenient, but low spectral irradiance and it's very expensive. This is the halogen white lab. It's very hot, can cause thermal injury. This is the CFL, compact fluorescent light. This here, the LED, gallium nitride light emitting diodes. And this is the baby undergoing Billy blanket phototherapy. It's a very useful thing, but it's low spectral radiance and it's very, very expensive. We can't afford it. And we should also have a light meter, so-called flux meter, which we keep at the level of the abdomen to measure the spectral irradiance. For phototherapy, baby has to be prepared, eyes should be covered, and require good monitoring. Maintain 3-hourly breastfeeding and reposition the baby every 3 hours, monitor the weight, etc. Coming to intensive phototherapy, the principle is bring the baby as equipment as close to the baby, 15 to 20 centimeters from the baby. And the irradiance is much high, 30 to 35 microwatts. And the infant should be naked except for diaper and eye shield. And you should line the sides of the bassinet with aluminum foil, or you can have white curtain so as to reflect as much light as possible to the baby. Especially this very important do's and don'ts in phototherapy: shielding the eyes, minimum covering for the genital areas. Then the reflectors, light source, and transparent light filters should be kept clean. Change the lights after 1,000 hours or 6 months, or they flicker or blacken. Most of the government hospitals, when I have gone and reviewed, these simple things are not taken care of. Especially changing the lights and all, it's a problem. Check irradiance. If less than 6 to 8 microwatts per centimeter square per nanometer, change it. And also do rebound or check for rebound by repeating serum bilirubin. Hydration is very important. Adequate hydration helps conjugation excretion, give extra 20 ml per kg, but frequent breastfeeding is all that is needed. Contraindications: phototherapy for cholestatic jaundice, the Brown's baby syndrome, and also congenital erythropoietic porphyria. SN transfusion indications are cord bilirubin more than 5, previous sibling history, positive DCT, or increase in bilirubin in spite of intensive phototherapy and severe hemolysis. And about the drugs, IV gamma globin, I found it very useful in immune hemolysis. If there is RH or ABM, in Sri Gokulam Medical College, 15 years, I could avoid most of the exchange transfusions by giving IV gamma, though some studies have come recently showing it's not useful, but I don't believe what all, definitely all the things being published by the Western authorities. How it works is occupy the FC receptors or reticular endothelial cells, and so the circulating antibody bound RBCs, they are not recognized, so they help, so they escape destruction. So it's actually we are buying more time. Then another advancement has been the Doppler studies, middle cerebral artery Doppler, showing the fetal anemia. You see long, sharp systolic peaks, characteristic of fetal anemia hydros. Previously, we were doing with amniocentesis, amniotic fluid, and then spectrophotometry and charting the Lily's chart. This is obsolete now, just for some postgraduate information. Then intrauterine transfusion. This is one baby I bought from Sultan Qaboos University Hospital. Actually, the mother in utero, fetus, severe hydrops to Suresh Hospital, Madurai clinic, where we could do the intrauterine transfusion 2 times. Then we did the exchange transfusion at 36 weeks at Sultan Qaboos University Hospital, and baby had 2 more top-up transfusions, doing now very well, 24, 25-year-old, extremely well. And prevention and early detection is also very important. Educating pregnant women, pre-discharge counseling, watching for jaundice, establishing lactation. And RH isomerization can be prevented by anti-D after delivery, abortion, etc. In the US, they're giving antenatal anti-D at 28 weeks in RH negative mothers, so that the incidence come with immunoprophylaxis less than 0.1%. Clear Bedkett test for quantitative assessment of fetal maternal hemorrhage. These are the fetal cells, beautifully seen, and the maternal cells are acid eluted. They appear like ghost cells. So I'll try to conclude with 10 practice first. One thing is kernicterus is preventable. 85% of kernicterus is preventable. If we have a modified bind score, a bind M, especially in places where you don't have audiometry or MRI, this is very useful. Then first stage jaundice is always pathological, take it very serious. Also conditions of significant jaundice, that is increasing bilirubin more than 0.5 milligram per hour, requiring phototherapy, and all this you have to be careful, especially RH negative mother, O group mother, you have to be very careful. Crash cart approach to newborn jaundice, that's also a good idea. And just few cases, a DCT positive case, but no RH or AB incompatibility. Always think of minor blood group problems, because I was also fooled once. A doctor's baby, middle, yes? 2 more
So we have
minutes.
2 more minutes.
Oh, yes, thank you. So we had to do exchange transfusion 2 times, but I was lucky to save some sample, took to Sri Chitra, found out it is anti-E, anti-C. So remember that, minor blood group incompatibilities. Another case scenario where hyperbilirubinemia, AB incompatibility, bilirubin is very high, we gave double surface phototherapy, IVIG, but still the jaundice continue, improved, but jaundice continue. Then we took a ultrasound of brain and abdomen, look for the red herring, and there we got it. This was the one right adrenal hemorrhage in the ultrasound, which is responsible for the jaundice. So the pearl number 3 is unusually severe prolonged jaundice, think of concealed hemorrhages. Then another case, whereas the jaundice remained reasonably high even on day 32, but all the tests were normal. So this was a case of breast milk jaundice, a diagnosis of exclusion, but that also you should keep in the back of your mind. Then this baby had a 15th day jaundice, umbilical hernia, and the last time, and congenital hypothyroidism was an incident and finding. In those olden days, we are not doing the neonatal screening for each baby. So remember, prolonged neonatal jaundice may be the sole manifestation of thyroid hypothyroidism. This baby, 30 days, present in pale stools, direct bilirubin. So the diagnosis biliary atresia. So this is North American Society of Pediatrics advises more than 2 weeks of age, jaundice, pale stools, and high-colored urine evaluated for cholestasis. Another important point is OA estimation alone is not enough. We do not pick up sensorineural hearing loss. You have to do auditory, automated auditory brainstem above response. And the last point is quality improvement initiative. Neonatal jaundice pathway, they did in one study in pediatrics in 2018 published, showed that in creating a neonatal jaundice pathway and quality check, they've improved the management very well. And the last $1 million question is sunlight effective for jaundice? Answer may be no, but filtered sunlight is non-inferior to conventional phototherapy. This study was done in Africa. So film canopies can filter the sunlight and use it. And the last slide is mobile application softwares, example, Billy Tool, RCOG, Billy Checker, etc. You can feed the instrument with bilirubin level, age of the baby, gestation age, and it will give the recommendation. So thank you very much for the patient listening. I am open to questions later on. Thank you. Bye.
Thank you, sir. Crisp and to the point as usual. Now I request Dr. Mohandas to introduce Nelby.
Thank you, PMC sir, for that wonderful talk. I still remember PMC sir taking classes for us in 1993, 94 with the latest mannequin on NRP. Now we will move to the next session. It is on neonatal seizures. Previously, we used to over-treat neonatal seizures. Each and every abnormal movements we used to treat. All incessant cries used to get anticonvulsants. And now with the better understanding and investigative facilities like video EEG and AEEG and all, we can minimize drugs or optimize treatment, both in terms of number of drugs and the duration of treatment. And to talk on this, we have Dr. Nelby George Matthew, who DM Neonatology from CMC Vellore, now working as a consultant neonatologist in TMM Hospital, Tiruvalla. And he is secretary of NNF Kerala. And his areas of interest are extreme preterm care and non-invasive ventilation. Dr. Nelby.
Thank you, sir. Am I audible, sir? Thank you, sir. Am I audible?
Yes, audible.
Good morning, everyone. Over the next 15 minutes, we will go through certain aspects regarding neonatal seizure. I will basically speak on to the basics of neonatal seizure. The first and the foremost question, why should you discuss so much about neonatal seizures? It is because the newborn brain are highly vulnerable to seizure because the immature brain are more excitable and are more prone for seizure. The clinical implication is incidence of seizure is quite high in newborn period. Secondly, usually the neonatal seizure signifies an underlying illness. And then the neonatal seizure can damage the brain or exacerbate any pre-existing injury. And coming lastly, the drugs currently used for treating seizure, the anti-epileptic drugs, can have negative influence on developing brain, which may have long-term implications. Coming to the basic pathophysiology of seizure, if you see, the brain cell is kept in the resting membrane potential by the efflux of sodium. That is, sodium is continuously pushed out from the intracellular to the extracellular space, and potassium is pushed in, influx of potassium by the sodium-potassium pump. It is this sodium-potassium pump which maintains the resting membrane potential. This sodium-potassium pump is an energy-dependent pump. So any disease which causes energy depletion, like hypoxic ischemia, hypoglycemia, what happens is energy-dependent sodium-potassium pump fails. That can lead on to sudden influx of sodium and efflux of potassium, leading on to depolarization, and an action potential sets in. This excessive and uncontrolled depolarization of CNS neuron manifests clinically as seizure. That is the basic of seizure. Now, the next question, why newborns are more prone for seizure? If you see, the newborn as such is in an excitatory state, that excitatory receptors like NMDA and AMPA receptors are more expressed in newborn compared to the adult, while the inhibitory receptors like kinase, the GABA receptors, are less expressed compared to the adult. So as such, newborn are in an excitable state and they are more prone for seizure. Coming to the certain etiologies of neonatal seizure, the one which I am most worried is hypoxic ischemic encephalopathy, because it contributes to the major chunk of neonatal seizure. Next thing I am worried is metabolic cause, especially the easily correctable metabolic causes like hypoglycemia, because as I already said, it is easily correctable. But if you miss it, it can have devastating effect on brain, developing brain. The same applies to the infection also. That is why we don't want to, the seizure may be the first manifestation of meningitis, and you never want to miss a meningitis presenting as seizure. That's why LP, the CSF analysis, is very, very important in diagnosing and treating seizure. Seizure as such is a disease of dilemma. If you see the diagnostic choice, if you go by clinical criteria, seizure may be overestimated. If seizure mimics may be, as the server saying, seizure may be overestimated. The seizure mimics may be delta seizure and you will be treating it. If you see, sometimes electrical seizure may not be manifested as clinical seizure, then what happens is you will be underestimating seizure. So, but EEG is not universally available practically. So which criteria to go for? Coming to the etiology, multiple etiologies may be there. So to attribute one etiology to seizure may be difficult. The next question, which baby to treat, when to treat, and how long to treat? These are certain dilemmas when you come to clinical seizures. So over the next few slides, I will try to sort out certain dilemmas. Coming to a clinical scenario, this is baby of Soumya, took from the sister, staff has taken the baby from the ward on day 3, complaining that the baby has jerky movements of the upper limb. So on admission to the NICU, the baby was found to have continuous seizures. Baby was actively seizuring. So what is the first thing to do? Always make sure that the temperature, airway, breathing, and circulation is well maintained. Then next thing, put an IV cannula. Immediately see GRBS. There are controversies regarding the validity of GRBS, but practically get an GRBS done. If the GRBS is less than 45 milligram deciliter, immediately give 2 ml per kg of 10% bolus. Don't stop there. You have to start continuous glucose infusion to avoid rebound hypoglycemia. The next thing is, if you are working in a setup where you can get an ionized calcium done immediately, or if your NICU is having an ABG machine, inside ABG machine, do a blood gas, see ionized calcium. If the ionized calcium is less than 0.2 millimole, then you have to give ionized calcium bolus only under cardiac monitoring and slowly. If the baby is not responding to calcium, then you may have to give magnesium sulfate also. Our baby's glucose was 68 and calcium was 1.2, which was very well in the normal range, then I had to think of giving anticonvulsant, which is the first anticonvulsant of choice. It is always phenobarbital. Now also it is phenobarbital. The loading dose, we all know, 20 milligram per kilogram, slowly over IV, over 15 minutes. After 15 minutes also, this baby was having recurrent seizure. So I had to go up top of the bolus. I had to go to the maximum dose of 40 milligram per kilogram. At that point, once you go higher on the phenobarbital, you have to be very careful about respiratory pattern of the baby, because respiratory depression is a very known complication of phenobarbital. Again, the seizure was not controlled. I had to give phenytoin, phosphenitoin. I preferred phosphenitoin over phenytoin because the side effect profile of phosphenitoin is much less compared to phenytoin. With the first dose of phenytoin, baby's seizure was controlled. Otherwise, I had to go for higher doses of phenytoin and think about alternative drugs. Next thing, seizure is a disease where the treatment and investigation had to go hand in hand. Two investigations I want to highlight. As I have already mentioned, blood glucose. You never want to miss a hypoglycemia or lately diagnose a hypoglycemia. It can have devastating effect. Second thing is CSF examination. Any periodic seizure, you should do a CSF examination without delay, because seizure may be the first sign of meningitis. Along with that, other investigations, electrolytes, the work septic workup, cranial ultrasound to be done, and do an EEG also. If you are not attaining a clue with these investigations, you have to go to the next level of investigation, like serum magnesium, do an arterial blood gas, see for anion gap, a complete workup for IEM, and further imaging. I would rather prefer MRI than CT because of the radiation risk, and other MRI yields more results. Now, coming to anti-epileptic drug. Should we give anti-epileptic drug to all seizures? What WHO says is, if there is clinically apparent seizure, which lasts for more than 3 minutes, or if there is brief seizure, recurrent seizure, you have to treat. And all electrical seizures, even in the absence of clinical seizure, you have to treat. Clinical observations sometimes grossly underestimate or overestimate electrical seizures. So ideally, a continuous EEG should be done for seizure risk patients, and especially if you have started baby on anti-epileptic, because sometimes clinical seizure may be controlled, but electrical activity may not be controlled. But it is not universally available. You may not be able to do continuous EEG in all babies. So for me, practically the CNMO staff may be the continuous monitoring machine. So our baby is currently on phenobarbital and phenytoin. When should your anti-epileptic drugs be discontinued? So every day we will be seeing the baby. If the baby is seizure-free for 72 hours, if the baby is having a normal neurological examination, the EEG is normal, and the imaging is not showing any major issues, so that the baby has chance of recurrence. If the chance of recurrence is less, we can very well stop anticonvulsant. This baby is on phenobarbital and phenytoin. So first I will be stopping phenytoin, then see for any recurrence of seizure, then I will stop phenobarbital, because the policy is last in and first out policy, and phenobarbital is the drug to be stopped last. Coming to the anti-epileptic, commonly used anti-epileptic drug, still phenobarbital is the gold standard. The efficacy of phenobarbital with 20 milligram per kilogram is 40%, and when you go to the maximum dosage, it attains 70%. But that is clinical control of seizure. But if you see EEG control, it is only 40%. The EEG control is seen only in 40%. Though said to be gold standard, it has got its own concern. I'm not going into the theory part, but the clinical problem issue is, whenever you are giving phenobarbital, sometimes it was incomplete response is seen, and sometimes even worsening of seizure is seen. And another issue is, currently used, not only phenobarbital, currently commonly used anti-epileptic drug, whether it is phenobarbital, phenytoin, or diazepam, or currently used anticonvulsant except levetiracetam and tropinamide, has shown to have neurotoxicity. It may cause apoptosis. So I want to stop my anticonvulsant at the earliest. The second line anticonvulsant is phenytoin. I have already said fosphenytoin is preferred because of the less side effect profile. And currently, levetiracetam is attaining more acceptance, and a lot of NICUs are using levetiracetam. I am not going into the theory part. It reduces the neurotransmitter release. It is basically used as an add-on therapy to phenobarbital. Certain studies have shown it may be used as monotherapy. But if you say, compare which is better efficacy, phenobarbital or levetiracetam, the answer is definitely phenobarbital. Then why we are preferring levetiracetam in certain ICUs is just because it has got lesser side effects. We will just go through certain empiric situations. The worst scenario, you are stuck up in an NICU, in a place where you can't do a this GRBS measurement. Will you give empiric 10% dextrose to a baby coming with convulsion? Definitely I will go, because I will give 10% dextrose because hypoglycemia is more dangerous than hyperglycemia. Whether the same thing applies to hypocalcemia also? No, because IV calcium is associated with serious side effects like asystole and skin necrosis, as well as there is no evidence from trial to support or reject empiric treatment. So I would rather do a serum calcium or ionized calcium measurement before treating for hypocalcemia. Now coming to another scenario, meningitis. Will you give empiric antibiotic? No, I will definitely do an LP before starting antibiotic. But certain situations demands it, like baby is hemodynamically unstable and not fit for LP. So if the baby's platelet count is less than 1 lakh or 40,000, suppose it is 40,000, you may first stabilize the baby, correct this stage, and later do this CSF analysis. Now coming to pyridoxine-dependent epilepsy, it's very, very rare condition. It may be used as a last resort, or if two anticonvulsants are not working, then you may give pyridoxine. You may give, I'm not going into the much details because of the lack of time. Now this is just a flow chart to show how to stop anticonvulsant. Baby is on anticonvulsant therapy. All anti-epileptic drugs except phenobarbital once seizure is controlled. Perform a new neurological examination before discharge. Do an EEG and imaging as usual. If the neurological examination is normal, you can stop phenobarbital before discharge. If the neurological examination is abnormal, or if the EEG is abnormal, or if the MRI, if the imaging shows that a major abnormality and chance of recurrence is high, continue phenobarbital for 1 month. Repeat neurological examination. If it is normal, taper the drug over next 2 weeks. If the neurological examination is abnormal, then also you can do an EEG. And if the EEG is normal, then you can taper the drug over the next 2 weeks. If the neurological examination and EEG is abnormal, you may continue the drug for 3 months and reassess the baby after 3 months. There was a practice of giving anti-epileptic drug for severe HAE patient. Is it prudent to give? The answer is a big no. You should never give anticonvulsant as a prophylactic drug. Now coming to the imaging modality, all babies with a seizure should have a neurosonogram done. Definitely one neurosonogram should be done. Once the baby is stabilized, I would rather skip a CT for MRI. When is MRI indicated? If the no cause is identified and seizure is resistant to the usual anti-epileptic drug, then you have to do an MRI. MRI diagnoses the bleeding disorders as well as developmental migrational disorders and developmental abnormalities of brain. What is the role of EEG? Now, ideally, all babies at risk of seizure or babies having seizure should have a continuous EEG, which is not practically available in all centers, because a trained person should be there to read EEG, and minimum 1 hour EEG is stated to say ideally continuous at least 1 hour. So it may not be available in all situations. So maybe not ideal, but standard method now followed is clinical to be right. But whenever available, all clinical seizures should be confirmed by an EEG. Coming to a newer modality, AEG, which is not universally available, but what it does, it makes EEG reading very. Thank you. I will finish in time. Thank you. So, continuous EEG or amplitude integrated EEG, it makes the EEG reading very simple. And it may be used in ICUs where you are having a doubt whether to cool the baby or not. This continuous EEG can help you. This baby is developing subtle seizure. You can cool the baby. Next is by cooling baby, you can do a continuous EEG monitoring. This amplitude integrated EEG monitoring to prognosticate, then also to subtle seizure will be picked. But I want to tell one more thing, that for cooling, this amplitude integrated EEG is not a must. You can very well cool the baby without this amplitude integrated EEG also. Thank you for patient listening.
Thank you, Nelvi, for that wonderful talk. Only one thing which I would like to say here is, he was saying about the calcium. He just mentioned that briefly, but if you are giving calcium, make sure that you have a very good IV line. Otherwise, it can cause extensive skin necrosis, and you will land up in Giridhar's talk. So I think. Mohandas, can I ask the questions?
Yes.
Yeah. Right. The first question is to Dr. Giridhar. Now,
yes, sir.
Can you stop sharing the screen, Nelby? Nelby, are you there? Nelby?
Yes, sir. 1 minute.
Okay.
Yes, sir.
Okay. If the ophthalmologist miss retinopathy of prematurity, is the neonatologist responsible?
Am I audible, sir?
Yeah, you are audible.
Yes, sir. Yeah, I think because the responsibility, that is the vicarious responsibility, actually comes into effect only when the person who's under us is under a direct supervision. Here we have one more specialist, that is the ophthalmologist. He is actually an expert. He is expected to see identify ROP and treat it if it is there. So our responsibility here is only referring the patient. If the patient fits a particular guideline for ROP screening to the ophthalmologist for ROP care. So we are not liable at this point of time, sir. Hello.
Okay, there is another question to Dr. Nelby. Is an EEG is a must to stop the anticonvulsants? Without EEG, are you going to miss electrical seizure?
Sir, as I mentioned previously, if you see this phenobarbital, the clinical seizure may be, if you, as the first line phenobarbital, if you are giving phenobarbital, clinical seizure may not be apparent, will be controlled, but electrical seizure may not be controlled. So ideally, we should see an EEG before stopping. Ideally, EEG should be done before stopping.
If the facility is available, it is available. But if it is not there, if the baby is otherwise normal neurologically, you can get away without EEG, especially if there is no facility. Okay, thank you all for the wonderful session. We are running short of time, so we are closing this session. Thank you.
Thank you very much. Thank you.
So by now, we have already done with 2 excellent sessions, and now moving on to the 3rd session for today, and that is on birth asphyxia. And for the same, to introduce the speakers, I invite Dr. V.C. Manoj, who is HOD of Neonatology at Jubilee Mission Medical College, Thrissur, and he's the National Executive Member, NNF, and National Executive Member, South Zone of Neonatology Chapter, IAP. Over to you, Manoj, sir.
Thank you, Arya, for the kind words. Am I audible?
Yes.
At that outset, let me thank my NNF Kerala family for having asked me to play, actually not only introduce, but to play a host for this session on the occasion of our prestigious conference MidNeocon organized by Team Alappuzha. Friends, I am honored today to interview two stalwarts of neonatology who are both very good friends of mine as well, Professor Niranjan Thomas and Professor Mangala Bharati, on a hot topic in neonatology in India now. How should I manage perinatal asphyxia post-HELIX trial? Hi Niranjan, thank you for joining us all the way from Melbourne, Australia. We are really truly honored to have you with us.
Thank you, Manoj. Glad to be here. Always a privilege.
Hi Mangala, thank you so much for joining us from Chennai. That too today, the most inconvenient day for you.
Very good afternoon, sir. Good afternoon, everyone. My best wishes to the program. Thanks to MidNeocon team. Hello, Niranjan, sir.
Hi, Mangala.
All right. So, shall we initiate the interview or discussion or whatever you want to call it?
Yeah, please go. Already it's raining a lot in Chennai, sir.
I'm not sure whether I'll rise up to the expectation of Niranjan, because when I said you have a dialogue between each other, he suggested, why don't you do it in coffee with Karan style and interview both of us? I'll try to, it won't be in that format, but then probably we will just have a chat. So let's, before that, actually, as is customary, actually, I should be introducing in a more elegant manner. So let me just share your CVs.
Manoj, most of them know both of us, so you may be able to continue if you're finding it difficult to share your screen. It doesn't matter.
Yeah, we can proceed, sir. We need not just this.
Yes.
Yeah. I'm okay. Yeah, I'm able to. Yeah. So, friends, why are we having this dialogue or rather interview with these two legends? All of you know, both have been immensely working on this field, therapeutic hypothermia. Professor Niranjan Thomas, we all know, have been instrumental in developing one of the low-cost interventions that has won many awards, the Miracradle, which the face-changing material which most of us use to cool babies. And he has done enough work in this field, and unfortunately we have lost him, and it is Australia's gain when he has moved on to Melbourne from CMC Vellore. And Dr. Mangala Bharati is no less. He is again one of those the legends who is passionately following so many low-cost. He has so many low-cost interventions to his credit. Not only just, I don't want to name all of them. And then he has been involved with HELIX trial, the trial that has really evoked so much of interest. So, like, he is the right person, and I think the most balanced person to give us a balanced view on it. So, it's a proud privilege, both of you, to have you with us in this dialogue. So, with that, now let's start the discussion. Let's start with a case that you and me find most of the time in our ICUs. A 4,100 grams born at 41 weeks, a male infant, delivered by spontaneous vaginal delivery after induction through a thick meconium stain liquor at a peripheral center. Infant was unfortunately depressed at birth. There was fortunately a attending pediatrician who resuscitated the baby in the delivery room, intubated and shifted to your center. Now, Mangala, who is to blame for this asphyxia? Or in other words, what is the impact of care at birth or resuscitation and transport on the outcomes?
Yeah, thank you, sir. I think everyone will agree that this is, as you just mentioned, this is a very common scenario that we face each and every day. As you say, I was fortunate to work with a think I was working for an extramural center for quite some time, and for the past few years, I'm in an intramural center. But we face this situation in whether you are working in an extramural center or intramural or in a public or private. One of the biggest challenges that we face when we have a baby with asphyxia is when we try to identify the cause of asphyxia. So unlike the Western countries or the developed world, most of the time, all that we know is that something had gone wrong. And so hardly there will be a documented fetal distress in the form of abnormal heart rate or an abnormal fetal movement. So the so-called the sentinel event. So even if you quote the data, hardly it is somewhere around 10 to 50%. Whatever data is available from reported from even from India, the incidence of sentinel event related to birth asphyxia is only that much. That's what had happened in the HELIX trial as well. I think if I remember correct, HELIX had a sentinel event incidence of around 14% in babies who were recruited in the trial. So in the lack of a sentinel event, it's always difficult to exactly pinpoint we know that something had gone wrong, but exactly when did this happen? Is the obstetrician at fault, or is it that neonatal pediatrician, or many times we are often blamed, saying that an expert person was not available. If we had a very a senior neonatologist or a person available in the delivery room, maybe the outcome of this baby would have been better. That is always the obstetrician's viewpoint most of the time. So at the moment, all that I can say is that in a country like India, it is just like road traffic accidents. We are prone to get accidents in the delivery rooms anytime. So we should be readily prepared, and there should be a trained personnel available as care at birth is very, very important. That's more so for a high-risk delivery, but even for low-risk delivery, for any delivery, at least a health worker trained properly in neonatal resuscitation should be available at our doorsteps all the time. So it's very crucial.
Thank you, Mangala. Actually, this is not a panel, so actually, please feel free to interrupt the. Like the Niranjan, if you want to say anything, or shall we move on to the next point?
Sure. Okay.
Let's consider another case. 3,200 grams, 36 weeks, late preterm male infant of diabetic mother, born by emergency LSCS in view of absent fetal movements. Infant was resuscitated in delivery room, intubated, shifted, and was then ventilated in NICU. Subsequently, baby became stable. Now, after this case, we'll go to the top. These are two cases to introduce or sensitize the topic. So, how are we going to define HIE here, hypoxic ischemic encephalopathy, and what is the role of scoring and classifying HIE at this point?
A question to me, Manoj?
Yes, Niranjan. Yes, please feel.
Yeah, so I think
spontaneous questions, so feel free. Yes, to Niranjan, since Mangala's done the answering for the first one. Yeah.
So I think many times people confuse perinatal asphyxia with HIE, and we know that a lot of studies have shown all babies who have a low UPGAR or a low COD pH do not go on to develop encephalopathy. And especially when you're having a cooling program, it's very important, because cooling a baby, the criteria is that the baby should have moderate or severe encephalopathy. So that is the importance of defining examining and defining which baby who has suffered insult, intrapartum insult, actually go on. So about 50% do not develop encephalopathy. And so you need to filter that out, because you don't want to be cooling babies with no encephalopathy or mild encephalopathy, because you could do more harm. So I think that it is important, especially in the era that we are cooling babies, that we make an early diagnosis of HIE. Early, because definitely there is no doubt that evidence points, if you cool less than 3 hours, the outcomes are definitely better. So that is where a formal examination is very important. And there are most people would use the NICHT criteria, which is a modified Sarnath, which has six areas that you look at. And if you fulfill 3 in the moderate or severe, you say that baby has encephalopathy and would fulfill the criteria. people also use the Thompson score. So in Velo, we use both. We use the Thompson score and the Sarnath. To recruit a baby for cooling, we would use Sarnath, but to monitor, we would use the Thompson scoring, because the Thompson scoring gives you a numerical number, which actually gives you good information as to how the baby is progressing. Now, the important thing is that if you are in an intramural center, obviously it makes it much easier, because you know what has happened and you are ahead in the game. So most people would say by the end of 1 hour, you should do a good neurological examination. And at that time, if there's any criteria that fulfills moderate or severe, 3 out of the 6, you should offer therapeutic cooling if you are able to offer that, if you are an institution that does it. Now, there will be babies who are initially abnormal who will normalize, and the babies who are normal who will become worse. But so that has to be kept in the back of the mind. So quite often we have a baby who looks terrible in the first 1 hour, but end of 1 hour may be normal. So, and a baby who's normal at 1 hour who might worsen in the next few hours. So it's important that if the first neurological examination is normal, you continue to monitor the babies every hour or so. And what practice we used to have in Vellore was, what we introduced was that we have a score chart. So you have the score chart and we have hour 1, 2, 3, 4, 5, 6, and somebody examines and puts it down objectively. Having said that, some of the factors, as you know, are subjective, but it's important to be as objective of the subjective factors, if you know what I mean.
So actually, so we need to basically not only have a hypoxic event, you should have encephalopathy to cool, right? So some you, as you said, it is very subjective, and then we don't find that evidence of encephalopathy, and then baby develops seizures at say 7 hours of life or so, 6 or 7 hours of life. So have we missed the bus?
Yes, you have missed the bus, because I mean,
I would ask both of you. I mean, how did this happen, or what can we do to prevent this actually?
I think right now, what the most useful thing we have is clinical examination. And if you have the facilities, amplitude integrated EEG. These are the two things that we have right now.
We don't have EEG in most of the centers. We are not in Australia, we are in India. So probably other than EEG.
I mean, having said that, Velo has EEG. There are some centers that have EEG. So if you have it, I think that's the extra tool. And like what Nelby mentioned earlier, it is not an absolute must at all to have EEG to offer. I'm not saying it is, but it's a tool that can be used if you have it. There are other biomarkers that are going to come in soon, hopefully, but I don't think there's anything that's really been proved to be enough sensitivity and specificity to help us use that alone.
Okay.
You have to think.
I do agree with both the points. The first that in the absence of EEG, right now the only reliable tool that we have seems to be only the clinical assessment to ascertain the presence or absence of encephalopathy.
Make it objective. The clinical examination, how do you make it objective?
Yeah, yes. We also have faced this problem, what Dr. Niranjan had brought out. Even though an NICU scoring system is an objective scoring system, it's a very dynamic thing as things change over a period of time. And there was a reasonable inter-observer variability as well. So we had because the residents are the first ones who handle the babies, even trained DM residents, we found especially differentiating a mild from moderate. So differentiating moderate from severe may not be that important, because both moderate and severe are going to qualify for cooling. Even people disagree on whether it is moderate or severe, that's okay. But differentiation between mild and moderate is very crucial, because you are going to make a decision whether you are going to cool or not. So what we did in this trial, especially, we started in our center, which was later extrapolated to other centers as well. So we made sure at least 2 residents scored the NICHT score independently, and only when both the scores agreed on mild or moderate, so we went ahead, and then in case if they differ from each other, a senior person was called in and a third person had to make the scoring system. So
what do you suggest to? There are so many practicing physicians in this group. So what do you suggest to them? How do you make it very objective?
as of now, all that we can do is to have a rather than trying to have the score in your mind where you are prone to make errors. Obviously, it has to be a pro forma form where everything has to be scored in a circle and it is very crystal clear, so that you remain objective. Maybe I think if you have an it may be a luxury in certain settings. I'm sure if you have an option of a second clinician doing an assessment, whoever it is, maybe your resident or your colleague, whatever it is. So involving them and asking them to make another independent assessment on the form might help. These are the two things that come to my mind, sir. I'm not sure how far we can, how more objective we can make the assessment of encephalopathy right now.
Yeah, I think putting it down on paper helps. Putting it down formally on paper really helps. And also sensorium, there are some of the, out of the 6 scores, some of them are a little difficult to assess, a lot of variability. But one thing is the sensorium is, I think, reasonably good a marker, as is the tone, especially if you have not given any medications that can depress it. Whereas the autonomic and the reflexes are not, it's much more subjective.
Since you already mentioned...
Sorry to interrupt, sir. One more thing which helps here is always the seizures, especially when you have early onset seizures.
Yeah.
Because whenever a baby had thrown seizures, we had always classified it either as mild or severe. So it can never be a mild HIE or a baby throwing seizure. So if you are sure that the baby had a seizure at that time, you know that you are dealing with either a moderate or severe encephalopathy.
Great. So now, since we are at this, now let me ask Niranjan, like you mentioned something about the biomarkers which are coming up. Can you just, I mean, something that is in the nearby horizon, anything coming up, or they are still a dream?
I think there are a few. So in Vellore, we are looking at urinary biomarkers. I can't say we were. And I think we are looking at some like GFAP for the melatonin fractions. But I'm not sure that we have reached a stage that we should be able to offer it. So one of the projects that is finished, we've collected the samples, are salivary, looking at salivary factors. So you can, the dream is that you have a bedside rest, you put a filter paper in the mouth, put into a handheld machine, and that gives you what the level is. And that should be, that's a dream. But we have collected the samples, but we haven't finished the assessment yet.
I'm sure, no, like with people like you, the dreams will come true, because I know how you struggle to get PCM into an option for therapeutic hypothermia. So let's see. But as of now, nothing in the horizon, isn't it? Nothing in the horizon. Okay, so there are no biomarkers. We need to still rely on our clinical skills, have some scoring system, and then decide and take the call finally. So can you err on the side of cooling mild HIE because of the, if you, I mean, the otherwise it's a costly mistake. Is that okay, or we should not do that?
I can put on an Australia hat and say that yes, you can, in the sense that the benefit. So there is more evidence coming that the outcomes for mild HIE is not as good as we used to think. And if you are able to provide safe cooling, so if the safety of the cooling procedure is well established, that's the difference. So if I'm sitting in Australia, if you have the doubt, you give the benefit of the doubt. If we have an AEG machine, you can put it on just to help you confirm. Those are the things that you have extra. If you're in a situation where the cooling is causing just the factor that you're going to cool a baby is going to cause more harm, then I wouldn't do it.
Mangala, anything you want to say?
I was about to ask this question to Dr. Niranjan as well, because he was in Australia. So I think we are more about only learning more by reading through papers what is happening in the developed nations about use of cooling for mild HIE. And we know that actually people are reporting even up to 25% of some handicaps, even in children with mild encephalopathy. Obviously, it seems to be a very important area. So, but how do you actually do it, sir? The only major concern for us is that babies who may show some mild encephalopathy in an hour or two, many times by the time they reach 5 or 6 hours, they may turn into no encephalopathy. That's what we commonly see. So, unlike the other group, so do you wait for 6 hours, or when do you actually make a decision that, okay, this is mild, this is not turning into no, and take a call whether to cool or not in mild encephalopathy?
So the fact is that we don't cool mild encephalopathy. But most of the time, the babies who are cooled are actually misclassified as moderate when actually they're mild. So what happens is that when at 1 hour of age, if there is a doubt, like you have, like you said, two clinicians looking at it, and there's a doubt about it, we would err in the fact of cooling rather than not cooling, rather than wait for some more time. Because I think there is good evidence to show that the earlier you cool, the outcomes are better. So when you are running a cooling program and you have confidence that it is a good program, then you give the benefit of the doubt. It's not that if you definitely is mild HIE, no, you won't cool. That's not part of our protocol.
All right. So still some vagueness in this as well as the take-home message is there. Let me just quickly go on to HELIX trial. Now,
Manoj, sir?
Yeah.
Sir, actually the time is almost up.
No, 45 minutes, no? Give me 5 more minutes. Let me just get the gist of it, please. In implications of HELIX trial, no, I know that both of you are having like a very balanced view, but I will just, for the sake of argument, I will just ask you in a particular way. Mangala, why should it change your practice? And I will ask Niranjan, why you should not change your practice? I know that both of you have a balanced view about it, but just for the sake of argument.
Yeah, thank you, sir. We started HELIX actually with an intention of trying to prove that cooling works even in LAMC. So that was the hypothesis and that was the intention. But I should admit that we were taken aback looking at the results, what we had at the end of the trial. Not showing significant difference in the primary outcomes is the combined outcome of death or disability at 18 months, and also resulting in more deaths overall, the cooling. So I think we tried to look into the various reasons why this could have been different. We couldn't find any, even on introspection, the equipment used, we were fairly confident that we were using the right equipment. And we also did some introspection about whether we have administered this intervention in the right way. And again, we are pretty sure that the intervention was administered in the best possible way in the given setting. That's what I can say. It may not, I won't say it is as comparable as the setting in the West, but in our settings, the best possible way this intervention has been administered. So there is I'll finish that quickly. So we have a strong doubt that whether definitely are we dealing with, as not much of work has happened in the developing countries in this area. Are there significant population characteristics which are unique to countries, LMICs, and the countries like India? Is our population definitely different from, as MRI also showed, more of white matter injuries, more than 70% of them having injuries, more like a subacute rather than acute forms of injury. So again, to be honest, in my center, I have not started cooling again. So after the HELIX trial, I'm here to start cooling. So we are still debating, okay, how do we tease out that, okay, are we now in a state where we need to pick up subgroups? Okay, it might help this population, may not help that population. If so, how do we pick up? All these questions are running in my mind right now, sir. But I'm just there. I'm not able to either advocate nor say we should not be cooling. This is really does put us into a fix for the results what we have shown at this point.
We echoed the sentiments of most of the centers which do cooling, and actually now thankfully National Neonatology Forum is coming out with a position paper. Next week it is going to be released, so hopefully in maybe another 10-15 days it is going to be released. So probably we will have some guidelines to fall back on. Dr. Niranjan, your take on this. We need to wind up soon, so please be brief.
Yeah. So will it change my practice? Obviously not, because we've been doing this in Vellore. I'm talking in the sense if I was still in Vellore. So we've been doing this from 2009. So why? So if you look at it, like if Mangala said about the MRI. So when we did the thin study, so that is the other randomized study that we had done, looking at MRI markers, we found that the white matter, the basal stem thalamic insults were there in 75% of the patients. And it was not like, it was very similar to the other trials that have been done in the West, which is just different from what the HELIX showed. But if you look at the HELIX carefully, what it is about 30% of the babies died before they reached MRI. So that is a large amount of babies that you don't have MRI, so you don't know. Whereas in thin study, 92 babies, then 92% had MRIs. The second thing is that if you look at the median date at which MRI was done in the HELIX study, the median date was 15 days. So again, if you look at the fractional anisotropy research that they have presented saying there's no difference, and the MRS and FA will pseudo-normalize by end of 7 to 10 days. So if you're doing your MRI so late, your conventional will not change, but your other things will change. And in the thin study, there was a significant difference in conventional and in fractional anisotropy, the brain atlas or what we looked at. So that is one. So I'm not that the argument that the MRI findings subacute does not really help me that much, because of the fact that 1/3 of the babies died before they got MRI. There's a lot of bias there. The second is the fact about the population. So the thing is that if you can't generalize, I mean, I know the institutions that have done the trial of public hospitals, they're under tremendous pressure. They did a fantastic job, no doubt about it. To run this trial in India in public hospital is hats off to the team who did it. But that's a very different population. That 70% of them were babies who were retrieved from outside. So that comes back to your first question, outborn versus inborn. We know that it's not only the question of was the diagnosis of HIE correct. It might, a baby who, so CMC was the first one, actually, we put this pragmatic definition for outborn babies, that instead of connecting intrapartum to HIE, connect HIE backwards to intrapartum. So if you have a baby with abnormal neurology, look back and see, was there any events? The baby did not cry. So all these parameters, 5 minutes of the baby not having cried at birth, all have been taken from what we brought out. So if you look at that outbound population, it is not the question whether they had HIE or not. The problem is the initial stabilization, the transport, all this makes a lot of difference in the outcome. So that's again, when you have I know that is what most centers in India would face this. A majority of babies coming in with HIE for cooling would be outborn. So yes, that in that way, the population is similar. But that doesn't mean that other centers who have a good perinatal care, a different kind of setup, you cannot translate and say that because HELIX did not show improvement, you cannot do cooling, because the setting is very different. The setting depends on how much of antenatal care you had, the socioeconomic status, whether inborn or outborn, what level of IC you have. So whatever said and done, public hospitals, the intensive care monitoring, the invasive monitoring, I think will not reach the standards of some good NICUs in India. So that's the other point, that why I think that HELIX cannot be extrapolated to all centers in India. Yes, if you have public hospital centers that have mainly outborn babies, it might work. But the population, the argument that the population is different because of the MRI differences, I don't think there's enough data on that.
Thank you, Niranjan. Can I ask Pramita how much time more we have? So accordingly, Pramita?
Sir, 10 more minutes, sir.
Oh, great. Thank you. So then if we have 10 more minutes, so now I would now go on to, okay, Mangala, you want to say, add on anything in this, and then we'll go on to the next question.
I think fully agree with Niranjan's views on, I'm not an expert in neuroimaging, but the reasons were actually different as far as, because we were told by experts in neuroimaging who handle the neuroimaging that the kind of data, what we are looking at, the sequences, what they had made, extremely similar. So, sorry, am I audible, sir?
Yeah, you are. Please go ahead.
Yeah, so the kind of
seem to be losing.
Mangala,
are you there? Okay, then by the time he comes back, Narendra, what is now going to be your prediction about the medico-legal implications of HELIX trial? Of course, I said that NNF is coming out with a position paper. A lot may depend on that. Apart from that, what is going to be the medico-legal implication of HELIX trial?
So if you, so the good thing is that people have reacted to the Indian Journal of Pediatrics article. So you have about 10 letters to the editors. So that is enough argument against it. Second, we have, I've written a letter to the Lancet also with the arguments against that, and that should be published on the 16th of November. And there are other people who have also written to the Lancet about it, the fact that it cannot be extrapolated. We have the thin study. We have multiple studies from JIPMA, and we have the meta-analysis from the LMICs that show that the mortality actually decreases. So based on one trial with so much bias, the other thing that I have about the HELIX is also the fact that the mortality rate in the cooled arm was so high. So that is not what we see people who cool see. So I think medico-legally, if NNF, especially if NNF comes out to the position paper, you have enough other evidence to counter that. So there are a lot of loopholes that can be countered. Yeah.
I am actually part of that position paper committee, but I am not allowed to divulge anything before it's officially released. So I will keep quiet on that. And Mangala, now what is your take on the medico-legal implications of HELIX trial? Leave the NNF position paper, which will come out in 2 weeks, but other than that.
I totally, I'm very sure that we cannot call it as, what to say, unethical, or we can't totally stop pulling across India. I don't have that view, definitely. But as already pointed out and brought out well, so I'll say more than 90% of the load of HIE, and especially moderate and severe HIE, is in public health settings right now. And I'll say among the kind of public health facilities, an institution with a good ICU setting and even availability of super specialty DM postgraduates available to take care of babies around the clock. A trial with a very good sample size under controlled settings. In these settings, if a trial says that there is an increased mortality, definitely we have to be very, very careful about bringing cooling as an option in this setting, in this kind of setting. But in all public health settings, because I'm not sure whether we do have other public health settings which are better than the settings in which the trial have done in India. Whether they'll be able to excel the level of care what has been provided other public health settings, I do have definitely questions on that. Because at least in the trial mode, we tried to give our best. Rather than our usual care, the care was best. Always when research happens, the quality of care goes up. That's what happened during HELIX also. But the second part is that we also do both intramural and extramural. We do get a lot of intramural with the central events, and we are also working in private settings. Now it's a challenge for both the settings. That means even in private settings, you do get babies being referred from public settings hospital, delivered at public settings hospital, not given enough care. And we all know the care of transport right now. So at least even in Tamil Nadu, most of these babies were transported by an exclusive neonatal transport system, which at least had some personnel trained in neonatal transport. But we can imagine the rest of the states and the kind of neonatal transport facilities available, for stabilization at the time of birth. So we should focus there to improve all those things. But I'm looking forward to, I think task force has got an enormous challenge before it, because we have to draw the line again. So because all the settings have got to cater to mixed populations, whether it is a public setting or a private. Even in public, we do get intramural with clear-cut central events, which are like, so very unlikely to have a chronic kind of asphyxia. We know, let's say I have a baby with a cord prolapse. I know it's an acute event, documented. So everything is fine. My PG is available to pick up this baby in the labor room. Baby comes to me immediately. Should I cool this baby or not? Again, the same way in a private setting, the reverse. The private setting, they are not sure about the care at birth and transport, but they do have all the facilities. The center has got good resources and experience on cooling. But the kind of the baby is different. Should they go ahead and cool this baby? These are the difficult questions at the moment. Maybe I look forward to the expert committee's recommendations on this.
Okay, so now while we are at it, extramural, intramural, one of the attendees, consultant neonatologist, Dr. Sakir is asking, is there a subgroup analysis on inborn babies in the HELIX? Again, Mangala, followed.
Yes, sir. Subgroup analysis was done for many variables by the center. We had centers distributed across 3 countries. And then it was done for inborn, outborn. It was done for the growth status, AGA versus SGA babies. So on none of these actually subgroup analysis we were able to find any difference of outcome. So the results were the same whether it was for inborn or outborn, whether it was for an SGA baby or an AGA baby.
So before we wind up the verdict on HELIX trial, or rather I would just try to summarize the consensus between both of you and then correct me in the thing. So post HELIX trial, there has been a lot of confusion created in centers which are doing therapeutic hypothermia. One of the points I think both the
not heard.
Both the experts agree is that therapeutic hypothermia should be done in a center with adequate tertiary care facility, including all the facility for managing all the complications, including PPH and things like that. And secondly, HELIX trial is not a landmark trial to change your practice. Probably you have to have more evidence and you need to generate more evidence. Until then, you should be offering this treatment. Is this the consensus of both of you, or is there, have I understood differently? Please feel free. Both.
I'm sorry, sir. I think I'll just put it in a little different way. Almost it will be similar to. So I'm pretty sure that centers who have been doing cooling who have lots of expertise and who have published data, who have enough experience in doing that, and who are quoting anecdotally, even though they're not done randomized controlled trial, they're pretty sure about their previous results. I don't think the HELIX trial data should change their mind or practice. So because they've been doing it for some time and they're very sure, but really they do have a challenge of collating information, and then it will be very interesting to see really good data coming out of those, as because many of them remain anecdotal at the moment. On the other side, public settings with not good facilities, care at birth, and not good neonatal transport systems. Even if you do have intensive care units available with you, and you do have even people to take care these babies around the clock with state-of-the-art facilities also, I will have a second thought in bringing in cooling these settings at the moment.
Great, fair enough. Now, Niranjan, your message on this HELIX trial?
I agree with that. I mean, in the sense that people who have already been cooling and who have data to show it is safe, because I think safety is the major concern as I look at the HELIX trial. My concern is not the efficacy; it's the safety, because we have enough data from MRI and neurodevelopmental outcome, even if the numbers are small, to reassure us that it is safe and efficacious. Now, HELIX trial, the mortality rate is so high that the worry is that it is doing more harm. So then, if that is the issue, then I have concerns about it being extrapolated to centers that have a similar sort of setting. So if I agree with Mangala that those who are cooling, who already have established cooling protocol, who have follow-up, who have demonstrated safety, then they should not stop cooling. Right? That will be doing more harm to so many thousands of babies who could be saved.
So the question has been again asked, what are the implications of HELIX trial? I think that is what medico-legal implication. That has been what we have been trying to analyze. Now, will you take consent? The last question on this, or how should you? I mean, suppose my baby is going to be offered cooling. What are you going to tell me? Verbal consent, written consent, or just how do we go around? This, I think we'll have to wind up. This is the last question, and then we'll just take that. Yeah.
As a procedure, just like any other procedure, definitely an informed consent is taken for cooling. If I understand correct, this question is being asked from the medico-legal perspective. What kind of do we include words which protect you medico-legally given the current situation, especially about this paper? I think for that, just one large randomized controlled trial or individual opinions I don't think you don't need to worry from the medical legal perspective. So let us wait for some bodies' recommendation like NNF's question paper. So based upon the recommendations given by a national body, so we can always word our consent accordingly if necessary. That's my take on the medical legal implications.
Great. Anyway, it was a very interesting session on a very hot topic. You have done a lot of, you have brought out a lot of points, and I believe that within the span, I think we are not exceeded time if you are considering the earlier allotted 45 minutes. So we are dot on time now. Any last one sentence message from both of you before we hand over to the organizers? Final message.
Yeah, Niranjan sir.
So I guess I think it is. I've always been, as you know, very enthusiastic about cooling, and that came from experience from what we have done 10 years in Vellore, and what the effect is. We saw an effect, and if you ask any of our trainees, I mean, LV is there, Binu is there, they will tell you the difference it made. Like the clinic patients, the number of cerebral palsies is to see because of asphyxia has dropped off. It's a combination of antenatal care, intrapartum care, I agree, but definitely cooling has had a benefit, and we have shown it in our follow-up data also. We have a registry, and we have follow-up data on all these babies. So from that angle, having HELIX, there's always it's like a break to the system, and sometimes breaks are good. You know, you should not accelerate too fast also. So I think there's a time to pause, look, assess, and then go forward again.
Excellent message. Now over to Mangala.
Yes, I think almost a similar final message from me. I think right now our focus after the HELIX paper has been more revolving around one question, like whether to cool or not. I don't think that's the right approach. Let's change focus. So definitely the important question that we should be addressing right now is that, okay, so do we need to introspect? And the onus is on both sides. From the teams like HELIX to tell people, okay, why they were not able to show benefit. A lot of introspection has to happen from that side. On the other hand, definitely we are looking forward to centers who are already cooling to bring out more convincing evidence and support to say that definitely cooling is beneficial. And lots of introspection, especially related to population characteristics. That should be our focus rather than dealing on whether to cool or not. That's my final message.
Great. I don't think we could have done. Yeah. Yes.
One more thing, Manoj, is what I had been thinking of recently is the fact that, so if you look at your own data, look at your neonatal mortality rate, you look at your perinatal mortality rate, look at your HI rate. If you reached a stage where your figures are near the developed country, I think that's reasonable. Like 30 years back, the neonatal mortality rate in CMC Vellore was 15 per thousand. When I left, it had dropped to 2-3 per thousand. So that is the level at which the care is improved. Marker. So if you look at, so that's one of the questions that I would like to ask also. What is the centers that did the HELIX trial? What is their background neonatal mortality rate? What is their survival rates for babies who are not cooled? HI 28 weekers. So if that has not been achieved, then I don't think we should do more harm.
Fine. I think this discussion is. We have to stop at some point. So thank you so much. Actually, I don't think anybody could have done more justice to the balanced interpretation of HELIX trial than the two legends. And I would consider in this field, Niranjan and Mangala. So thank you so much, Professor Niranjan Thomas and Professor Mangala Bharati. And I would urge all of you to watch out for the NNF position paper, which is hopefully going to be released after 15 days. So once that comes, then probably we'll have more guidance. And then the other message, probably the final message, which was the thing, those centers who are doing cooling, you need to collect data and then do some sort of research in this field. So with this, I would close this session. Thank you so much, Niranjan and Mangala. Once again, it is really a huge privilege for us from our NNF Kerala family to have you both for this dialogue. Thank you so much. Now over to the organizers. Pramita, all yours.
Thank you, Manoj. Thank you, Manoj.
Thank you, Niranjan sir, Manoj sir. Thanks for the opportunity.
Thank you.
Thank you, Manoj sir. Thank you, Mangala sir, and thank you, Niranjan sir, for that excellent talk. Now let's move on to the next session. So we have two talks in this session. For that, let me invite the chairpersons, Dr. P.R. Jayakumar sir and Dr. Dali Sarama Maman. Dr. P.R. Jayakumar is the past Vice President IEP Kerala, President NNF Kottayam. He is the Senior Consultant Neonatologist, Medical College Hospital Kottayam. And Dr. Dali ma'am is the Professor of Pediatrics, Government Medical College Kottayam. I invite Jayakumar sir and Dali ma'am to kindly introduce the speakers and to chair the session.
Thank you, Dr. Pramita. And sorry that Professor Dali Maman, Madam was not able to come into the online because of some technical problems. So I will be here to welcome all the speakers and introduce them and the topic. So the first session of the topic is congenital adrenal hyperplasia. Currently, the screening for that is going on in the state of Kerala for the last many years, and we are having enough data related to the classical type, and those which are presenting with the high 17-hydroxyprogesterone. And of course, some of the cases may be missed even when there is universal screening. Typical cases or those cases where the non-classical presentation is there. And so high index of suspicion is necessary on the part of neonatologists as well as pediatrician to diagnose it early. So we are having a good weapon for treating this condition if it is started earlier, and can avoid many complications associated with this. And many countries are now having and coming up with the antenatal screening and diagnosis and antenatal interventions using steroids. And so how far we have gone into that in our country is not well known. And coming to the presentation, and we have got the right person to present the topic with us, Dr. Riyasai, well known to the NNF as well as IAP fraternity, and he was the president. He is the president, currently the president nominee, and was the dynamic secretary of IAP before, and he was the national executive board member of IAP many times, and he's having postdoctoral fellowship in pediatric and adolescent endocrinology, and is also the active member of the chapter, and has contributed a lot of chapters to many textbooks related to pediatric as well as adolescent endocrinology. And over to Dr. Riaz to present the topic.
Thank you, sir, for all those nice words. Shall I share the screen, sir?
Sure, sure.
So as this is a very short session, we will just discuss one case, and then we will go for the details. So this is about a case of undescended testis, which was brought to the emergency room. So a 2 weeks old male newborn is brought with the history of acute onset of not feeding well, and the baby was having cold extremities. The capillary fill time was prolonged, and there was tachycardia. So a clinical diagnosis of sepsis with shock was made, and fluid boluses and antibiotics were started in the emergency room. And while making the detailed evaluation, actually the resident there found out that there is something abnormal with the genitalia. So actually it was while trying for catheterization, like as the child was having septic shock, so he found that the genitalia is atypical, and the baby was actually having a small phallus with a cody. Cody means this ventral curving of the phallus, and a penoscrotal hypospadiasis. The labioscrotal folds were empty, and as the gonads were not palpable. So this is actually a very important area all of us should focus on. So this, when a baby is born, the examination of genitalia is so important. So this baby was actually described as a baby who is having undescended testis with hypospadiasis and was discharged. So whenever we see a case of undescended testis at the time of birth, we should very carefully look at where the meatus is. If it is a true case of undescended testis, the meatus, the urinary meatus will be at the tip of the penis. If there is a hypospadiasis associated with the undescended testis, always be suspicious. It could be a 46XX DSD, where the hypospadiasis, which we think is actually an enlarged clitoris because of the androgenization. And actually, this baby would have died at home. Somehow they reached the hospital and we were able to save that baby. So focusing again on the examination of genitalia at the time of birth. And it will be very unlikely any other doctor examine the genitalia during the well baby visit. So examination at the time of birth and noting or looking for a hypospadiasis is very important. So this is a case of the CAH in salt losing crisis. So it gave us the correct diagnosis. It changed the line of management. Apart from what we were giving, the antibiotics as well as fluids, we also started the definitive treatment, that is steroids after taking the samples. And the correct diagnosis as well as the correct management saved this baby. So whenever a baby is brought, a baby who is suspected to have congenital adrenal hyperplasia is brought in emergency, our treatment is a newborn baby. Our treatment is always hydrocodone stat 25 milligram, followed by 10 milligram 8th hourly. And then along with that IV fluid according to the severity of the shock. To look for hypoglycemia, a 10% dextrose may be needed in some. Look at the electrolytes. There can be severe hyponatremia as well as hyperkalemia, which can actually cause life-threatening arrhythmias. And this particular baby improved, shock was corrected, and the electrolytes reports came as 123 and potassium was 7.5. ECG was also confirming the presence of hyperkalemia, which improved with treatment. And we discharged the baby on tapering doses of hydrocodone with a maintenance dose of 1.25 milligram 3 times daily. And that is another point. The choice for hydrocortisone in the newborn baby or even in any child who is growing is hydrocortisone, and it is not prednisolone or Dexona. And the hydrocortisone tablets are now available at the strengths of 5 milligram and 10 milligram. Initially, it was available only for 20. And the dose is for the newborn, it's usually 1.25 milligram, that is 1/4 the tablet 3 times a day. And giving 3 times is very important. And also Fludricort was started at a dose of 150 microgram daily. And the dose of Fludricort is actually 100 to 150 microgram. Maybe some babies in the initial period may require up to 200 microgram daily. And there is no need of splitting the dose of Fludricort. It can be given as a once daily dose. And more important is in a breastfed baby, it is always important to supplement the baby with salt also. And this salt again, usually the baby will need almost maybe the 1 gram of salt every day. So we can actually use the table salt itself, that is 5 gram, that is one spoon can be diluted, and it can be kept for 5 days, and we can give it 1 ml, like 5 ml is 5 gram, means 1 ml can be given in a day, which is along with the given along with the breast milk. And the beauty of treating CAH is actually with medical management alone, the genitalia will improve like anything. If you are following up properly and the treatment is being done, the phallic size will come down, the scrotalization of the labia will disappear, and the appearance of genitalia will improve so much so that we will doubt whether we need to intervene with a surgery in the neonatal period, or can we wait till the baby is a little more grown up, even during the adolescent age. And whenever we examine an atypic genitalia, be careful. Don't miss a child with virilized genitalia, thinking that this is a baby boy with undescended testes. So maintenance treatment is with hydrocortisone tablet. The dose is actually 10 to 15 milligram per meter square. That will come around 1.25 milligram thrice daily for a newborn, which may be increased according to as the child grows. And the sodium chloride supplement also have already explained. And whenever there is a stress, we need to increase the dose directly for any baby who is having shock. For a newborn baby, the dose is 25. For young children, it is actually 50, and older children, that is who are more than 12 years, the dose is actually 100. So 25, 50, and 100, remember. And this hydrocortisone, if you are giving stat first dose, then followed by the same dose, in total same dose, it can be given the 6th hourly or 8th hourly for next 24 to 48 hours, and then we can rapidly taper to the normal maintenance dose. The same with if you are giving orally also. So some children, when there is fever, we have to advise them, we have to give in writing in the follow-up book that whenever this baby comes with an acute illness, don't forget to double the dose of hydrocortisone. There is no need of doubling the dose of fluorocortisone, but the hydrocortisone dose should be doubled. And this doubling can be given for maximum 2 or 3 days. There is no need of giving the higher dose for a long time, but after that we can directly go back to the normal dose given. And if the child is vomiting, don't wait the baby to get dehydrated. Always give a parenteral dose of steroid. And this is one picture which can very easily explain what is happening here. So here what happens is because of as there is a block somewhere in the system, that is we know that all the adrenal hormones, the source is actually cholesterol, and from cholesterol when the adrenal hormones hello, can you hear me?
Yes, sir.
Hello.
Yes, you are audible.
Sir, welcome, sir. Yes, sir, we can hear you.
1 minute. I think the slide has gone.
Can continue, Dr. Riaz?
One minute. I think the slide has gone. 1 minute. Please wait. Hello. Now can you see the slides?
Yeah.
Yes. Okay. So like looking at the actual what you call that hormone graph for the flow chart, it looks very difficult to understand. So like from the cholesterol, it goes to pregnenolone, from the progesterone, then deoxycorticosterone, corticosterone. So all this looks very difficult to understand. But if you explain to the parent in a much better way that all the adrenal hormones are produced from cholesterol under the action of the pituitary hormone ACTH, when there is a block below and the cortisol as well as the salt retaining hormone aldosterone are not produced, there is an excess of androgen coming into the system, and that is the reason the child get a virilized genitalia or the increase in the phallic size, as well as the increase in the ACTH is producing the hyperpigmentation. And the treatment here is we are replacing the deficient steroid hormones where cortisol is the life-saving hormone as well as the aldosterone, which is the salt retaining hormone. So these two hormones are being given from outside, and this actually reduces the push on the cholesterol by ACTH, thus reducing the production of androgen, and the appearance of the genitalia as well as the pigmentation improves. So this we can very well explain to the parents, and they will be happy to continue the medication without any complaints problem. And we should, in the first day itself, we should tell them that the treatment is not for improving the appearance of the genitalia, it is for saving the life. Cortisol is a life-saving drug and it should not be discontinued under any circumstance. And actually this androgen excess results in the hallmark finding of the disorder, which is early virilization and genital ambiguity in the female infant. But remember, the problem here is with clinical diagnosis, we won't be able to identify all CAH because the hyperandrogenic effects in the male are not seen during the birth. It actually appears very late, maybe by 1.5 to 2 years only it is going to appear. So we may miss cases. See, this child was brought to us. This is a 4-year-old child who is brought with some muscular appearance as well as hyperpigmentation. This is another 4-year-old child for comparison. And this child was brought up as a boy till 4 years of age. And when you examine the genitalia, you can see that it looks like a typical male genitalia. There is scrotum, but which is empty, fully fused scrotum with a hypospadiasis. Looks like a penis. But actually, this is a girl child who is having CAH, which was the non-salt losing variety. So fortunately, the child doesn't went for a salt losing crisis or had any complication. But now the problem is now the sex reassignment will be very difficult. So for identifying both females as well as males with CAH, the only way what we can do is the newborn screening. So in our state also, we have started doing newborn screening for the last more than 5 years now. And we can see that this is the cutoffs which we use, and we should be familiar with the cutoff. The cutoff is different for different age groups. For low birth weight babies, up to 100 we take as normal. 100 to 149, these all values are in nanogram per ml. 100 to 149 we take equivocal, and more than 150 we take as positive screen. And for all the other babies, we take this more than 12 hours because our sample is being taken at after 48 hours only. So the cutoff here is less than 65 we take as normal, 65 to 89 equivocal, and more than 90 nanogram per ml. Having said this, we have identified around 350 cases of congenital hypothyroidism by doing the newborn screening. And our detection rate is something like 1,200 per 1 in 1,200 or something. So that is quite similar to other centers or other states in the country or other countries in the world. But when we come to CAH, our detection rate is less really. This may be because with this our 17-OHP values actually change drastically in the initial days of life. So very recently, there was some communication from the US where they have made a new criteria for CAH classification. This was published in 2020 July, and what they are using is a two-tier screening. Two-tier screening means they do a cutoff. They have different cutoffs for different age groups, and they do one screening from the cord blood and another screening they do after 10 days, that is after the first week of life. And the interesting finding is 25% of the children with CAH were identified on the second screen after the first week of life. So do we need to change our practice? We don't know. Like Jagama was telling initially, these milder cases we can miss in the initial screen, but for any newborn screening, milder cases may be missed, the screen sensitivity, according to the screen sensitivity. But here, what is more important is if we are not doing a second tier screen for a CAH baby who is male, this particular baby may crash and land in our hospital, and we may even lose the baby. So there should be some thinking that should we do a second tier screening for all babies? The practicality we have to think about. But now people are telling, or studies are coming up, that doing the initial screen after 48 hours or 72 hours may not help us to identify all the babies with CAH. So with that, I stop, and I can take questions. Thanks for your patient listening.
Thank you, Dr. Riaz, for the excellent presentation in a short time. And the message is very clear. Whenever we are coming with an abnormal genitalia, electrolyte imbalance or virilization, high suspicion should be there, and evaluate and refer to the pediatric endocrinologist, so that we need not miss the cases. And also the acute presentation, we can save, we can reduce mortality. So hope that no questions are there in the chat box, so we can go directly to the next session.
Sir,
okay, thank you, Riaz, once again.
So there is one question, I think. How early we can see adrenal crisis? Textbook says after 5 to 7 days. That is true, because usually the crisis occur well into the first week. That is the problem, because even if you monitor the baby for a few days in our NICU or in the ward, we may not be able to identify the crisis. So for all borderline values of 17 OHP, it is always prudent to repeat it after 1 week, or maybe repeat again after 2 weeks, like that. If it is true CAH, the 17 OHP value will increase when the child is growing forward. Otherwise, it will come down to normal. So that way we
Okay, Dr. Riaz, are you aware of the antenatal screening for adrenal hyperplasia anywhere else, and the data related to that, and intervention using dexamethasone and all?
Actually, now that practice has been stopped in a routine basis. Because by giving dexamethasone to mother, they have identified many adverse events both in the mother as well as some intellectual disability and some other problems in the babies who were unnecessarily treated. Because for the benefit of one baby who is affected, we may be treating 7 babies who are actually not needed to treat.
Also, amniocentesis is necessary.
Yes, and now the dictum is to do that experimental therapy only as part of an RCT. So in the individual centers, we are not permitted to do that. Thank you.
Thank you, Riaz. And next topic and presenter is well known and need no formal introduction. Still, for the formality, I am going to the topic, and that is related to the pandemic COVID situation, the setting, and the impact of it on the newborn. And initially, we thought that the least affected group is the antenatal women and neonates. and especially the first wave, it was true. And the second wave, some rise of mortality among the antenatal women has been observed, and symptomatic newborn occasional reports came into the scene. And we were initially thinking about the pandemic H1N1, where the mortality of among antenatal women was as high as 30% compared to 1% in the general population. But fortunately, that type of a degree of involvement was not there. And now we are almost coming to the concluding, probably, the session of the pandemic situation, and the full data almost available in from many countries. And from the very beginning, Dr. Manoj was keenly observing the data and making interpretations regarding that. And he is the right person to deal about the final verdict related to the impact of this situation on newborn. And coming to Dr. Manoj, who is the head of the Department of Neonatology, Jubilee Mission Medical College and Research Institute, Thrissur, and he has published many papers, research papers in international national journals, and also has contributed chapters to many textbooks of neonatology. And he is the academic coordinator of advanced NRP of NNF, and also was the coordinator of NSSK, and the course coordinator and research guide of postdoctoral fellowship of fellowship programs for doctors and nurses, and a national executive member of NNF, as well as IAP Neonatology chapter, and also was the president of NNF Kerala and secretary of NNF Kerala, and was the president of IAP Thrissur. Over to Dr. Manoj for presenting the topic.
Thank you, Jayakumar sir, for those kind words. Am I audible?
Yes.
And my slides are visible?
Yes, visible.
All right.
Can go on.
Good afternoon, friends. In the next 10-15 minutes or so, we will try to briefly look at a disease which I hope that will turn out to be like this. Rather, this talk, I just pray that this talk is going to be a useless talk for you in the future, and then this is a talk for the past. But then, like, just to know, for curiosity's sake, let us pray that we won't need to actually go into the intricacies of this in the future. We'll just try to look at classify COVID illness in the neonates, what to monitor, investigate some of the danger signs, know the rational drug therapy, and then a little bit about the multi-system inflammatory syndrome in neonates, which has been threatening some of us in our practice. So, if you want to classify COVID, the simplest classification is that some of the babies who are asymptomatic or who are mildly ill or moderately ill or severe ill, and this has been the classification that is now accepted in our NNF FOXI guidelines as well. And asymptomatic are the babies who are exposed to the infection, probably the mother, and who doesn't actually require any sort of treatment. They just need to be monitored. So the ideal place for treatment should be home. They should never be admitted, and they should be exclusively breastfed. Of course, the mother, if infected, should be wearing a surgical mask and hand hygiene and things like that. And absolutely no tests required for this group. However, when you have asymptomatic babies, you should always be looking out for the next group, mild illness. Are they developing mild illness? And what is mild illness? Presence of fever, sore throat, rhinorrhea, cough, diarrhea, vomiting, etc. without respiratory distress. No tachypnea. Again, this group also we can manage at home. No routine tests are required, and probably we can always, we need to be looking at the watchful of the complications, and then if there are comorbid conditions, that may create an issue. So this is one area where you need to be really watchful. Managing mild illness, again, these babies should be on breastfeeds, not on any formula, only breastfeeds, and the only drug recommended is paracetamol, 10 to 15 milligram per kg 6 hourly. And However, we should be looking out for symptoms in the form of persistent fever more than 3 days, respiratory rate more than 60, and saturation or hypoxia. Of course, other symptoms to look for are poor feeding and activity. And once these are present, then these may be developing moderate illness, so we need to be careful. Then you need to admit this baby. Till then, it is home treatment and absolutely no role for any other medications, ivermectin, remdesivir, flavipir, hydroxychloroquine, dexamethasone, which were all being used at some point of time. So only when the baby develops respiratory distress, these babies need to be admitted. That is a moderate illness. Fast breathing or hypoxia. If the saturation falls below 90 to 94% on room air, and if the respiratory rate is more than the age-based criteria, then they need to be admitted, and then basic workup should be done. CBC, CRP, liver function test, renal function test, chest X-ray are to be done, and then probably, if required, repeated after 72 hours. How do you treat them? Again, if mother is present, encourage direct breastfeeding. If mother is not present, then try to give express breast milk. If that is also not available, then do gavage feeding. And if nothing is possible because of illness or because of some scenario, then you can give IV fluids, especially tachypnea, and then baby is not tolerating feeds. Any baby who is tolerating feeds, even though they have some illness, they should be enterally fed, not given IV fluids. Again, the only drug recommended is paracetamol, even in moderate illness. Only if you suspect bacterial co-infection, then the recommended drug is amoxicillin as per the Government of India guidelines, and for an older baby, not a neonate, co-amoxiclav and ceftriaxone are also prescribed. Again, we need to be monitoring the respiratory illness and the use appropriate therapy. Most of the time, it's an oxygenation problem more than a ventilation problem. So even nasal prongs oxygen might be enough, but sometimes the illness will progress and you need to give some non-invasive ventilation in the form of HFNC or CPAP. That is a group which has severe illness. Now, severe illness is an area where we should be very, very careful. Unfortunately, the cases are very, very less, and we all had few cases in our practice some time ago. I think none of you are having the case right now in the state. So, pneumonia is the predominant symptom in severe illness, with saturation less than 90%, requiring oxygen, increased respiratory effort, grunting, seizures, etc. And then, of course, other systems that are usually implicated and have some problem are gut. So, GIT. So, this along with severe diarrhea, vomiting, abdominal pain, along with respiratory distress, you need to be careful. And sometimes these baby deteriorate, go into multi-organ dysfunction, thrombosis, and etc. The typical MIS category which we will just discuss. So, how do you investigate these babies? Again, the basic parameters which we discussed, and since they are in the hospital, if you have facility, a blood gas may be useful. Otherwise, look out for of course, you have taken the X-ray. If required, if you are suspecting any cardiac illness, then ECG may help. And then they may need to be the test need to be repeated after 48 hours, not after 72 hours. Always remember, severe illness in a COVID RT-PCR positive baby is most likely due to non-COVID reasons. So you need to rule out all other neonatal conditions. Severe COVID illness per se, where COVID is the factor that causes illness, is very, very rare. But at the same time, we have seen that the morbidity profile of babies change and they worsen when they have even other comorbidity along with COVID infection. How do you manage these babies? They are managed under 3 basic heads: oxygen, fluids, and antibiotics. That is for COVID alone. So oxygen is based on what is your problem. If it is an oxygenation problem, you can use non-invasive support, and if that fails, then then ventilation as per indication. The management, there is no change from any other baby with respiratory distress. Fluids, it is sometimes we are liberal with fluids, but here is a scenario where you can restrict fluids a bit. However, make sure you don't dehydrate them, maintain hydration. And antibiotics are indicated for any bacterial co-infection which are very likely to be there, and then use a unit protocol in selecting the antibiotic. Other common problems from RDS, they may progress to ARDS, and sometimes they land up with kidney failure and things like that. So you need to be ready to manage. The management protocol is exactly same as any other neonatal illness. Now, what are the drugs used in COVID-19? Well, I just summarized it from our recent NNF FOXI IAP clinical practice guidelines published in June this year. What is so the only drug that is recommended is steroids if there is no MIS. So steroids can be used if baby has severe or critical COVID-19 infection requiring mechanical ventilation, not for all severe illness also. And the preferred drug that is used is dexamethasone in a dose recommended as 0.15 milligram per kg orally. Or if you want to give orally in a not as sick baby, probably nasogastric route has also been recommended. Duration of therapy should be 5 days, 14 days, or until discharge, whichever is earlier when you feel the drug can be stopped. Do not go beyond 14 days in any case. And if dexamethasone is not available, it will be very, very unlikely. This is based on the rheumatology guidelines. So probably we have taken the guidelines, and then so other steroids which can be used in equivalent doses are hydrocortisone 3.75 milligram per kg IV in 2 divided doses, prednisolone 1 milligram per kg orally, or nasogastric administration, or methylprednisolone 0.8 mg per kg IV. These are the drugs that are usually used in severe illness. Drugs not to be used are the antiviral, remdesivir, interferon, tocilizumab, plasma, etc. CAH has a role only if the baby has multi-system inflammatory syndrome. So, little bit about multi-system inflammatory syndrome, otherwise we call it MISN. How do you define? WHO definition is what NNF also follows. This is actually common definition for all children. Fever more than 3 days, but actually we know that some in neonatal you can relax on the fever criteria. So otherwise it's for all infants, fever more than 3 days and presence of at least 2 system involvement in the form of rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammation, hypotension or shock, cardiac illness in the form of myocardial dysfunction, pericarditis, valvulitis, coronary anomalies, etc., etc., and then evidence of coagulopathy, which we were seeing few months ago in a series of cases, and then gastrointestinal problems in the form of diarrhea, vomiting, abdominal pain, etc., etc. How do you define this? Of course, fever plus beyond these criteria should be present. That alone is not enough to diagnose MIS. As per WHO criteria, WHO definition, you need also elevated markers of inflammation such as ESR, and you need to rule out other obvious microbial causes that cause this pathology. And of course, you need to make sure that baby or the mother had COVID infection. So in the sense that either an RT-PCR positive test or a positive serology is mandatory along with all these parameters and absence of any other disease to diagnose a baby as having MISN. And the caveats in newborns are fever may not be always present. And sometimes you won't get a COVID history in the baby because the baby might have been exposed to COVID in the utero. There are so many other viral illnesses which can present the same way. So this history is mandatory as per the definition. And what is the incidence? I was trying to look at incidence, and then probably the quoted figures are in the guidelines, and they quoted 4% in the infants. Patients reported from the CDC. That is the figure that is quoted. How babies present? Multi-system involvement. So they have respiratory involvement in the form of respiratory distress, pneumonia, pneumothorax, cardiac involvement in the form of hypertension, shock and arrhythmias, renal failure. And of course, sometimes we find that these are not present, just CNS symptoms alone are present. And gastrointestinal diarrhea, vomiting is very, very commonly reported from most of the parts of the world, and rash of the hematopoiesis. How do we investigate? is taken from the American College of Rheumatology, who has suggested this Tier 1, Tier 2 investigation. So what is Tier 1? Tier 1 investigation is, first of all, make sure that there is a history of COVID in the form of RT-PCR positive or antibody positivity. And there are those who want to look at the details of how to interpret the antibody. You can look at the guidelines. I am not covering it for lack of time. So once that is there, then at least these the two criteria to be filled. One, the inflammatory mediated CRP or ESR positive, and also we have, and in an absolute neutrophil count less than 1000, either or any of these, platelets less than 1.5 lakh, sodium hyponatremia in the form of sodium less than 135, or hyperalbuminemia. Also remember that these have to be present, and then that alone is not enough, because if you just look at our sick babies now, and these babies all do this criteria, so the other illnesses should be ruled out. It's a very tall task. When to do Tier 2 investigations, if Tier 1 is positive or there is a clinical suspicion, we are not very sure, then you can go for Tier 2 investigation, or if there is a life-threatening situation in neonate, then you can think of Tier 2 investigation, and it consists of 3 groups of investigation: inflammatory markers in the form of ferritin, procalcitonin, etc., cardiac markers in the form of troponin or pro-BNP, etc., etc., and then coagulation markers in the form of D-dimer. Please remember that there are no laid out robust norms for these as far as neonates are concerned. We are extrapolating from the child data. Managing MIS-N, WHO says the investigations are not mandatory. Tier 1, Tier 2 is not mandatory to diagnose MIS-N, and then once you diagnose MIS-N, then you classify into 2 groups: those who have shock or life-threatening disease, and those who do not have that. So if you have shock or life-threatening disease, then the 2 drugs that are recommended are IVIG at a dose of 2 gram per kg over 24 to 48 hours, and methylprednisolone 10 to 30 milligram per kg per day. However, if you do not have methylprednisolone, you can use dexamethasone, but this is when you have MIS-N with a life-threatening condition, probably this is the drug. These are only 2 drugs. Aspirin has been recommended by some of the authorities. Antibiotics for MIS-N, no. If there is a coexisting bacterial infection, yes. And please remember, the efficacy of what you recommend in these recommendations is not proven fully by evidence, but this is a recommendation. Now, if there is no life-threatening sedation, then the 2 drugs, IVIG and methylprednisolone, are again plus minus. You can use it or you cannot, depending on the scenario. So, to wind up, the practical points to follow up: in a neonate suspected with COVID infection, we need to look at, the first thing is classify. Is it asymptomatic COVID? Is it mild, moderate, severe? The asymptomatic and mild should be managed at home. Home is the best place. Moderate should be hospitalized, and always look for the next stage of the disease, and monitor SpO2 vitals. Always look for the danger signals, and then monitor saturation. Continue breastfeeding as far as possible, and steroids only for severe illness. Never give. So don'ts are: never give ivermectin, chloroquine, remdesivir, ritonavir, etc. Do not use steroids for mild or moderate COVID illness. Ignore the never ignore the comorbid conditions, because that is probably the diagnosis, not your COVID. And then never, if you are not able to manage, so suppose it's like using CPAP in a center, and then you find that you do not have the facility to ventilate, you are always looking for failure of CPAP in the center. So similarly, if you are treating a moderate illness and you do not have ventilation facility, you would definitely transfer. You would not want to delay transfer. As far as MIS-N is concerned, we need to always rule out common causes and refer if Tier 2 investigations are indicated as per the recommendation. And always remember, any neonate, before you transfer, you need to stabilize the infant. In MIS-N, there is no role for universal testing of COVID-19 antibodies if neonate is born to COVID-19 positive or negative mothers. How if the diagnostic criteria are met, do not treat lab reports in isolation. Always take it in the whole context, and no antivirals. And miscent babies who are RT-PCR negative do not need isolation. That also we need to remember. So just to recapitalize whatever we have said now, clinical monitoring and supportive care is the key. Oxygen is indicated if saturation is less than 95%. Steroids are indicated for rapidly progressive and severe COVID-19 illness. There is no role for remdesivir, other antivirals, interferon and convalescent plasma in neonates. When you diagnose miscent, always the WHO criteria must be fulfilled, and it's a diagnosis of exclusion after running out of common causes. Never diagnose miscent as your first if there is an obvious cause that is glaring at you. Clinical monitoring and supportive care is key, and life-threatening diseases, if present, baby should be referred to a tertiary center. Steroids and IVIG should be used only in specific indications which I mentioned. And any baby with this, we know that now that babies who turn COVID positive subsequently have a lot of problems. Now we have experience of almost 1 year babies, and the long-term follow-up is probably must for these babies. So if you want to get more data, I just pray that you don't need to use any of these, and this talk you can just forget after this. Let us not have the next wave and then struggle with managing neonates with COVID. With this, actually, I would stop. So I want to invite all of you. If you are part of the organizing team, we are hosting the first International Neonatology Summit in Kerala in March. That's going to be a 3-day affair. We start at 3 o'clock on Friday, and then you have two dinners on Friday, Saturday, and then the lunch on Saturday, and Sunday it's going to be a Mela, a scientific feast, along with, so NNF Kerala is proud to host this event along with the IAP Neocon 2022. The venue is Hyatt Regency, a 5-star hotel in Thrissur. So those who are not registered, I know most of you are registered. Those who are not registered, I would urge you to be part of the first International Neonatology Summit in Kerala. Thank you so much.
Thank you, Dr. Manoj, for the excellent presentation of the topic. Even though the symptomatic cases are less and moderate and even severe cases are relatively less, and the experience also is less, but we have to extrapolate from the international scenario. And I don't know, anybody has got the opportunity to diagnose Miss N in Kerala and treat it. And in that case, there is a role for IVIG and methylprednisolone. And there is a question, is there antibody positivity is mandatory for the diagnosis of MIS? That is the question.
Unfortunately, I had the misfortune.
Antigen and antibody for the diagnosis of MIS-CAN.
Yes, sir. So actually, we had 2-3 cases of miscent presenting recently. I mean, 1.5 months ago. So that was a learning experience for us also. We also thought we will not be this thing, and then we were saying we never had such cases. But then sometimes miscent will strike you, and then so antibody diagnosis is not must to diagnose. As per what I would suggest is this is a new disease. The things keep changing, so the best way to approach this is by going by the guidelines. Medical legally also you are right. Now there's a beautiful guideline published jointly by the 3 organizations catering for this, the NNF, FOXI and IAP clinical practice guidelines released in June this year. So I would suggest you to go by that, and they recommend WHO definition for diagnosing miscent, which means that you do not need to have antibodies in serum if mother is COVID positive or has a history of COVID positivity, but otherwise the essential criteria is either RT-PCR positive or miscent antibodies positive. How to interpret is a complex job. I don't want to take time here.
Dr. Manoj, is it true that there is increased incidence of LSCS and incidence of premature delivery in there's a COVID positive mothers? That is usually seen in the international.
If you are asking my personal,
naturally the prematurity is associated with the increased incidence of respiratory distress as well. So,
unfortunately, yes. The COVID has affected us in two ways. One, it has actually augmented and accelerated the neonatal morbidity of otherwise disadvantaged babies like the preterm babies. The incidence of COVID birth has been, COVID and the preterm delivery has been now reported more in the mothers who had COVID infection in the second trimester. So probably it has, and plus added to that the kind of medico-legal sword that we are all in. Unfortunately, the incidence of cesarean section has gone high. Scientifically, there is no need to do cesarean section for the fear of spreading COVID to the baby like in some other thing, but then that is a fact.
Thank you all for participating and excellent presentation speakers. And I take this opportunity to extend our sincere gratitude and thanks to Professor Ojos and the entire organizing team for giving us the opportunity to chair the session, and all the speakers for the excellent presentation. Thank you all.
Thank you.
Over to Josar.
Arya.
So now we are heading towards the finishing line, and this is the final session for the MidNeocon of this time with 4 more interesting topics. And to chair the session, I would like to invite Dr. M.K. Santosh and Dr. Anil Vincent. Dr. M.K. Santosh is a senior consultant in pediatrics in Kannur and past president IAP and NNF Kerala. And Dr. Anil Vincent is a senior consultant in health services, and he's a past president IAP Alappuzha. So I humbly invite both of you to chair the sessions. Over to you, sir.
Good afternoon, everybody. Can you hear me?
Yeah.
We are having a tuberculosis elimination program going on in Thalassery. I know this is a pre-lunch session and almost all of you are hungry. So I promise that I won't take much time to introduce today's speaker, Akash Pandita. This youngster is MD and DMD. He is currently assistant professor of Sanjay Gandhi Science Lab. He has got more than 100 international publications, and he is in the editorial board of 7 international journals.
Sound is cracking.
I am using my mobile phone, that's why. And range is poor in this
the sound is not very clear.
And he is in the editorial board of 7 international journals, and he is the reviewer of another 35 international journals too. His area of interest is jaundice, surfactant therapy, non-invasive ventilation, research and teaching. This youngster is today introducing 5 papers which can change our future neonatal practice. Over to you, sir. Dr. Akash Pandita.
Thank you, sir, for that kind words, and thank you for that introduction. At the outset, I would like to thank IAP Kerala and NNF Kerala, Manoj sir, for making me part of this August gathering. And without wasting much time, we move on to the topic. In the next 15 minutes or so, I will be talking about the 5 research papers which are likely to change our future practice. Now, before going to the main topic, I would like to let you know about what is research. Now, research is researching, that is searching again and again to find the best answers to our questions. Remember that this search should be done in an organized and systematic way so that if somebody else wants to repeat, he gets the same answers. However, the research priorities vary from country to country, and within the same country, the research priorities will vary from region to region. The research priorities mainly depends on the epidemiology, that is what type of problems we see commonly in our population, and the resource and other logistics. Now, if somebody thinks that research is a cup of tea only for high-income countries, then that is not true. In fact, it has been seen that with introduction of evidence-based neonatal practices, we can say almost 1 million lives per year. So research should be a part and parcel of our neonatal care, whether we are from LMIC or high-income countries. Now, in order to make significant impact in both morbidity and mortality, we know that neonatology is just not confined to the baby after he is born. It starts right from the conception. In fact, in some of the countries in the West, perinatology is an integral part of neonatology. So we need to cater to all the sections. That is, we should intervene right from the conception. That is, we should cover antenatal period, intrapartum period, and also the postnatal period in order to make significant reduction in morbidity and mortality. Now, coming to the first intervention, that is use of antenatal corticosteroids. Many of you might be wondering that it is already a well-established practice. However, that is true only in high-income countries. Less than 10% of our women who are in low-income countries receive antenatal corticosteroids, whereas only one-third to half of the mothers receive that in middle-income countries, compared to 80 to 90% of the women in the West. Also, there was a recent trial published in 2015 known as the ACT trial or antenatal corticosteroid trial, which was a cluster randomized trial. In that, the researchers tried to improve the neonatal mortality by introducing antenatal corticosteroids. What they observed was fascinating, that they observed for that every 1,000 women they exposed to antenatal steroids, the neonatal mortality increased by 3.5. Also, there was increase in incidence of maternal infection. So this question was recently answered by a trial conducted by WHO in LMIC countries, in which India was also a part of the trial, known as the ACTION trial. In this trial, the scientists studied pregnant women between 26 to 34 weeks of gestation, and they compared intramuscular dexamethasone with the placebo. And the main outcomes which they studied was stillbirth and neonatal mortality. However, the trial was stopped after the second interim analysis because the benefits were clear with antenatal dexamethasone. They studied around 3,000 mothers, and the number needed to benefit was 25. That is, 25 mothers, when the steroids were given to 25 mothers, we were able to save one neonate. And all the countries who were taking part in this trial were from low middle income countries. What they observed was satisfying, that both the neonatal death as well as stillbirth came down significantly with the introduction of dexamethasone in the antenatal period. So the take-home message from this paper is that antenatal steroids are beneficial across the globe, irrespective of the settings. They not only decrease the morbidity, but also decrease the mortality. In fact, antenatal corticosteroid is one of the most effective public health initiatives, as said by UNICEF. Also, since we do not have the actual salt of betamethasone, that is the combination of betamethasone acetate and propionate. So this was the other question, that whether the dexamethasone, which is commonly available and advocated by our government, whether it is as effective as betamethasone. In this trial and the other trials, we have now seen that dexamethasone is as good as betamethasone and is even cost effective when compared to betamethasone. Moving to the second paper, that is intact cord resuscitation. Now, by now, we have enough evidence to tell you that delayed cord clamping is beneficial both in preterm and term babies. It decreases mortality and important mortalities like NEC, IVH. It also decreases need for inotropes, blood transfusion, and improves iron stores in term babies. However, what is worrying is that the babies who have a difficult transition and are more vulnerable to increased morbidity and mortality have been excluded from these studies and therefore are divided of this practice. However, by our previous knowledge, we know that preterm babies, they have limited cerebral autoregulation. That is, they are able to control cerebral blood flow over a narrow range of blood pressure. Also, when we wait for the patient to breathe before we clamp the cord, the increased amount of blood which goes to the lungs returns to the left side of the heart and in turn increases the cardiac output. Now, this increase in cardiac output decreases the fluctuation in the cerebral blood flow and ensures oxygenation till the patient breathes. Therefore, it is effective method of decreasing fluctuations in the cardiac output as well as the cerebral blood flow. Now, there is an upcoming evidence that intact cord resuscitation can be done even in babies who need resuscitation. And this is again a NAPOCOD trial, which was again done in an LMIC country, Nepal, in 2016, by far the largest RCT on this topic. And the observers studied late preterm and term neonates who were requiring resuscitation. They compared intact cord resuscitation, that is resuscitating the baby with intact cord without clamping the cord, versus early cord clamping, that is clamping the cord early within 30 seconds. And the main outcomes which they studied was saturation, heart rate, and Apgar scores at 1, 5, and 10 minutes. Again, this trial was stopped after the second interim analysis because of the clear benefits of intact cord resuscitation. What the observers studied, that what they observed was, again, in babies who received early cord clamping, which is shown in the blue, that the incidence of low Apgar, low saturations at 5 minutes, 10 minutes was significantly more in babies who received early cord clamping. Also, the rate of NICU admissions and mortality was higher in babies who received early cord clamping. Therefore, what does this trial and other trials show us? That intact cord resuscitation is beneficial and useful, not only in babies who make a smooth transition, but also in babies who have difficulty in resuscitation or who require resuscitation at birth. In fact, that is the group which is at high risk of mortality as well as morbidity. We move on to the next, that is CPAP. We all know by now that ventilation is the way to success. That is, we should prefer non-invasive ventilation compared to mechanical ventilation, and there is enough evidence to support that. And majority of us use delivery room CPAP for preterm babies who have respiratory distress. And the most common gadget or machine which we use to deliver this delivery room CPAP is TPs. However, the mannequin studies have shown that TPs is associated with increased work of breathing because the patient has to breathe through the circuit. And this is known as imposed work of breathing. Also, the interface which we use to deliver CPAP through TPs is a facial mask. Now, applying facial mask causes a lot of air leak, and also it leads to airway obstruction, which cannot be recorded or observed by the caregiver. Also, because of the pressure of the mask, it leads to trigeminal-cardiac reflex, which can itself cause bradycardia and heart rate, which are in fact indications for mechanical ventilation. And we all know that mechanical ventilation is an important risk factor for BPD. So there is little evidence to show us that what interface is best. And by this knowledge, if we are able to decrease the work of breathing, we will be able to decrease the risk of CPAP failure. And we know that in ELBW or VLBW babies, the CPAP failure rate is as high as 40 to 50%. So what next? Recently, the scientists have observed that if CPAP can be given through short binasal prongs, the work of breathing comes down and the rate of CPAP failure is significantly less in mannequin studies. They went a step further and conducted a human trial, which was again in RCT, in almost around 250 babies in 7 NICU centers in Europe. And the mean gestation was around 26 weeks. Here they compared the new respiratory support system in which CPAP is given to the baby with the help of short binasal prongs compared to the standard respiratory support, that is using a TPs and a facial mask. The primary outcome which they studied was need for intubation or death within the first 30 minutes of life. And they observed that with this new device, there was a significant decrease in the rate of intubation within the first 30 minutes of life. It was 33% compared to the 45% in the control arm. So we definitely know that CPAP decreases incidence of BPD, but we should also remember that TPs leads to increased resistance. The pressure is variable because of the significant leak from the mask, and it increases work of breathing. This high resistance can lead to low pressure delivery. And facial mask, because of the pressure application, can lead to various complications like apnea and bradycardia, and may not be the best interface to deliver CPAP and delivery room. Moving to the next intervention, often babies who do not do well on CPAP, they need surfactant. And for surfactant, we have a new technique which is known as LISA or MISA or MIST, that is least invasive surfactant technique. Now, what makes LISA promising is that it avoids the need for positive pressure ventilation, which is an important part of Ensure. It also avoids interruption of the CPAP. By CPAP, we distend the lungs and establish FRC. However, during Ensure, the patient has to be taken off from CPAP. So whatever lung recruitment we had achieved, that again becomes zero and the lung collapses, leading to atelectotrauma. In LISA, we are continuing the baby on CPAP. So whatever FRC we are established, that remains there. So there is no atelectotrauma. Also, because of the spontaneous breathing, the distribution of surfactant is better in LISA or MIST. Now, this was the largest trial which we did way back in 2017, where we showed that with the LISA, there is 50% reduction in the need for mechanical ventilation. Also, the BPD risk in babies who received surfactant by LISA was significantly less compared to Ensure technique. We further did a systematic review in 2019, and recently we published a network meta-analysis on the same topic. And in this network meta-analysis, we have shown that with LISA or MIST, we can not only decrease the morbidities like BPD, IVH, PVL, but also it decreases the mortality. So more and more centers across the globe are using now LISA or MIST for surfactant delivery. So take-home message from this paper is that surfactant by LISA or MIST is a safe and effective technique. It avoids intubation and lung trauma. It has also been shown to decrease mortality along with the BPD. However, one needs proper training before he or she can implement this technique in his or her unit. Now, coming to the last paper, again, one of the common conditions which we see in our neonatal care, and we heard our previous speaker talking about hypoglycemia. And it is always important to prevent this condition rather than treat. Why? Because the symptoms are vague. They are not specific to hypoglycemia. Also, the clinical symptoms of hypoglycemia, they do not correlate with blood glucose levels. What does that mean is that a baby with a sugar level of 10 to 20 may be totally asymptomatic. So if we are waiting for symptoms to occur to pick up hypoglycemia, then the baby is going to crash and we won't be able to prevent the brain injury. Also, there are various risk factors for hypoglycemia which are commonly seen. For example, prematurity in front of diabetic mother, LGA. And also, because of this condition, which is totally preventable, the incidence of neurological injury can be as high as 50%. Any neonate who has hypoglycemia and throws a seizure has a 50% risk of developing impaired neurological, has a probability of 50% chance of developing neurological deficit in near future. And the condition is totally preventable. So what can we do to prevent this condition? Remember that screening is not possible in every unit, especially the primary and the secondary healthcare centers, which are part and parcel of our healthcare. This was a trial known as the HPOR trial, which was done recently, and it comprised around 2,000 babies from 18 hospitals. The babies who were at risk of hypoglycemia were recruited to two of the groups. One group received 40% dextro gel and other group received placebo gel. What this primary outcome was NICU admission. Although the NICU admission rates were not different, but with the use of this dextro gel, the hypoglycemia incidence was significantly low. And also that this dextro gel is totally non-invasive. It is applied intrabuccally, is inexpensive, is safe in the dose of 200 milligram per kg. And with this gel, there was no untoward incidence, and also the risk of hyperglycemia is not there. So this can be an effective way of preventing hypoglycemia, especially in the centers where there is no regular monitoring or the burden of disease is high and the discharge is done early. My take-home message for this presentation is just a small one, that it is supposing was good, but finding out is always better. Thank you. And I again thank the organizers for giving me this opportunity. With that, I end my presentation.
Nice talk, Akash.
Nice.
Thank you, sir.
Santosh sir is not arranged. Ano, Santosh sir,
He's there. He's there.
Straight away go to the next topic.
Okay. Good afternoon. Any neonatology conference is incomplete without a topic on neonatal sepsis. And acute appendicitis for a surgeon. Neonatal sepsis is the bread and butter of neonatals, at least in our country, which is a developing one. And all of you know, there has always been updates in this area, day by day. And to enlighten us on these updates, we are lucky to have Dr. Dinesh Kumar Chirla, MDDM, Fellowship in Neonatology, Australia, Fellowship in Pediatric Intensive Care, UK. And he is the current Head of Department and Director, Intensive Care Services, Rainbow Hospitals. He is a gold medalist and he is the Joint Organizing Secretary, NNF. He has around 40 research publications to his credit. And he has been the past president of NNF Telangana State. And he has been the EB member to NNF 2019 and IAP Pediatric Intensive Care Chapter. And he has conducted many conferences, and he has been the Chief Organizing Secretary to NeoCon 2019. These words, I invite Dr. Dinesh Kumar Chirla.
Thank you, Dr. Anil, for the kind introduction. Am I audible?
Yes.
My slides are visible?
Visible.
Yeah, thank you so much. Take this opportunity to thank Dr. Manoj, NNF Kerala and IP Kerala, Dr. Jose and Ranil and Dr. Santosh and all the members for inviting me and giving this opportunity to share my thoughts about neonatal sepsis. I know neonatal sepsis has been part of many of neonatologists' journey, but I think we should slowly look into a journey where we should not have too many babies with sepsis, and sepsis should not be our primary diagnosis, and the incidence of infection should come down. And what are the steps we should take in our unit to reduce the incidence of neonatal sepsis, especially the nosocomial sepsis? What happens in early onset sepsis is not in our hand, but what we can do to reduce nosocomial infection is what I'm going to talk today. This is not uncommon for a lot of tertiary or level 4 units to see a baby like this surrounded by a lot of machines like this. Or we have become so advanced to save smaller, very, very small babies, 24 weekers, 25 weekers, 500 grams and 600 grams. So why do neonates are at high risk of acquiring healthcare infections? I say the risk of infection as much as a post-transplant patient. Because the host defense mechanism is impaired, we have limited amount of protective endogenous flora or skin and mucosal surface. Even if you look at the skin, and especially some of the very preterm babies, the barrier function is, and they can get damaged very easily. And we do a lot of lines, and they are exposed to frequent. If anything is there, we suspect infection, and there are antibiotics. So the most important priority for all of us is prevention of infection. Now, why is it important? It's important because hospital infections increases the risk of morbidity and mortality in most of the newborns. It prolongs the hospital stay. It puts a financial burden on the family and the hospital. It increases the long-term complications like neurodisability. And of course, once the child is sick, we increase the workload on the hospital staff also. If you look from the Delhi neonatal sepsis studies, the case fatality of child who is culture positive is almost close to double of a child who has got any sepsis. When we looked at our data, which was a culture positive for the last 5 years of 453 babies, we didn't find such a high mortality. We were able to discharge 72.6% of the babies who were culture positive. 10.6% died and 16.6% 7% went LAMA. But when we analyzed, the preterm babies were at high risk of death compared to the term baby, 15%, 9%. Babies who were less than 1.5 kgs were a higher mortality, 17% was 11%. Mortality was higher in early onset sepsis, and gram-positive sepsis had higher mortality. So with this, we set a stage that prevention is primary because it protects patients, it protects healthcare personnel, and promotes quality healthcare. What are the factors in the ICU which actually promotes cross-infection? Inadequate hand washing, prevent overcrowding, understaffing, preparation of IV in the unit, lack of isolation facilities, no separation of clean and dirty areas, and excessive antibiotic use. So the strategies which we all can use is promotion of hand hygiene, contact isolation, a proper protocol of equipment disinfections, care bundles, asepsis during procedures, and ANTT. So no talk of bundles or prevention of infection is complete without hand hygiene, which would save lives. As you know, we have 5 moments of hand washes because it is not just the baby, because surrounding formats which can also get colonized. So we need to wash hands, not only before or after examining the baby, but also before the procedure and after touching the patient environment. So having adequate facilities for hand washing, provision of washing instruction in the washing areas, and having an administrative measures like making improved hand hygiene and institutional policies. So place alcohol hand rubs at the entry. So after you wash hands, you're going into the unit, having an alcohol rub, or placing an alcohol hand rub at each bedside. This is how you can improve the compliance of your staff using the alcohol hand rub. So now how do you increase it? The hand rub use of hand washing in the unit by implementing a multidisciplinary program like a hand hygiene week or hand hygiene quiz. We are a hand poster competition. We have done a lot of this and found a significant increase in the use of hand washing in our staff. So encourage patients and their families to remind healthcare workers to practice hand hygiene. So what is the concept of using bundle? A bundle is a structured set of evidence-based practice for improving the process of care and patient's outcome. So you will have 2, 3, or 5 sets of bundles, cares which we know independently can improve the care, but together probably we are expecting a much better outcome. So let us take one of the common is catheter-related bloodstream infection bundle. So while insertion, use of insertion checklist, having a dedicated procedure card. So you need to have a procedure card which you get cleaned properly, hand hygiene measures, skin antisepsis, use of maximum area precaution, sterile occlusive dressing, dedicated staff for insertion of the PIC lines. And while maintenance, daily assessment of skin integrity, dressing changes weekly and as needed, prevention of insertion site bleeding, scrubbing site with appropriate antiseptic, reduce access frequency, and daily assessment of need and early catheter removal, and training of healthcare personnel. So let us take one point which is important. So whenever we are putting the central line, assess whether the child needs a central line and who is going to put the central line. So we have in our unity policy, like we have this checklist. So who has to put the central line? Is the person trained? How many lines he has put in? For less than 1 kg, we have a designated number of people who could put it. So wash the hand. A nurse takes it, they have washed hand. Have they put a sterile barrier precautions? Are they wearing mask, cap, gown? There is a tick box for it. Prepare the insertion site with antiseptic solution? Yes. Spread the sterile drape without contamination? Yes. Clean the site of selected vein site before cannulating? Yes. Place a sterile transfer dressing over the insertion site. So we need to have a transfer dressing so that we see the tip. So if there is a redness or if there is any contamination, we see that. Ensure that there is no blood at the insertion site and in the hub of the cannula. So sometimes what happens after the insertion, it gets there is a blood. So be patient. See that it is completely dry before you put the dressing on it. Prepare all your fluids, especially the central line fluids in the laminar flow. While you maintenance, always perform hand hygiene before you are accessing central line. Use sterile gloves for handling central line. Clean the hub with the antiseptic solution. Inspect central line in each shift for the following and consider antibiotic by central line before removal of the line. So now we again have a checklist like this before for the maintenance. Say again, always perform hand hygiene, use sterile gloves, clean up. But they will check on a daily basis in the round. Can we remove the central line? How many days the central line is in? Evidence of inflammation or not? The nurse will note in each shift. Is there a blood at insertion site? Is there any peeling of the dressing? Is the dressing clean or dry? Is there any leakage at the insertion site? Are injection ports or the catheters hubs? Is there any obstruction to the infusion flow? So we need to measure all this. These are the measures which you will do here. Topical antimicrobial ointment at the insertion site is not recommended. Systemic antibiotic prophylaxis, like just putting an antibiotic because you got a central line, or antibiotic lock prophylaxis has no role. These are some of the newer set of where infection prevention in NICU or a multidisciplinary intervention to reduce CRB side are something which have been sort of reviewed, which have shown that if you follow the bundle approach, there has definitely has been a reduction in incidence of CRBSI in the unit. Let's come to the other bundle called VAP bundle. So ventilated associated pneumonia. So if you have a children who are nowadays, as we are doing more and more non-invasive ventilation. But if you ventilate the children, you do not want them to pick up a pneumonia. So important is, again, what are the strategies? What are these some processes we have to apply? Train your staff, specifically to say hand hygiene, correct use of sterile gloves prior to using the ventilator equipment, sterile management of areas, especially while intubating or while giving surfactant or while suctioning. It's very important. Avoid re-intubation. So you know that when you want to extubate, so is the child ready for extubation? Oral care of the patient, position of the patient, feeding while, whether you should go for bolus feeds, so continuous feeds is not recommended, and care of the ventilator circuit. So take all aseptic precautions when you are intubating the child. So do not just sort of, once you clean them all with alcohol swabs and everything, take all septic precautions. I've seen some units not wearing sterile gloves while intubating. So you need to wear sterile gloves when you're intubating, because otherwise what happens is your tip of your endotracheal tube gets colonized while you're intubating and they develop VAP. Some have talked about role of inline suction when you are actually, to reduce the risk of contamination. But in newborns, because of cost factor, many units do not use it. But as long as you ensure that you are wearing sterile gloves, you have two people, either a nurse and a doctor or two nurses are there for suctioning, because you do not want to contaminate the endotracheal tube or the tip of the suction catheter when you are doing the suction. And you need to have a separate thing for the oral and the endotracheal tube, or you finish off the endotracheal suction before you go for the oral. And routine installation of saline and distilled water should be avoided into your endotracheal tube. These are the measures. Position of the airway is important. We need to avoid draining of the water into your lungs to prevent sort of your airway getting contaminated. And mouth care. So cleaning your mouth every 4 hourly, say the tongue and the cheeks and the buccal mucosa is important. Some people will do it sort of distilled water. Nowadays, there are some recommendation coming about role of maternal colostrum as a preventive measure to reduce the ventilator-associated pneumonia. Do not give some sedation holiday. So if a child is being overly sedated and not moving at all, that prevents sort of clearing of secretions and increases the risk of ventilator-associated pneumonia. So it is important for us to give a sedation holiday for the child so that there is some mobility of secretions. Keep a monitoring of the child regularly to ensure that all the parameters are in place. And use only disposable circuit as far as possible. Occasionally, the gas sterilized circuit, if generally suppose you have a child who comes in, but we use only disposable ventilator circuit. And again, you have a checklist like this. Every day you need to ask, is this child ready for extubation? Is the child sedation? Is child over-sedated? Is there any visible soil in the ventilator circuit? Look at the suction canister also. After once you do a suction, if the canister we change every 24 hours, we get it cleaned. Amu bag is soiled, it has to be changed. And Keep the ambu bag in a clean, non-sealed plastic bag. If there's a condensation in the ventilator bag, drain away, ventilator circuit, drain it away. Keep the head end of the baby elevated to 15 to 30 degrees, which we showed in one of the photographs. Oral and nasal clear every 4 hours, and is oral AT suction only if you find that there is a block or an obvious secretions are there. So this is how, if you have, when do you say it's a VAC? There are sort of radiological, clinical, and sort of analytical criteria. So when a child is ventilated for more than 48 hours and then had an X-ray features like this, or you have bronchoalveolar lavage showing presence of organism of more than 10⁻³ count, or you have an increasing ventilation with fever. In newborn, we don't get fever so much, but increasing in the white cell or low in the white cell count, then we suspect. So always go through this checklist whenever you are having a child, when it comes to same thing as hand hygiene, sterile gloves, suction catheter, avoid using routine normal saline. So this is another sort of recent article where they were able to reduce the VAP incidence from 11.79 episodes per 1,000 ventilated days to 1.93 by implementing this VAP bundle in the NICU. So this is something which has been done routinely in adults and in children PICU, but it has now come more in the NICU. The third one intervention which I would suggest is ANT, that is aseptic non-touch technique. So this is something which most of us use. We access the IV cannula very routinely. So this is originated in 1990, aseptic technique that helps to prevent direct and indirect contamination of key part and key sites. So we should not touch by the key part or key sites. So always suppose if you want to give, so what are the key sites and key parts? These are your needles, syringe tips, IV line connections, and top of your ampules. So whenever we are touching those key parts, use always aseptic measures, and always wash your hands effectively. Never contaminate key parts. Touch non-key parts with confidence, whereas take appropriate infective precautions. So take this thing. Suppose you use always a sterile tray. Do not drop equipment into your tray because there's a risk that key part will touch the tray. Key parts should never be touched. Don't leave key parts open. Like you don't leave this hubs open. Keep them either in a micro aseptic sheet like that what is kept here, but don't keep them like the hub open because they can get contaminated when you're giving. Do not put like the drugs like this inside because the fluid can leak out outside and they can get sort of infected. Don't take paper tray. It's always better to take plastic tray, which you can clean according to your local policies. Always wash your hand before you decide to sort of access the IV port. Clean the tray. Then once you've cleaned the tray, whatever you required equipments, place them around the tray. You can clean hands with alcohol hand rub and soap and water. And you should follow, whenever using alcohol hand rub, you follow again all the steps what you follow while hand washing with the alcohol hand rub also. Put on, see, when you're routinely accessing the peripheral cannula for the non-touch technique, non-sterile gloves are fine because you're not touching anything, but you're having a clean environment is what you mean by a non-touch technique. And open equipment and prepared ducts, protect key parts using a non-touch technique. So you're not touching the tips of anything. So, and go to the patient. And what is very important in ANTT approach is you are not contaminating the key part. That is a basic thing which we have to say. Keep your sort of fluids or injections which you want to give, cover it with the hub so that they are not or keep them in covered in one of those sterile or covering in which they would come so that a micro sterile environment is created. If you have to open up the access port, either you do it beforehand, that is before the step one. If you are doing now, after you have cleaned up, you may have to change the gloves again and put a fresh pair of gloves by washing your hand again with the hand rub because you are going to give injections. So reapply the non-sterile gloves, clean the key part. So we use 2% chlorhexidine and 70% alcohol. And this is something which I would say you should tell all your staff to get used to the ANTT technique. So administer drugs using a non-touch technique. And this makes a big difference. dispose of sharps and equipments, clean your tray, and dispose of the gloves. And at the end of it, clean hands with soap and water, and this is due to the contamination. And ensure that the hand is sort of properly kept clean again afterwards your IV cannula. Now, what is the reason for us to sort of go through these whole steps? Many a time, it's so important for us. These are the simple things. The child is most of the time on a peripheral IV cannula. If we do not stress the importance of this to our nursing staff, this is where it gets contaminated. You have a child who has come otherwise well, but as was told earlier, by day 3, day 4, they start deteriorating and they get into sort of infection. They get colonized with the bad bug. And if you look at this child who's ventilated, he can get colonized either in the endotracheal tube, because if you have not cleaned the hub while accessing it, because when you're suctioning, he might get colonized in the central line here, because when you're accessing central line, if you're not used sterile gloves or you're not cleaned the hub, you can get again colonized, and the risk of CRBSI would be there. Or you might get colonized here through the peripheral cannula also if you have not cleaned them well. So there's so many portal of entries for a child. And again, if you have not kept the hands clean, there is so much risk of infection for these children. Now, how do you control the drugs, which is the biggest MDRO in your, because multi-drug resistant organism in your unit? Because there's a balancing act between choosing an appropriate antibiotic versus giving unnecessary antibiotics. So we need to have an antibiotic stewardship in your unit. So rapid identification of patients with bacterial infection, better empirical antibiotic selection, de-escalation once culture results are there, shortening therapy duration, and reducing the number of patients treated unnecessarily is very important to prevent MDRO. Having an infection control nurse will reduce the number of infections in unit. So you need to identify one of your nurse, train her in infection control practices. It has made a big difference in our units in the incidence of infections. We maintain an audit every month about the hand hygiene audit. What is the compliance rate of hand overall? Then we divide them into what is the doctor's hand hygiene compliance, what is the nurse's hygiene, and what is the visitor hygiene. And based on what we find, then appropriate interventions are done in that month, so that again it comes back to industry acceptable standards. Similarly, the VAP incidence is also maintained to see what is the incidence of VAP per the number of ventilated days. If your VAP incidence is going more than 10 per 1,000 ventilated days, then you know that you are in trouble. You need to probably take steps to try to reduce that. Similarly, you need to look into your CRBSI rates. And so you need to, so unless you monitor this on a monthly basis, you will not be able to change your infection control practices in your unit. So every month, there's a practice in our unit to monitor all incidents of blood culture positive, incidents of VAP, incidents of CRBSI, and incidents of sort of hand hygiene. Based on this, we would say where there is a lacunae and how to, because suddenly if the unit gets busy, sometimes there would be some problems in the implementation, or some people may not be compliant. So you may have to reinvent or reintroduce certain things like a hand hygiene week, infection control awareness weeks. We had some sort of infection quiz which initiated. So there could be a number of such things which have to be initiated. I think when you start interventions like this, then only you can say babies like, this is a baby who was born at 375 grams. Now this baby is now happy and walking, and this is so satisfying. I think unless a unit introduces something like this, and prevention of infection, a bundle of interventions, we won't be able to save the small babies. With this, I thank the Kerala NNF and IAP for giving me this opportunity. Thank you. And I can take up the questions now. Thank you, sir.
Thank you, sir, for that excellent presentation. I think we'll take the questions in the end. Okay. We'll move on to the next section.
Okay.
Santosh, sir.
Good afternoon, everybody. Almost all are hungry. And next speaker is Dr. Mohit Sani. I am proudly introducing him. He is Director of Academics, Institute of Child Health, Nirmal Hospital, Surat. And he is Editor-in-Chief, Journal of Neonatology, India. He is presently President of NNF Gujarat State Branch and governing body member of NNF. He was in Western Zone 2017 and 18. He is member of Neonatal COVID Task Force of Government of India. He has got a fellowship in neonatology at Royal Hospital for Women, Sydney, and Matches Hospital, Brisbane. Diploma in follow-up of high-risk neonate by Bailey 3 at Macquarie University, Sydney, Australia. And neonatal cardiology and neonatal echocardiography at Australia again. And he has got fellowship in neonatology, neonatal transport, and neonatal cardiology and echo at Hospital for Sick Children in Toronto, Canada. And he has got another diploma in research project management from University of Toronto. Diploma in research project management from University of Toronto. He has got multiple publications in peer-reviewed journals. And now he is the chief editor and author chapters in various books. Over to you, sir.
Thank you very much, sir. Good afternoon, everyone. I would like to thank the organizers, Dr. Manoj and sir, for making me a part of this. So in the next 10-15 minutes, it is just to create an awareness that ultrasounds in NICU can be very useful, not only in terms of heart or in terms of brain, but in many other places in the body where we can get information and manage the babies accordingly. So it may be a kind of boon for us in an NICU, from whether you think it is from above or for you by yourself. So it is nothing but something like, if you have graphics in the ventilator, it optimizes your ventilation. So if you have ultrasound or point of care ultrasound or echo and head ultrasounds, they will just optimize your hemodynamic management of the newborns in NICU. So if we think that what are the hemodynamic issues that can be there in preterm babies, there will be multiple, like, first thing which happens is fetal to neonatal transition. So if there is a hampering in transition, it can lead to many issues like PPHN or hypoxia and all that stuff. So RDS is the most common thing which the preterms they have. And the most common thing which is secondary to RDS is high pulmonary pressures. Duct, again, is a big issue in the preterm babies. For all those things, what we need is, we need an ultrasound or functional echo to just ultrasound to see what is happening with their heart. So babies in shock, if they present, like, if you don't take care of this sepsis bundle, what Dr. Dinesh sir has just discussed, the babies, if they land up in shock, they may have all these issues. Again, we need to assess their heart. If they develop CLDs, like, after a few days, if the babies are developing CLDs, again, they will have secondary PPHN. Again, we need to assess their heart. And to start with, even in the preterm babies, you just cannot be sure that they won't have a congenital heart diseases. It can be there with them. Then comes the head ultrasound. You have to assess the head because of the IVH is one of the most common thing with which they present. Then again, with the line placement and its complications, we need to check the tip of the USC, UVC or the PIC line we have put in. And if the baby is developing any complication because of that, we can quickly assess that with ultrasound. So what if I tell that I tend to do a functional echo. Okay, somebody needs to mute. Okay, so what is functional echo? Functional echo is nothing but a focused ultrasound for the evaluation of cardiovascular system. What we say is it's another tool. It is not the replacement of your clinical judgment or your clinical acumen or your clinical decisions. It is just another tool that supports your clinical judgment. Okay, and hence, once you have taken a decision after clinical assessment and by assessing with the ultrasound, You start with some drug, like if you started with paracetamol or indomethacin in PDA baby, and then you can revisit and assess whether that drug has acted, that baby is benefited with that drug or not. So when you combine both, what happens is your clinical outcomes, your outcomes for the baby particularly, it improves. So that is an adjunct to your clinical knowledge. So if you have a clinical problem, look for it, whether it is a functional issue. If not, if it is a anatomical issues, then always be sure you should not bypass the cardiologist, because they are the trained and certified person to diagnose the anatomical issues of the heart. This is pertaining to heart. Same is the case with the head ultrasound. If you find anything anatomically abnormal, always involve radiologists, because they are the trained and certified people to diagnose that. We are not. But if it is not an anatomical issue, it is a hemodynamic issue, then you can make a decision and then revisit and see whether that thing has improved or not. So this is just an observational study results. In that, what they found was, if they have taken a clinical decision and they made a plan in terms of PDA, and once they did a functional echo on that, they had to change their plans and decision in 40% of the babies. Similarly, in babies with shock, you can see here, they had to change their management decisions in 93% of the babies in shock. So that means it is very useful tool, specifically if the babies are presenting with shock, because there can be many things which you can assess and then physiologically change your treatment instead of your just clinical assessment. So let's talk about one scenario. This is a 26 weeks preterm baby born by a normal vaginal delivery, cried immediately after birth, known antenatal issues. Appropriate antenatal steroid coverage is being given. Baby developed RDS at birth, was started on delivery room CPAP and was shifted to NICU. So very typical RDS preterm baby. In NICU, this baby is on FiO2 of 40% with CPAP of 6 centimeters with okay, like stable vitals. Nothing much, nothing issue, no issues with the vitals. This baby started having desaturations and developed mottling and became off color. So what are the reasons of deterioration? The first and foremost thing, whenever we assess these babies, is we have to stick to our basics. We have to rule out if the baby is on positive pressure ventilation, either CPAP or ventilation, we have to rule out dope. We have to see whether this disease HMD, RDS is worsening, whether the baby is getting into shock because some issues or there is some bleeding going on intracranially. So in this baby, everything was being ruled out, but still your perfusion is poor. So there is no pneumothorax, no issues with this. So then we will think, okay, this baby is becoming off colored and mottled. Should we give a bolus to this baby? And there can be a discussion on that, whether we should give or not. But it was being given 10 ml per kg. If you don't want to give because of issues of IVH, that is one thing. But generally, if the babies you will receive babies or you assess the babies and the babies are in shock, you give one bolus, and particularly in preterm babies less than 1.2 kg, you should be very cautious. You should not give straight boluses, fast boluses, until unless there is a significant bleeding or is hypovolemia. Otherwise, you give it slowly over 10 to 15 minutes. So one bolus was being given, but baby did not improve. So what will be our next step? Especially in cases of shock, we will think about inotropes. So then again, the question comes, which inotrope? So whether dopamine, dobutamine, adrenaline, or milrinone in this kind of babies. So this is what is generally followed, like, a kind of protocol approach. If baby is in shock, give bolus, give second bolus, still BP is low, start dopamine, then dobutamine, increase the doses from 5 till 15 or 20, and then add another drug. And then in the end, you start thinking about epinephrine, vasopressin, or starting steroids. But now, this protocol approach is something which everybody starts, but this is not something we should be following, because it is kind of loop without any result. You keep on moving in the loop without any results. So that's why this functional echo or echo assessment, this is what we do in our unit is whenever a baby requiring even one inotrope with higher doses, more than 15 mics, or on 2 inotropes, then we should assess the heart of this baby or assess what is the cause or whether what we are giving is actually functioning there or not. So that's why we tend to do an echo if the baby is on 2 inotropes or on 1 inotrope with highish kind of doses. So this was the vitals of those, that babies. As you can see, the CFT has prolonged, the pulses, they were average, and the saturations is bit on the borderline on the lower side, but BP has been maintained. So hence the functional echo was done. So this is the contraction, like this is a apical 4-chamber view, contraction is good. And this was the echo report. Structure was normal, no PDA, LA, LV was dilated. There was significant MR, LV dysfunction was there. Cardiac output, this one is 100 ml per kg per minute. Functioning was good. These are the normal values. So as you can see, the cardiac output was low, functioning was good. So all those things, they tell me that there is a increase after load. My pump is contracting properly. My volume is good. What was an issue? After load was high. So whenever we have to manage these babies, as the definition of our functional echoes or POCUS point of care ultrasound goes, that it is an adjunct to your clinical assessments. It is not the replacement. So always, collaborate your echo, like put it in the investigations. These are the few investigations in which you assess how well your heart is contracting and what is your tissue perfusion. Monitor the babies, basically these 3 things. And then clinically you have to assess, CFT, pulses, urine output. Let's call this CPU. So let's see this baby. This is a preterm baby with your CPUs, like your perfusion and everything is bad. Your blood pressure is normal or higher side. Lactates are increasing, means your tissue perfusion is not good. Your cardiac output is not good. So what is happening is your cardiac contractility was okay, but your SVR was high. So that is basically nothing but a transition hemodynamics in preterm. When these preterms are born, when the cord is being clamped, their LV is suddenly exposed to high systemic vascular resistance and their myocardium is weak. So it has to adapt. It takes time. That's why your perfusion goes bad in this baby. So in this kind of baby, the ideal drug would have been dobutamine instead of dopamine, because already your afterload SVR is high. You have to decrease that. You need vasodilators and not vasoactive agents. So if you start dopamine in this baby without assessing anything, it will be harmful. So drug of choice will be something which is vasodilator, and simplest drug we use for that has been dobutamine. Let's talk about this baby. Another 29 weeker, 1 kg, given 1 dose of surfactant, admitted in an ICU, started having oxygen requirements, increased oxygen requirements, and hypotensive at 12 hours of life. The only positive history that goes in favor of sepsis was that mother had a leaking of 20 hours and she is already on antibiotics. As you can see in this table, after the admission, this baby is constantly hypotensive. If we assess it clinically by mean blood pressures, baby is becoming tachycardic, the pH is becoming acidotic, base excess is increasing, lactates are increasing. This baby was initially on ventilation, and then this baby was on CPAP, was extubated. So respiratory wise, he was improving. This baby was improving. Initial, after detecting hypotension, 1 bolus line was given. Then as a protocol, that loop, this dopamine was started, which was increased till 10. And then another time after that, another drug, dobutamine, was added without doing anything. But still the baby was hypotensive, acidotic, and lactates are going up. That means whatever treatment, what I am doing to this baby is not helping this baby. So when functional echo was done, so this was the finding. So this is basically nothing but PDA. This red color jet, what you are seeing is PDA. So this baby was having an issue, having an issue with PDA. So it was all this tissue hyperperfusion and low blood pressures were because of PDA and not because of anything else. You need to treat the duct. Whatever inotropes you will give, it will harm the baby. And as you can see in this table also, you could see the wide pulse pressure that was also indicating towards hemodynamic significant PDA. So if we see that this chart of functional echoes, like if you assess, you have to assess the baby and see whether this baby is hypotensive or not. If your baby is hypotensive, first step is you have to rule out the basic thing, mechanical issues, high intrathoracic pressures or pneumothorax. If they are not there, then by functional echo, you assess whether it is low output or high output. If it is normal or high output, it may be, especially in preterm babies, may be the PDA. If there is no PDA or if it is low cardiac output, then you have to look for whether it is because of hypovolemia or low contractility. As in first baby we discussed, there was no hypovolemia, the contractility was not low. The only issue was high SVR. Okay, then you assess assess the issue and then you treat it as per what is an issue. Don't just blindly keep on adding the drugs. But if you do, there is no hypertension, you did a functional echo, normal cardiac output, do not treat that baby. It's just on the basis of 1 or 2 readings of blood pressure or any of your clinical vitals. So whenever we use inotropic therapy, first we have to ask, what is the diagnosis? What are the hemodynamic issues? And what you want to achieve? Your first choice should not be what inotrope I should give. It should be what I want to achieve. And then the question is how we are going to achieve it. So that also depends what is your problem and the inotrope you are going to choose, what is its action. Okay, so always avoid to use a kind of inotropic soup. Start with dopamine, increase, add dobutamine, increase, add adrenaline, increase, add noradrenaline. It is not something like that. So just discuss this baby, one baby, 19 days old male baby, born at 28 weeks gestation, 1 kg, large hemodynamic significant PDA, was having neck, so was NBM, was already on drugs with sepsis. The lungs were pretty bad. The baby is on ventilator, hemodynamically stable. So was baby was not getting well, so was shifted for surgical intervention. The surgical intervention was done. But after a few hours, this baby started becoming hypotensive. Tachycardic, FID requirement increase, again acidotic and lactates increase. And as you can see in this graph, initially baby became hypotensive, started on dobutamine, increased till 20. Still the baby's blood pressures kept on falling. This small heart means echo was done here and suddenly the blood pressures increased. So that means something happened, something they found in this echo which improved his blood pressures. And what was that? After surgical intervention, this baby was having pleural effusion. So that was hampering his cardiac output. So when this was being drained, this was pericardial effusion, and then this was being drained, and then the baby became better. The other thing we always tend to assess is, most commonly attend to assess is IVH or hydrocephalus through head ultrasounds. Okay, so this 26 weeker 600 gram born outside came to you at 2 hours of life, having respiratory distress, is pale with poor perfusion. You intubated and did an X-ray. So what you can see in ultrasound chest and X-ray, there is severe HMD, and the cardiac functions are not pretty good. Okay, so now you have to decide whether you want to give this surfactant to this baby or not. So before giving surfactant, is always good to put a probe on the head. When this head ultrasound was been done, there was grade 4 IVH in this baby. So that means if you have a grade 4 IVH in 600 grammers who is not being resuscitated in ideal conditions, so is it good to continue with the life care of this baby, or you want to end this life care, or you have to has to be done after discussing extensively with the parents, but your outcomes are not favorable. So it is always good to prognosticate these babies, and head ultrasound is basically for prognostication, especially in the preterm babies. So except for cranial ultrasound and cardiac ultrasound, there are many other areas where you can use your ultrasounds. Central line insertion, if it is a difficult vascular access, it is very useful way and very effective way of putting in the central lines. Tapping the pericardial and pleural effusions, doing as your bladder taps, and then to see for the central line tip placements for UAC, UVC, and ET tip placements. It is very important. Like as you can see in this video, this ultrasound probe has been kept, and here this ET is being visualized. The ideal position of the ET, okay, like here. So we can keep on, instead of doing an X-ray, we can just keep a bedside echo ultrasound. We can check where is the ET tip. Next is, if you have put the UAC, UVC, okay, by this subcostal view, this baby is on high frequency. That's why you are seeing this jiggling movement here. This is where your UAC tip is. So you can very well locate where is your UAC, UVC tip. So my friends, if I talk about use of ultrasound in newborns, it is not just the cardiac ultrasound where we assess the babies who are sick or we have to make the decisions. It is not just the cranial ultrasound where we assess the IVH or we do Dopplers or then we take decisions in hydrocephalus and all other pathologies. Lung ultrasounds are something which is coming up very, is very obvious and being used everywhere, especially in diagnosing pneumothorax, pleural effusions, and then treating that immediately. Even the abdominal ultrasounds, you can assess the NEC neck with this very effectively. And if the significant ascites is there, it helps us to tap that. And then the line positions, as we have already discussed, ET tip position, ultrasounds for the hip, ultrasounds for the spine. These are the things we can extensively use in our NICU for these newborn babies. So if you want instant results like this, it is not possible. You have to keep patience, even if you have ultrasound in your NICUs. Thank you very much.
Pranil Vincent. Yes. Moving to the last topic of the day.
Dr. Anil,
yes.
just a small interruption actually. Dr. Dinesh Shirla is held up somewhere. So he was asking if he can go. So if there is any question for him, he will answer and go.
Yeah, there was one question in the chat box, which is already been answered by him.
All right.
Any other questions, audience? No more questions. You may leave, sir. Thank you very much for your presence.
Thank you so much. Thank you so much for joining.
X-ray being a basic investigation to the majority of our specialties, including neonatology. A simple, cheap, and easily available diagnostic tool, which is being used and misused by many of us. And taking a film or X-ray can give a definite diagnosis to many conditions like diaphragmatic hernia, intestinal obstruction, etc. To enlighten more on this topic, that is X-ray, we are lucky to have speaker Dr. Binish Balachandra. He is a graduate from Government Medical College, Calicut. He is MD, DNB from PGA Chandigarh, a winner of NNF Gold and National Gold Medal 2014. He is interested in research methodology and have a few original articles in national and international journals. He is currently working as consultant neonatologist and HOD pediatrics, Aster MIMS Kottakkal. I welcome Dr. Binish Balachandran for the talk.
Thank you, sir. And first of all, let me thank the organizer for giving the platform to speak in front of an esteemed audience. And I think we are already 1 hour late, so let's straight away go to the topic. And whenever my time is up, you can just remind me, then I will stop there. May have a few extra slides. So what we are trying to do is to learn about schematically read and describe a neonatal chest X-ray and identify the typical radiological features of some common conditions, understanding the variations and overlap between the radiological features of various conditions, and then identifying the complications of the disease and also the mechanical ventilations. So first of all, let me just highlight the point when we are not supposed to do an X-ray in routine NICU care, that we are not supposed to do a routine X-ray, pre and post extubation X-ray, and after each re-intubation to confine 2%, no need for an X-ray. For every desaturation or increased appetite requirement for a ventilated baby, again, no need for X-ray. To document lung clearance after your treatment or surfactant, again, no need for X-ray. And routine X-rays are almost always obsolete in ventilated babies. So X-rays are good, but provided we should use it judiciously, and no need to overdo it, because every X-ray, though in a minor amount, gives you radiation, and the long-term effects are always a concern in neonates. Again, the basic precaution we all know, you have to stick to the hand hygiene protocols, you have to do not disrupt the care of the baby, and etc. So I will just skip it. The basics always start with the identification of the patient, and always just cross-check the side marker against the anatomical points like apex and stomach bubble and the liver, because many of the time the marker has been put retrospectively, and even in dextrocardia, they will just put the marker on the opposite side and give it to you. That happens much commonly. And there are a few inherent differences for a neonatal X-ray as compared to the older child or adult. We almost always take AP views in neonates. A normal lung is supposed to have around 6 anterior ribs and 8 posterior ribs visibly above the diaphragm. That's what we call as a normal expansion. Ribs are more horizontal, and the normal cardiothoracic ratio is up to 0.6. And the air bronchogum is a pretty normal finding in the especially in the retrocardiac area or the middle 1/3 of the chest. And the thymus is a very prominent feature, especially in the early days of life. The field is again important. If you are taking chest X-ray, don't do a babygram like this. You don't need to the head or the pelvis or the limbs in the field. Just not only to minimize the radiation, but also you may miss the point of interest because of the babygrams. But such films are needed if you are doing that for a line position like a PIC line inserted from the lower limb. So unless otherwise specifically indicated, always just focus on the area of interest. The thymus, as I already said, is a muscular especially in the initial days of life. You can see that it can almost imperceptibly blend with the cardiac shadow, but mostly on the left side, almost on occasion, you can see that the border is not uniform. It is the wavy pattern to it that is called the wavy thymus sign, and this triangular thing is something like the sail of the ship is called the sail sign of thymus. Again, the thymus can at some time, especially in rotated film, can appear something like a consolidation or something like a cardiac disease, the snowman figure of eight appearance. Mind you, the snowman appearance doesn't usually occur in newborn. So most of the time it is the thymus that giving you the shadow. And in rotated film, even the thymus can present you as a space of crenulation, something like a space of crenulation in the upper chest. Again, most of the time, especially in the preterm babies or in the babies who are ventilated, the thymus can involute rapidly, and within by 24 to 48 hours, the thymus can many of the time regress almost completely. So that's the one thing, and other thing is the rotation. Again, a centralized film is key for all your measurements, all your comments about the lung expansion, the cardiothoracic ratios, the lines, position, etc., etc. You can obviously see the same patient, but you can see that how drastically the films, the X-ray appears when the patient is centralized as compared to rotation. How to check for rotation? Just mark the middle line of the vertebra and just measure from that to either the inner aspect or lower border to both the ribs. And also just compare with about the middle end of the clavicle, how it is, whether it is equidistant or not. And again, also compare the orientation of the clavicle. It should be symmetrical almost. Here you can see that it's grossly rotated. Whenever the X-ray is rotated, you can see that the posterior part of the lip head, and that's the only good thing about a rotated X-ray. If you want you can get much more information about the ribs, especially the posterior part, from a rotated X-ray. Otherwise, in most of the conditions, the rotated X-ray is practically meaningless. The other thing is the lordosis. Again, if the baby lies in a lordotic position, again it gives some, especially a lifted up apex like appearance and apparent cardiomegaly. You can just check the anterior portion of the ribs. Generally, the anterior portion of ribs are supposed to be in the downward direction, but you can see that is superiorly aligned as compared to the posterior part of the rib, which is a feature of lordosis. So that's the importance of a proper position of the patient. The next is exposure. Again, in the digital X-ray era, it is very easy to adjust the exposure and give you get the better feelings. But always a good exposure always required to comment about the soft tissue shadows, especially the lung parenchymal shadows. A slightly overexposed film may be better for the bone, to comment about the bones, but for other practical purposes, you need a proper exposed film on which the first T1, T2, T3, these vertebral spinal processes must be visible, and rest should not be clearly visible in a generally normal exposed X-ray. The other thing is the expiratory and inspiratory film. In a newborn X-ray, you don't have really control over the inspiration or expiratory phase in which the X-ray has been taken. But mind you, an expiratory film can, like this in the second image, the expiratory film can give you an impression that the lung disease is worsening, and there is it can also give an appearance of apparent cardiomegaly. But mind you, these are same patient, almost same time, just an inspiration, expiration that make a difference. Again, the rib count is important. The counting the expansion is important, especially for the most of the pathologies. You can either count the anterior ribs, these are the anterior ribs, or the posterior ribs, and just count how many ribs are above the diaphragm. If you count the posterior ribs, it should be at least 8, and if you count the anterior rib, it should be at least 6, which are completely above the diaphragm. That you mean by a normal expansion. And always it's better to go in a schematic reading, a schematic fashion in reading the X-ray, just not to miss any findings. Many codes have been recommended. One is ABCDEF approach: A for airway, hilum, mediastinum, lungs; B for bones; C for the cardiac shadow; D for the diaphragm; E for the extra lines and tubes and ED tubes; and F for the funding level. So you have your own codes or your own order, but mind you, just go either from center to periphery or periphery to center and follow the same universally. And always take the history and clinical setting into the accord. In newborn, many findings like a pneumonia or a RDS, the diagnosis just depend on the history and clinical setting, because many of the conditions, the X-ray findings are almost always overlapping. And again, I mentioned about normal expansion, but just counting the ribs and telling it is hyperinflated or not may not be always possible, because newborn chest is very compliant, so it can expand anteroposteriorly also to a significant amount. So the rib counting alone may not be considered as a good evidence for hyper or hypoinflation. So just for hyperinflation, always look for the diaphragm, whether there are flat like this, and also look for the increased lucency of the lungs and the air which is seen under the heart shadow, and the ribs which are more horizontal, especially the anterior ribs. So these are all the features of hyperinflation which always we should try to limit in a ventilated baby, just to prevent barotrauma and volutrauma. The normal positions of the tubes and lines are important to know. The ET tube is supposed to be around 1 to 2 centimeters above the carina. The umbilical arterial line should be ideally most of the commonly placed in the high position, which is between T6 to T9. The low position is L3 to L4. The UVC is supposed to be around 0.5 to 1 centimeter above the diaphragm in the IVC, and the PIC line, whether you are inserting it from the lower limb or upper limb, it should be either in the IVC or SVC, just entering at the point, just entering the right atrium. So the vertebra you can count from by the help of ribs. Either you identify the first rib or the last rib. Better always go for the first rib, because in newborn the T1, T12, 12th rib may not be clearly visible, and just count from that. The T6 to T9 is the position where the umbilical artery line should be placed. And the lines, always the umbilical artery line go first downwards and then ascends, and always through the left side of the vertebral column. That's a normal position, and the UVC generally goes straight, though a normal anatomical course is not straight, but in X-ray it looks like something is straight. And the ET tube, just to identify carina, always go look for the left main bronchus, which is almost always visible, and just from the left main bronchus go horizontally to the trachea, and from that point, at least around 0.1 to 2 centimeter above should be the normal ET tube. Here you can see that it is almost 2 inside, and that's a common. And coming to the common lung conditions per se, and this is one of the X-ray that I had to present here. So you can see the always just concentrate on the lungs, and you can see that the expansion, you can see the diaphragm margin is here, the expansion is low, the lungs are hypoinflated, and you can see that it's a bilaterally symmetrical disease, and the lungs are hypoinflated, and you can see that a reticular shadow, a reticular type shadow is there, and also with the prominent air bronchogram, the arrow shows the prominent air bronchogram. Also, you can see that some amount of granularity is also there. So again, the right film, the second film indicates a much severe grade of the condition. Again, you can even see the cardiac, or you can even differentiate the cardiac and diaphragmatic shadows, which are almost uniformly white out and with the very prominent air bronchogram. This is typical of respiratory distress syndrome. So the changes are first a hypoinflated line, the low volume lungs, reticular appearance, granular, diffuse granular shadows, sometimes we call it as ground glass appearance, and a prominent air bronchogram, and a bilaterally symmetrical disease happens in a setting of preterms or setting for RDS. That's your typical RDS baby to die. Again, you can see that a ground glass opacity with a low lung volume and prominent granularity in the lung fields, and after surfactant you can see that the pretty much clearing is there. But mind you, same appearance can happen in various lot of other conditions like infection. For example, here you can see that it's again a nearly uniform, almost a whiteout X-ray with the low lung volumes, and almost there is a granular pattern. It is a ground glass opacity pattern appearance to it also. But if you can see carefully, you can see that there is almost a mild amount of pleural effusion is the line of pleural effusion. So mind you, whenever you see a X-ray which is suspected of RDS, always actively look for the evidence of pleural effusion, because normally you don't expect a pleural effusion in RDS. When you see a baby with suspected RDS, but in X-ray you find a pleural effusion, more likely that there is associated infection or it's the other condition associated with it. So in fact, this baby is a case of GBS sepsis with severe pneumonia. So again, one of the baby, I will just give a clinical setting. The baby was in RDS, given surfactant, and had a sudden deterioration. And when you clinically, you can see that blood secretions coming from ET, and chest X-ray has been done. So with this clinical setting, very easy to diagnose the pulmonary hemorrhage. You can see that it's a nearly homogeneous opacity with a few prominent air bronchogram that maybe is congenital. And the second right film, you can see that almost both the lung fields are homogeneously wiped out. But again, this is with the setting only you can make a confident diagnosis of pulmonary hemorrhage. Otherwise, the appearance is much variable. But always a sudden worsening and sudden appearance of homogeneous opacity in the setting of pulmonary hemorrhage always is characteristic. Another condition, again, you can see that the expansion is nearly normal if you count the ribs, and you can see that there is some mild apparent cardiomegaly, but as compared to RDS X-ray, you can see that there is not much granularity here. The opacities are something streaky shadows originating from the hilum towards the periphery. You can see that there's more of a streaky shadows, and there is probably a prominent fissure, interlobar fissure with the fluid here. This is typical of TTNB, the normal to maybe slightly hyperinflated lung field with streaky shadows and apparent some mild apparent cardiomegaly. And you may sometimes see a mild amount of pleural effusion also. So that's typical of TTNB. Again, you can see that a more prominent interlobar fissure, again with the streaky shadows originating from the hilum with mild apparent cardiomegaly. This another baby, you can see that a small line of pleural effusion in here. Again, more of a streaky appearance of interstitial shadows. Same baby after 48 hours, you can see that lung is pretty cleared out without any intervention. So that's TTNB for you. Another condition, again, you can see that the lungs are affected bilaterally, but not in a non-homogeneous pattern. You can see that there are some areas which are more white, some areas which are more black. So the white areas are atlectic area and the black areas are emphysemator or overinflated area. So you have a baby with a disease which affects both lungs with the patchy areas of atelectasis and patchy areas of hyperinflation. That is typical of what you call MAS, meconium aspiration syndrome. Another baby with overall hyperinflation, the overall lung will be hyperinflated with the patchy areas of atelectasis and patchy areas of hyperinflation. But mind you, such a typical X-ray picture is not very common with MAS. Most of the time, MAS present with much milder X-ray pictures, leading to much confusions. Another condition, you can see that the X-rays at a look, even you can see that the X-rays are the lung fields are hyperinflated, and on its first sight only, you can see that compared to the left cosophrenic angle, this sulcus is much deeper. So that is called, in fact, a deep sulcal sign, typical of pneumothorax in the supine babies. And in the second X-ray, you can see that a much larger pneumothorax is there. Again, the deep sulcal sign is there, and you can see, in fact, clearly see the collapsed lung border here. And the underlying lung looks granular, probably secondary to the supine deficiency here. So if you are looking for air leaks, actively look for the milder types of air leaks in the apex of the lungs, in the medial side of the pleura, around the cardiac border, the anterior diaphragmatic and the posterior diaphragmatic area, and the deep sulcal sign. These are the minimal areas of these are the areas where the air first tend to collect. For obviously, if you have a large air collection, you cannot miss a pneumothorax. But these are the things, mild air collection, that we tend to miss. Here again, you can see that probably there is some hyperlucency here. There is probably air collection which is between the heart and the lung, and you can see that. In fact, you can see a small border of the collapsed lung also. This is typically called as medial pneumothorax. Sometimes not very uncommon in newborn, especially in AP view. The same thing again you can see in the right side also, but as compared to that, this is not confined to here. It's this lucency extend over the blood, probably the blood vessels, and also to the upside. And even you can see that probably a subcutaneous emphysema in the right side, in the right upper neck. So this is probably a pneumomediastinum, and this is a medial pneumothorax. Both conditions are somewhat may cause some confusion, but if you see the air extend towards the great vessels and to the to the neck, and also you can see that the teeth marked in the thymus. If it lifts the thymus, that's obviously that's a pneumomediastinum. If nothing of these kinds are visible, then probably it's a medial pneumothorax. Especially that is confirmed if you see the collapsed lung border. But always beware of the skin fold sign. That is this. Though this thing can be easily mistaken for a collapsed lung border, but if you trace it carefully, you can see that it goes beyond the diaphragmatic border, and in fact, even later to that, you can see the lung marking. So this is just a muscular drop pneumothorax, that is skin fold, but this is for obvious reason is a gross pneumothorax. Another condition, another case of medial pneumothorax, you can see that air, and you cannot see any pneumomediastinal features here. The lateral view of the same baby. Again, another case of pneumothorax, you can see that gross subcutaneous emphysema on the right side, a deep sulcal sign is there, a collapsed lung border is there, the clear-cut right pneumothorax. But mind you, you can see that in this part also, there are the lung look hyperlucent, but you can see the lung marking underneath it. In fact, in pneumothorax, you are not supposed to see the lung marking, but here you can see in the most of the area, you can see the lung marking, that because of the epithelium and the baby is in supine portions. This is called typically as anterior pneumothorax, because the air collects anterior to the collapsed lung. That's how you somehow see a lung marking behind the pneumothorax in majority there. That's called anterior pneumothorax, which is again common in newborn. Here you can see that thin rim of air is there, but you can typically see that air percolate into the thymus and lifting the thymus in both sides. This is typically called as the angel wing sign. And again, the lateral view, you can see the thymus has been lifted up. So that's a typical sign of pneumomediastinum. Another case with the same angel wing sign, you can see that both the thymus are uplifted, but here you can also see that around the heart there is a rim of air uniformly present encircling the heart, which is typical of pneumopericardium, and the sign is called the tramline sign or the halo sign, because you can say that you can almost like a halo around the heart, which is called typical of tramline sign or halo sign, which is typical of pneumomediastinum. So in this picture, you have pneumomediastinum and pneumopericardium and pneumomediastinum both. This is a very rare condition called disseminated intravascular air embolism. So where a condition where the air ruptures straight into the artery or vessel, and you can see that even inside the heart, you can see that there's plenty of air, and not only that, into the carotids and the the sagittal sinus, the ventricles of the brain, there is air there, and also you can see that in the heart shadow, in the liver shadow, you can see the prominent air within the portal circulation. So this condition is almost always fatal. Just for the convenience sake, I just included this called disseminated intravascular air embolism. Again, this is another condition where you can see that the lungs are hyperlucent, especially on the left upper lobe. But you can see, you may confuse this with a pneumothorax, but if you see carefully, you can see the bronchovascular marking inside the hyperlucent shadow. So this is typically of CLE, that is a congenital lobar emphysema, which sometimes often may give some confusion regarding the pneumothorax. So two things that get confused with pneumothorax, one is a skin fold and one is probably a congenital lobar emphysema. Thankfully, both are not so common to confuse so much.
Sir, you have 2 more minutes.
Okay, so I will just finish with 2 more conditions. The one thing, this is another condition, you can see that the lungs are overexpanded, and you can see small circular cystic shadows. But not only that, you can see that elongated shadows along the interstitial markings, that is typical of PIE. These elongated shadows, in which the air ruptures into interstitium, and these elongated shadows occurs. Sepsis is a very important thing. You can see that an inhomogeneous opacity and often fluffy opacity is typical of the bacterial pneumonia. And even you can see some pneumatoceles. But mind you, the sepsis can present in various things. Here, this X-ray somewhat looks like a RDS picture, but the granularity is somewhat lacking, more of interstitial shadows. And you can see that there is a pleural effusion there. This X-ray picture is typical of GBS sepsis. And here you can, this case of pneumatoceles, you can see the one pneumatocele here, and probably 2 pneumatoceles here also. This happened to occur in E. coli and probably staph sepsis. This is a rare condition, grows to the slightly older children, 2 months with bilateral diffuse involvement with nodular and reticular node, prominent nodular shadows with a, you can see even a cavity there. This is a case of tuberculosis. This is a case of CME pneumonitis. You can see that a prominent reticular shadow along with the interstitial shadows is very prominent. In most of the CME pneumonitis, you can only find this pattern of prominent reticular shadows and interstitial shadows. In most of the, when differentiating between viral and bacterial pneumonia, generally the viral pneumonia doesn't produce lobar pneumonias, but mind you, the RSV, respiratory syncytial virus, is one thing which causes lobar pneumonia, and also this type of differential inflation. There are patchy areas of hyperinflation, patchy areas of lobar pneumonia picture happens with viral pneumonia, especially with the RSV infection. And the other feature of viral pneumonia is a prominent peribronchial and perihilar thickening. This I don't need to explain much. This is a typical of collapse. The right upper lobe collapse, the right middle lower lobe collapse, the left lower lobe collapse, and left upper lobe collapse. You can see the collapse straight margin of the lung. So I guess I will stop with this. This another X-ray. You can see that the lungs are somewhat hyperinflated. You can see some cystic areas on both lungs, and also some fibrotic bands is typical of bronchopulmonary dysplasia. Mind you, in the older bronchopulmonary dysplasia, generally it progresses from stage 1 to stage 2. The stage 1 somewhat look like an RDS picture. Then it progresses to stage 3, where more of cystic areas happens, and stage 4, where the lungs are filled with the cystic areas and also prominent fibrotic bands. But in the new BPD, such classic changes may not happen in a sequential manner. You may have more of interstitial patterns, but again, you can find more of fibrotic pattern even in new BPD. The last X-ray probably, you can see that the thoracic cavity is occupied by the bowel loops, and you cannot see a diaphragm. So typical of diaphragm, congenital diaphragmatic hernia, the other DD is this, that is event directional diaphragm. Here also you can see that there are interstitial loops in the lung, but you can clearly see a diaphragm over it. So that's the thing. Just had to differentiate between CDH, and the CDH can happen the right or left, more commonly left. So I guess I will stop with that. And thank you for the opportunity. Happy to answer any question if there.
Thank you very much, Dr. Binish Balendra, for that excellent presentation. In chat box, there is one question: how to identify left anterior pneumothorax and left-sided CLE?
I didn't get to left side C.
Left-sided CLE.
Yeah, the problem is that generally the anterior pneumothorax is not somewhat that confined to one lobe. Generally, the CLEs are confined to one lobe. So if you see a clear-cut margin, then very easy to differentiate. The anterior pneumothorax generally a diffuse thing and happens all over the lung. So that is the only thing that I can offer.
There are no more questions.
Just regarding, there was a direct question to this after the this ultrasound workshop, ultrasound lecture. Somebody asked me that how they can decide the inotropes and the findings of functional echoes. So basically, it is basically a very extensive thing. But the only thing you need to judge is preload, contractility of the heart, and afterload, your cardiac outputs. And then according to that assessment, you need to decide your inotropes. This is the most basic thing we do when we do our functional echoes, when we decide our inotropes. This is the only question which I got, and I just wanted to discuss that. Thank you.
Okay, thank you very much, all the 4 speakers, for your excellent presentation and for your time and for being with us today. And over to the organizing chair.
We are at the end of our scientific program. Actually, we are almost in the right time. We finished with very good academic piece. A lot of discussions are done out of the way. So I think there is we are finishing right time, no problem. 2 o'clock. The usual CME will finish. But we are also expected to finish by 2 p.m. only. Even though we schedule like that, we know that the content is very good. So everybody will be interested to hear the very important and deliberation by the national and international faculties. Very good, no problem. So now we are end of our MidNeocon 2021. So now I invite, we can go to the wait for 10 to 15 minutes. We can do the concluded remarks. I now invite Dr. our NNF President, Dr. Revisar, to say a few words.
Jose, I don't have words to explain the joy I am experiencing now. It was truly an overwhelming experience and an academic piece in every sense. The faculty was truly stunning, and the topics chosen were nothing but the best you can get in such a short period. That is less than 2 days. I think the scientific committee is really great. Hats off to you, Jose and team. Jose, Shanavas sir, Anandan, Nelby, everybody there. You have put in all your might to see that the MidNeocon has come out so successful, and it will be remembered in the annals of NNF, I'm sure. I wish the participants all the best. I'm sure you all would have become wiser, and you will be able to impart better neonatal care to the babies under our care, whereby diminishing our infant mortality rate even further. All the best once again, and congratulations, and my deep sense of appreciation for your hard work, which has paid off in every sense. Thank you very much.
I request our organization chairman, Dr. Shanavas, to say a few words.
So respected Devi sir and other dignitaries of NNF and fellow pediatricians. So here comes the end of the good session. So every good thing should have an end. So 1.5 days and 12 hours of intense academic feast from basic perinatology and preventive pediatrics to very advanced pediatric neonatology. So I have noticed 3 things that I gained from Dr. Manoj sir. Number 1, we can conduct a neonatology workshop very easily through a new e-platform. Second one, we have heard of so much debates. 2 persons are arguing on same subject, but here simply Manoj sir has extracted the very various aspects of hypothermia treatment as a part of neonatal encephalopathy due to birth asphyxia. Third thing is the 5 papers in the last decade that changed the neonatal. All these are very novel ideas. I think all conferences should have all those things, and I hope all the topics are enjoyable for all the participants. I express my sincere thanks to Dr. Ravi sir, Dr. Manoj sir, Dr. Nelby, and Dr. other neonatology team, and my fellow district president, Dr. Jose, who is the main culprit who is always doing everything, every activity, each and on A to Z. He is look after by in the best way he is doing, and also our Dr. Jayaraman sir and other and IAP dignitaries also I express my sincere thanks, and Dr. Anandan. I said yesterday also he's silent man behind the topic. He's always doing things, arranging various. We have made so many brochures. All the brochures were made by him by personal effort. Thank you, Dr. Anandan sir. And
I expect all the topics will be very useful for your further travel in the neonatology life. Thank you all.
Dr. Manoj, sir, please. Manoj.
Respected seniors and my dear friends, it is really a proud moment to be part of the NNF Kerala family. And this was a great learning experience for all of us. As Shanawaz sir said, we could conduct a online workshop with various breakout rooms without any hitches, and then so it was all like novel things for us together, even though we might have done it individually, but as a group we had done. And I would really love to associate myself with this event for all the reasons. And the whole program under the leadership of Dr. Jose, and then ably and very silently backed by the man who doesn't speak at all, Dr. Anandan. And then of course the leadership of all the people, Dr. Shanawaz sir, the NNF Kerala team, Dr. Ravi sir, Nelby, and then Vishnu, everybody, it was a wonderful event. Now, before anyway, thank you so much for including me in this event. I would request all of you to enable your cameras. We can have a selfie together. If at least 1/3 of the people are still around. So for validatory function, 1/3 of people being around is a great thing. So if possible, let us all have our the selfies together. So please enable your cameras unless you are very video shy. Enable your cameras and then we can have. There are 2 frames. Hold on, I can take the.
Arya.
Please switch on your videos if possible.
Vijay Umar, Aishwarya, Divagar sir, KK Divagar sir.
Divagar sir.
Then Jairam, Vijay Umar sir, Trivandrum, Vijay Umar sir.
Dr. Mohit Sani was here till now, just only he left.
I think he will come. He will come.
Only so many willing people. Anyway, shall we go ahead?
Thanos sir, video. Thanos sir, the video.
കാണുന്നില്ലേ?
കാണുന്നില്ല.
സർ ഒന്ന് വീഡിയോ ഒന്ന് ഓഫ് ചെയ്തിട്ട് ഓൺ ആക്കി നോക്കൂ സാർ.
ശ്രീപ്രസാദ് പോയ ശ്രീപ്രസാദ് റേഞ്ചിന് ഭയങ്കര പ്രശ്നമാണ്. ഇപ്പൊ തീരും തന്നെ ഇങ്ങനെ തിരുപ്പി.
ദിവാകർ സർ വീഡിയോ ഓൺ ചെയ്യാമോ?
ഐശ്വര്യ, വിജയകുമാർ,
ജോസേനെ കണ്ടൂടെ?
ഇപ്പൊ കാണാം. വിജയകുമാർ then Aishwarya, Divar sir, Sadish from, I think he is from Dubai. Dr. Sadish.
Hi.
He's from Dubai, I think so. He is from old alumni of Kota, MCH Kota. He always joining our CME program. I think Sri Prasad net connectivity is low. I think Manoj, you take. Otherwise,
I think
somebody.
Okay. So please hold on. There are 2 frames. So pause and then hold on. First frame going. One more frame is there. Please hold on.
All the technology is from Manoj.
No, this is nothing. This is hardly anything.
We don't know.
Great. Done. I mean, whoever has switched on the video, they'll be there in the video. Others only name will be there. So anyway, thank you so much.
Vijayamar sir, few comments. Vijayamar sir, Trivandrum. Unmute.
ജോസെ ഉത്സവം കഴിഞ്ഞു.
ഞങ്ങളെ ഷാനവാസിനെ അവിടെ കൊണ്ടുപോയി നിങ്ങൾ ഇങ്ങനെ അടിച്ചു മാറ്റി വിടുന്നത് അത് സമ്മതിക്കൂല. ഞങ്ങളുടെ മുത്താണ് ഏതാ. ഏതായാലും വെരി വെൽ ഡൺ, വെൽ ഓർഗനൈസ്, വെൽ സെലക്ടഡ് ടോപ്പിക്സ്. ഐ ഹവ് അറ്റൻഡഡ് ത്രൂ ഔട്ട് ദ കോൺഫറൻസ്. വെരി നൈസ്. കുഡോസ് ടു ആലപ്പി. ഓക്കെ.
അനിൽ
ആലപ്പുഴക്കാര് പുലികളാണ്.
അനിൽ
Yes.
Anandan.
Yeah.
Hi,
Before let's.
എന്താണ് ഇത്? പുതിയ ഫേസ് ലിഫ്റ്റ് ആണല്ലോ.
Anandan, say a few words.
Sir, first of all, I would like to thank everyone, especially Manoj, Nelby, Devi sir, and the whole team, Joe sir, Shanavas sir, the scientific team, Pramida, everybody. You know, the dedicated work has helped us to make this event a great success. So we'll continue this good work in the future also. That's all I want to say. Thank you, everyone. Thank you once again.
Vishnu.
Yes, sir. Good afternoon, everybody. As everyone's echoing everyone's words, it was a wonderful 2 days. Had a great time with a great team. In fact, from the day first virtual meeting we had for the organization of the scientific programs, it was a really good time associating with wonderful team at Alapi. Joe sir, Shanavas sir, Dr. Anandan, and all of you. So thank you very much for the wonderful 2 days of academics. Thank you all.
Nelby.
Sir.
Nelby.
Sir, it was a great experience. It was a great experience. Teamwork, sir. Basically, നമ്മൾ ഗൈഡ് ചെയ്യാൻ ജോസ് സാറ്, രവി സാറ്, ഷാനവാസ് സാറ്, മനോജ് സാറ് എല്ലാവരും ഉണ്ടായിരുന്നു. അതുപോലെ ടീമിൽ വർക്ക് ചെയ്യാൻ ഒരു പ്രഷർ ഇല്ലായിരുന്നു. എന്ത് പറഞ്ഞാലും ഡോക്ടർ ആനന്ദൻ അത് നമുക്ക് ചെയ്യാം, ഞാൻ ചെയ്യാം അത്ര പറയുള്ളൂ. ബട്ട് തിങ്സ് വിൽ ബി ഡൺ. വിഷ്ണു, പിന്നെ ഡോക്ടർ പ്രമിത, ഞാൻ ഡോക്ടർ പ്രമിതനെ ആദ്യമായിട്ടാണ് മീറ്റ് ചെയ്യുന്നത്, വിളിക്കുന്നത്, പരിചയപ്പെടുന്നത്. ബട്ട് ആ ഒരു ഹെസിറ്റൻസി ഒന്നുമില്ലായിരുന്നു. എല്ലാം വളരെ ഭംഗിയായിട്ട് നടന്നു. ഇറ്റ് വാസ് എ ഗ്രേറ്റ് എക്സ്പീരിയൻസ് ഹാവിംഗ് ദിസ് ഒരു വെർച്വൽ കോൺഫറൻസ്. ഓവറോൾ ഇറ്റ് വാസ് വൺ ഓഫ് ദ ബെസ്റ്റ് കോൺഫറൻസസ്. Thank you all. Thank you.
അടുത്ത നിയോകോൺ ആലപ്പുഴയിൽ ജോസ് സാർ.
ജയറാശങ്കർ ആദ്യം മുതലേ വർക്ക്ഷോപ്പ് പോലെ ഭയങ്കര ഡിസ്കഷൻ ആയിരുന്നു. ജയറാം സാർ,
ഞാൻ ഇതുവരെ ഒരു CMEക്ക് ഒരു വർക്ക്ഷോപ്പിന് ഇത്രയും കണ്ടിന്യൂസ് ആയിട്ട് ഇരുന്നിട്ടില്ല. ഒരു സെക്കൻഡ് പോലും നഷ്ടപ്പെടാതെ ഇരുന്നിരുന്നു. വെരി ഗുഡ് വർക്ക്, വെരി ഗുഡ് ജോബ്. കുറെ കാര്യങ്ങൾ പഠിക്കാൻ പറ്റി. ഒരു CMEയിൽ ഒരു സെക്ഷൻ പോലും മിസ് ചെയ്യാതെ കാണാൻ പറ്റിയ എല്ലാ സെക്ഷനിലും എനിക്ക് കുറെ പോയിന്റ്സ് ഗ്യാദർ ചെയ്യാൻ പറ്റി. താങ്ക് യു ആൾ.
ഒരു കാര്യം നമ്മളെ ഇതിനകത്ത് ഇപ്പോൾ ഇന്നലെയും ഇന്നുമായിട്ട് ഡോക്ടർ പ്രമിതയുടെ നേതൃത്വത്തിലുള്ള ടീം കമ്പയർ ചെയ്തത്, there is not making any confusion at all. And done a wonderful job under the leadership of Pramida, Dr. Arya, Dr. Grishmendu, and Dr. Ades from the team have done like in last Pedicon. They have done a wonderful job for comparing the session. That was initially we are planning for any conference. The comparing is also a very difficult task. So they have done a wonderful job, and all the guidance to the Pramida, to the juniors. They have done a wonderful job. Pramida, congratulations and thanks for on the MidNeocon to Pramida and the team for comparing this program without any confusion. So I think Jagumar PR, he is always there. He is for okay.
Sir, Dr. Pramida, 2 words.
Pramida, what thanks. We will conclude the session. We are ending the session. Lunch നമ്മൾ സപ്ലൈ ചെയ്തല്ല, ഇൻ ബിറ്റ്വീൻ സപ്ലൈ ചെയ്തത് കിട്ടിയില്ലായിരുന്ന?
വിർച്വൽ ലഞ്ച്,
വിർച്വൽ ഡിന്നർ ഇന്നലെ ഉണ്ടായിരുന്നു.
വന്നില്ല.
ബെസ്റ്റ് ഓർഗനൈസിംഗ് പവറുള്ള ആള്, നോവൽ ഐഡിയ ഉള്ള ആളുമായിട്ട് മീറ്റ് ചെയ്യുമുണ്ടായ ഒരു ഇതായിരുന്നു ഇപ്പൊ ഉണ്ടായത്. മനോജ് സാറിന്റെ നോവൽ ഐഡിയയും ജോസ് സാറിന്റെ ഓർഗനൈസിംഗ് പവറുമാണ് ഈ CMEയുടെ സക്സസിന്റെ കാരണം എന്ന് ഞാൻ വിശ്വസിക്കുന്നു.
മനോജ് നമ്മുടെ നാഷണൽ പ്രസിഡന്റ് ആവാൻ പോവല്ലേ?
അയ്യോ അങ്ങനെയൊന്നും പറയല്ലേ.
ഇതിനപ്പുറം നമ്മൾ ഇനി കാണാൻ കിടക്കുന്നുള്ളൂ. ഇതൊരു തുടക്കം മാത്രമാണ്. This is only a beginning. We'll have to see much more from him.
Yes, definitely. Pravida, please.
Sir, I'm extremely honored to be a part of this great program, the MidNeocon 2021. And actually, it's to be true, it's one of my first experience to be a part of a great program like this. So first of all, I would like to thank the Almighty for helping us to carry out the program without any problems or any issues in between. And then I would like to thank all the faculties, the delegates, and all the members of the organizing committee. Thank you, sir.
Well done, Pramida and team.
Thank
Hats
you.
off to you.
Thank you, sir.
Okay.
Can conclude.
Okay. We can conclude. Thank you very much, sir. Thank you. Bye.
Thank you, sir. Thank you, sir.
Bye bye. Have a peaceful Sunday evening.
Yeah.
Okay. Joseph.
Yeah.
Thank you, sir.
Thank you.
Bye bye. Bye, Anand.
Bye.
Thank you. Bye-bye.
Vishnu.
Bye, sir.
Bye.
Bye, sir.